Good morning, everyone. Before we proceed with today's event, I would like to take a moment to acknowledge our land. We wish to acknowledge that we are on the traditional homeland of the many diverse First Nations, Métis, and Inuit people whose ancestors walked this land before us, and those persons who share this great land with us today. Good morning, my NSWOC and SWAN family. I'm Joshua Morleo, the Ontario NSWOC Regional Director, and I also currently practice as a clinical specialist for wound and ostomy care at the University Health Network Toronto Rehab Bickle Center. Thank you for joining us on the last Friday of November for our Ontario Regional Meeting, or should I say Ontario NSWOC Education Day. It is great that we are also joined by our NSWOC and SWAN colleagues in different provinces and territories outside of Ontario. I am so excited to give you a synopsis of our planned event. In creating today's agenda, my vision is to leverage the role of NSWOCs and SWANs in various sectors of care and to use our meetings as a platform to highlight our specialization and the valuable work that our NSWOC and SWAN members do. It also gives an opportunity to identify potential challenges that can impact care delivery to our complex client population, which in turn affect our pivotal roles. Looking forward to hear from our fellow NSWOCs representing long-term care, community, and rehab, who will provide us insights of their crucial roles on these areas of care. In the same context, I also would like to use our meetings to be an opportunity to support continuous learning of our NSWOC and SWAN community. Therefore, I'd like to extend my gratitude to our industry partners for collaborating with some of our NSWOC colleagues to educate us with emerging practices and innovations in wound, ostomy, and continence that supports our own practices. We will also be sharing important updates from NSWOC Canada and render important insight on current initiatives from accessing Medena catheters, the next steps with the Canadian best practices on the topical management of malignant cutaneous wounds, and exciting new projects in 2025, and of course, opportunities to engage our NSWOC and SWAN members. I want to formally thank Coloplast, Hollister, and Orga Medical for your sponsorship, which will support the Harm Reduction Project on the Canadian best practices in wound care for people who use drugs, a harm reduction approach. So without further ado, I'd like to introduce our first set of speakers who will discuss the Health Canada's special access process for Medena catheters to support people living with a Kock pouch. First up, we have Kathy Hurley. Catherine has served as the Chief Executive Officer, formerly Executive Director for Nurse Specialized in Wound, Ostomy, and Incontinence Canada for the last 20 years, and was also the first Executive Director for the Operating Room Nurses Association of Canada, or ORNAC, for 5 years. Past experience includes serving as a Director of Global Strategic Marketing, wound care core business for Convatec division of Bristol Myers Squibb in Skillman, New Jersey, USA, and business unit manager for wound and skin care based in Montreal, Quebec, Canada, prior to that. As an international healthcare consultant, she facilitated strategic business planning for the board directors of the Wound Council of Enterostomal Therapists in Hong Kong, Ostomy Canada Society, and the International Skin Care Advisory Panel, known as ISTAP. She is also a registered nurse with a neurosurgical ICU clinical background, and she completed the International Interprofessional Wound Care course at the University of Toronto, studied postgraduate business, and completed a postgraduate program in a not-for-profit board governance at the Telfair School of Business in University of Ottawa and the Rotman School of Business in University of Toronto. Kathy will also be joined today by Joel Goldenberg, who is the current president of the Premier Ostomy Center. Kathy and Joel, take it over.
Thank you so much, Joshua. And you can see Joel has joined us there. What we'd like to do today is to share with you our experience as we work towards gaining access to Medena catheters for people living with a Kock pouch across Canada. And so in the time we have together, we'd like to provide information on how the process to access Medena catheters for emptying a Kock pouch has changed. We want to discuss an alternative method to be able to access them. And that will include showing you a form that needs to be filled out and an example of this form. We'll also evaluate the process of accessing Medena catheters for patients living with a Kock pouch. And then we will talk a bit about how they're paid for and how you can access them and actually get them paid for in your facility. And so what I'd like to do is just start by redefining what a cock pouch is. I'm sure most of you know what it is, but I'll just make some general statements around this. So it was first performed in 1969 by Dr. Niels Kock in Sweden. And basically, during the surgery, a surgeon connects the end of the small intestine to the abdominal wall, creating a stoma. And then they construct an internal pouch from part of the small intestine and attach it to the stoma. And this allows for the patient to be able to control when they're emptying their stool, and there's no external pouch. So the pouch is emptied with a Medena catheter. They're mainly for ileostomies or continent ileostomies, but they can also be used for urinary situations. But there's so many more surgeries that are updated and advanced that they're not used as much as they used to be in the past. And with these cock pouch procedures, there can be complications. So you can get valve complications where the valve can slip over time and it can cause leaking and impact the skin. And a slip flap can also obstruct the pouch opening and make it difficult to insert a catheter to drain it. And so the patient may end up needing revision surgery. A second complication, the patient could develop a fistula from the pouch to other organs. And if the tissue wears away, this can be impacted with inflammation or a loss of blood supply to the area, which can cause pain and infection. The third issue of having a cock pouch is pouchitis. And this is when pain and inflammation occurs, and it's usually due to infection, and the patient will need to go on a course of antibiotics. There can also be stricture or stenosis at the opening of the pouch, so the opening area can narrow, and when you go to put the catheter in, it may meet some resistance or be hard to put in, and the patient may need dilation if this happens. The fifth complication is a peristomal hernia. So if a loop of the intestine emerges through the stoma, a hernia can grow over time and block the stoma opening, and it could actually pinch the intestine, creating a blockage. And finally, the patient could also experience short bowel syndrome. So if a revision surgery is required for a K-pouch, there is a risk of not having enough small bowel left after the surgery, and this can impact the patient's digestion and their ability to be able to absorb nutrients. And so what we're talking about today are the Medena catheters that are used to empty the cock pouch. And it's really important to start at really knowing what these Medena catheters are about and why it's important for the patients to have them. So really, the overall statement is that they facilitate a safe and effective insertion and emptying of a continent ileostomy. And in length, they're 30 centimeters. They're about 1 centimeter in outer diameter. You can see the image of them in the top right-hand corner. They're made of metal grade polyvinyl chloride or PVC with phthalate-free plasticizer by TEHTM. And I would like to just explain that phthalates are a family of chemicals that are used as plasticizers, and they're substances that are added to PVC plastics to make them more flexible and durable. But TEHTM is a tri-2-ethylhexyl trimeltate, which is a phthalate-free plasticizer. And this is used in medical devices such as blood bag and this type of tubing. And so it's resistant to migration, which is important when you're using this type of medical device because it reduces the amount of plasticizer that can leak into the device's contents. And therefore, it reduces the risk of toxicity. The top of the catheter is rounded and it has a hole. I know it's a little bit hard to see, but it's right at the tip of the catheter. It needs to be inserted very gently into the stoma, and it can release pressure and gases in the area when the cock pouch is being emptied. So the distance and size of the two holes at the end of the catheter are designed to avoid that area from bending when it's inserted through the opening of a continent ileostomy. And patients should only use these Medena catheters after they're trained in its use by an NSWOC. And so that's a bit on the Medena catheters, but in order for you to know the code names and the names of the actual catheter, this is what is available in Canada. We will be sharing these presentations, so you will have copies of these codes, but you have your Medena Straight 24 French, a Medena Straight 30 French, and a Medena Bend 30 French. The manufacturer of the Medena catheters is based in Sweden now, and we'll tell you a little bit about how that happened in just a moment. And we also have a Canadian national distributor who is Premier Ostomy there, and it's Joel Goldenberg, the president, who you'll be hearing from in just a moment, and they're based in Montreal, Quebec. And so I'd like to just kind of walk you through the challenge that we had when Medena catheters were, for a very short time, no longer available in Canada. We received a call from several NSWOCs who were concerned because their patients were having issues accessing Medena catheters, and Health Canada at that point was not supporting bringing the catheters into Canada for distribution within our country because the company who had been producing them and selling them in Canada had sold to another European company. We first started by looking at how many patients in Canada potentially would be impacted by not being able to have these catheters and not being able to empty their cock pouches. And so we were able to identify approximately 500, but there could be more that just did not come forward. And we had done this by asking NSWOCs who were doing ostomy care and in facilities with ostomy surgery, and also Ostomy Canada Society provided us with some numbers. So Medena catheters were sold in Canada through a company called Torbot until 2021. They were sold to Urad at that time, which is a company based in Sweden. But due to a declining market and the high cost of obtaining the medical device license in Canada, Urad decided not to apply for the necessary license. It was very cost prohibitive. And because the market was declining from a business case standpoint, they said they could not rationalize moving forward with business in Canada. And so what that meant was that patients were going to have to order the catheters in from the US, and Urad company said that they would not ship to individual patients in Canada at that time. And so Premier Ostomy Center applied to import the Medena catheters, and they did, Premier Ostomy did have the required licenses, but they were still refused by Health Canada. And Health Canada was trying to make the decision as to how they were going to move forward with these catheters, and they felt that patients could access it outside of the country, which wasn't always the case. And so when we presented to Health Canada more than once and had follow-up phone calls, and the response we got was, well, it's only 500 people. But what they had to understand is it's 500 people who could end up with blockages and other complications if they didn't have access to these catheters to be able to empty their cock pouch. And so Joel and I teamed up together, and we also had input from many NSWOCs across the country, and we actively advocated to Health Canada, emphasizing the importance of the access to Medena catheters for patients. But unfortunately, we just kept getting blocked. And so Joel was making the proper applications from his end to be able to bring the catheters in, and he was getting rejected. And so the catheters were discontinued, and Health Canada was saying at this time it was not considered a shortage. There were catheters in the system, and so anyway, the bottom line is that we couldn't substitute this catheter for another licensed medical device, and Health Canada did refuse to move forward at that time. And so we went back to Health Canada and we pointed out that many patients have undergone this surgery, this cock pouch surgery. They're older, they're living on limited incomes. And because of the cost that they're facing, they can't take additional shipping and duty fees if they have to purchase these products outside of Canada. So if they do have to go to the US, it makes the purchases quite expensive. And distributors outside of Canada were also setting high minimum order requirements. So the patients couldn't just buy a few at a time, they had to buy multiples at a time. So it further increased the cost. And Health Canada said to us, well, we're going to inform the Canadian Border Services that we will permit the importation of the Medena catheters for personal use if patients are ordering it from the United States. But the problem was that many patients didn't live near customs offices, and they may have to travel if the products got held up at customs. And also they ended up having extra duties and fees placed upon the orders. And so, and then the other issue was they had to arrange the shipping through customs through a courier. So it ended up becoming very, very complicated. And so the other thing Health Canada said is that they had received a very few or a limited number of special access applications for these catheters. But we pointed out to them that many of these patients are older and they may be unaware of how they can apply for it, and they may lack computer skills needed to complete the forms. And so, and then the other thing we knew is that patients were reusing these catheters. They were reusing them multiple times. So because Health Canada said, well, we really aren't seeing a lot of movement with these catheters. But there is a danger in reusing the catheters. And one NSWOC even told us that a patient had the tip of the catheter break off into the cock pouch internally because they had reused the catheter so many times and it had broken down. So there were many barriers and many challenges that were happening, and that we had to go after. And so we took a look at how people were currently managing their care, and we knew that the patients were depleting the remaining stock of Medena catheters in Canada. So we knew the supply was going to run out. We knew that some patients need to empty their pouches 2 to 3 times a day, and they're reusing the catheters, and this practice could increase risk of infection. And we also knew that URAD was not going to ship to Canada, and they won't ship to individual patients. They were fully unwilling to do it because of cost and resources. The market size is reducing because these patients are older and they're not doing as many of these surgeries anymore. And we also knew that there was no in-country clinical support to help these patients with their needs unless they were connected with an NSWOC or someone who would be able to support this process. And so I'm going to turn it over to Joel now, and he's going to walk you through the approach to have a single importer and distributor for Medena catheters in Canada.
Thank you, Kathy, and good morning to everybody. If I continue, so basically, it was discussed that having a single importer and distributor to manage the importation and the distribution of the Medena catheters to the patients in Canada would provide several advantages. First off, we would have accurate tracking. So at this point, I know exactly how many catheters are being purchased, who is using them. So at some point, I'll be able to create data to hand over to Kathy and the NSWOCC Association. So we'll actually know, we should at some point know how many people in Canada actually have the problem, how many are using the product, how often they're changing their catheters. So we'll be able to have proper data with them. The second thing is, well, we hope it doesn't happen. As you know, with medical products, unfortunately, sometimes there are manufacturer's defects that require recalls. By having a single importer and distributor, it facilitates quick and effective communication with all patients in event of a product recall. We can make the arrangements to swap the product out if necessary. So it's better for patients. So this centralized approach would enhance the management and the safety of the Medena catheter distribution in Canada. So after, like Kathy said, we had multiple meetings with Health Canada. On July 18th, we finally had a meeting, Kathy and I, and about 6 different people from the various departments in Health Canada, so we could come to a terms and not be passed from one, because that was one of the issues, is one department was telling us something, we would go to that to the other department that they would recommend, and they say, no, we can't do that. So we finally got everybody together in one room so that we can come to a consensus. And basically what we came up with was as follows. So we have the special access process. So a batch request system will be implemented, allowing for the monthly quantity to be required specifically. And the RNs can apply on behalf of the patients through a batch request. Basically, the healthcare professional has to apply for it only based on the healthcare facility where they are working at. So it has to be to a healthcare facility. It could be private or public, but that's the way it has to be. The special access form must be completed, including the batch process section. So what they're letting us do by batch process as well is if you have multiple patients, you only have to fill out one form and you can list the multiple patients' initials, not their full names. You just would need to list their initials. Furthermore, you can apply for, I think the last time they told us is up to 3 months at a time worth of stuff, because this is going to be very important. Every single time the patient needs catheters, you are going to have to restart the process, reapply for the special access again for this 3-month period and list the number of catheters required. The positive, as I could tell you, is once the forms are filled out properly, Health Canada is usually responding within 42 to 72 hours with the approval. So that part is going very well. The second thing is, since we're already through this and I've now have all 3 sizes in stock in Canada, once we get the approval, it's very quick turnaround to the patient. The first ones were longer because I couldn't actually import it until I had the special access. Now that I've been able to order quantities, we have the stock physically in Canada. So Premier Ostomy Center is authorized to import the catheters from URAD and sell them within Canada. Health Canada will notify Premier Ostomy upon receipt and approval of the batch request. The payment process will be managed by Premier Ostomy, which will ship to bill to the patients directly. So I'm going to have to explain this a bit, and I've made a few changes recently. So basically the way this works is I am only allowed to technically sell the catheters to the person who is applying it. So therefore I have to sell the catheters to the nurse or to the healthcare facility where they are working at. The nurse does not have to pay me. The healthcare facility doesn't have to pay me, but I have to have a bill to that. So basically what we've come up with is we will make a bill out to the healthcare facility or to the nurse's name as that, with a bill to that and a ship to the patient. We are also coming up with a second bill because we realize at that point, what is the patient going to do if they have private insurance and want to claim back and there's no bill in their name? So we are now making a second invoice that'll be from the nurse or the healthcare facility to the billing it directly to the patient. Everything will be at zero value. So that way the nurse will have in their records the proof that they've ordered it and the proof that they've technically sold it. So there'll be a zero balance, and there will be a second bill that the healthcare the patient can go to their health insurance or their government agency and prove that yes, they did in fact buy these bills because they have a bill in their name. Once the patients we reach out to the patients, they pay us usually by credit card. We will then ship the products directly to the patient. And we have to have the special consideration that for patients experiencing homelessness or other issues, social services will need to be involved to facilitate the process. Again, often we can get them to reimburse the patient directly, or we can make arrangements directly. Depending on the province, we can make arrangements directly that we can hopefully bill directly to the patient.
Yeah, and it's interesting, Joel and I have already come in contact with one NSWOC who has a homeless patient that we had provided this information to, and they were going to have to go through social services. So this has already happened.
Yes, it is unfortunate, but it's not necessarily even homeless, but people that are on low income, just regular social services, that in general don't pay for any of their medical supplies because they don't have money for it. Those are the kind of people that we're going to have to work something out directly with the provincial health authority, depending, like I said, depending on the province, and that's done on a province by province basis. So the guidelines for the batch request for multiple devices. For the batch requests involving multiple units of the same device, you can request additional devices for anticipated emergency cases if the following conditions are met. A licensed medical device is not available. Shipping delays could negatively impact patient outcomes. So obviously in this case, both criteria are met. Because there is no licensed product available, and shipping from Sweden to over here is ridiculously long. You will need to estimate the number of devices required for a monthly emergency use over a 1 month period. Health Canada has since told us that we can go up to 3 months on that. So you can do a 3 month period. So basically, that is the idea, is you want to put the number of catheters for approximately a 3 month period that they're going to use. It's not going to be a huge number, we know that, but that's the way it has to be done. So we're looking for a 3 month period. And that's honestly to save more, it's for two reasons. It's to save you the paperwork and having to do this over and over again. And it's to encourage the patients to order a little bit bigger quantities so that it saves on the shipping costs. That way I don't have to start charging shipping on it as well. And I know I saw a question just pop up on there, how much are the catheters? I can answer that right away. They're $30 a catheter. So I've sort of explained how the shipping and billing works, but I will go over it again because it is a little bit complex. So basically, you will fill out the special access form. The special access form gets sent off to Health Canada. Health Canada will approve it. They will send me a copy that it is approved. I will then reach out to you and to make sure we have the full patient information. We will then reach out to the patient directly and tell them, yes, we have the approval, we have the catheters. We will make sure that we will arrange for the payment. Once we have the payment, we have the two bills, like we said, prepared. One that will be from Premier Ostomy Center, billed to the nurse that applied for the product. A second bill will be billed from the nurse to the patient so that the patient can claim back on their insurance, on their income taxes, whatever they want. So all bills will be marked paid. So don't worry for the nurses. You will not be getting a bill that shows you that you owe us any money or anything. The bill will be clearly marked paid. The bill to the patient will be clearly marked paid. It's just a bookkeeping transaction to satisfy both Health Canada that we are following their guidelines, that we only can bill to the nurse or the healthcare facility, and to provide the patient with a bill that they could show and claim back what they want. In terms of a product recall, how that would work, that's very simple. We have the list of all the special access, we have the list of the patients, and we have the list of the nurses. So if ever there would be a recall, we would reach out to everybody in on the chain, both the nurse and the patient, to advise them of the recall, depending on what the recall is, to arrange how to ship back the product or to just dispose of the product, and to make arrangements to reship replacement product. So it would be done both through the nurse and directly to the patient. In
Yeah,
terms of
and Joel, that was one of the things when we spoke to Health Canada that, I mean, we brought up and discussed with them is if the patients are bringing in product from the US and there's a product recall, there wasn't a clear pathway to get to these patients. Whereas now, with the way it's set up through Premier Ostomy, you have a very clear process in place.
See, also is because in general, actually, always manufacturer recalls. Nobody in general reaches out to patients. It's done. If company X has a product recall, they will reach out to me at Premier Ostomy Center, and then it would be up to me to reach out to any individual patient. So manufacturers don't do that. I am willing to do that and go directly to the patient while keeping the nurse in the loop, because that will facilitate things and to lessen the workload for the nurses. But it is definitely a better way for the patient, because this way, like I said, I can go directly to the patient and let them know, or my company can go directly to the patient and advise them. And the same thing for clinical support. We're there, my team is there. If patients or nurses have any questions, any issues using the product, any issues on how to dispose of product, we're there. We have a great customer service team. We can respond by phone, we can respond by email. I'm often available for Teams or Zooms meetings if necessary, whether it be with the nurse directly or with the patient. We're also there to help you guys fill out the forms, because I know that several of you, we've already had several nurses reach out to Kathy or myself for help in filling out the form. I could tell you that if you have one letter wrong when you fill out the form, it's going to be refused. So I know Kathy's going to get into it shortly about how to fill out the form. But so we're there to support you along the way. And then again, navigating the process province by province, because, you know, we have organizations like the AA Dale in Alberta that have full coverage for patients. You have SAIL in Saskatchewan that people should be good for up to 50% recovery on this. And then we have other different provincial programs. So we have to figure out a way, and I'm willing to work with the local authorities and with the nurses in the different provinces to help get them eventually fully covered, so that the patient doesn't have to pay me directly, and that we can get the provincial health authorities to pay me directly.
And so now I'd like to take the opportunity to introduce you to the special access form that Health Canada has now allowed us to be able to fill out in order to access Medena catheters. And there are some very specific things that need to happen in order to fill this out. And these forms are available online, and we have the QR code here, and we also have copies of these forms that we can email to you if needed. But I'm going to go out of the presentation for a moment, because we have a sample of one of these forms, and we've kept it updated when we notice certain things that Health Canada would and would not accept when they were submitted. So if you bear with me for just a second, I am going to go out and bring up the example form, and I'm going to walk you through it. Okay, can you see the form?
Yep, looks good.
Okay, great. So this is the application form that comes from Health Canada for custom-made devices and medical devices for special access. You absolutely have to have this exact form. And at the top, there is an email address. And this is the email address that the form is sent to once it's filled out. So it's right at the top of the form, and that's where all forms are submitted. And so walking through the form, first of all, you have to put in the healthcare professional who is looking after the patient. So you can see here, Susan Smith, full provincial license number as a regulated healthcare professional, and the nurse's street address, where the person lives, and the postal code, the telephone number. If they have a fax, you would put it here. If not, just put NA. And then the email address of the nurse would go into this area. So this is the personal information of the nurse. And someone at Health Canada would probably be validating this in the background. Then the healthcare facility information. You have to put the name of the healthcare facility you're working at, the street address, city and province, and the postal code. It's very important that every single one of these fields is filled in. Do not leave anything blank. It's got to be completely filled in. Now, it's interesting here. They ask for the date of the procedure, and they did originally have a place that an actual date that could be put in. They rejected a couple of forms, and we couldn't figure out why. And it's because they want a date of when the product will start to be used, not the actual date of the procedure, which is a little bit misleading. And so what they said they would accept is just to put "to be determined" instead of putting an actual date in. And since we've put that in, we've noticed that they've put the forms through. So just put "to be determined." And then if it is an emergency procedure, you would check here. If you're just ordering, you don't need to check that. And then in the next section, it's the information regarding the unlicensed device. So it's the name of device, components, and accessories. And so in here, we have put two things: the Medena straight ileostomy catheter and Medena bend ileostomy catheter. And it may be one or maybe the other. So it's whatever your patient's using. We just put both in so you could see how they would accept them being written. So you may just delete one of these. And then underneath it, you have your device identifier, which includes the catalog or model number. So you have the product code, what the catheter is, and size. And you need to put all of these things for whatever you're ordering. And you may only, again, be ordering one of these, but we put all of them in so you could have an example of all of the information that you need to include. So you can customize this based on your patient's needs. And then here you put the quantity of each catalog or model number required. Now they're letting us order up to 3 months worth of supplies. This is just an example on an annualized basis. But you could put for 3 months, you could put 3,000 catheters. So, or however many the patient or patients that you're ordering for are going to use. So that would go in this area. And you would need to say whether you're ordering the Medena straight or the Medena bend in this area. If it's a custom-made device, you would have to click here. It is not, so you do not have to check this box. It stays empty. And then the next section, you put in the manufacturer's name, which is Yorad AB, the contact name and title, the street number, where they're located. It's in Sweden. And all of that information that you need is written right here. And again, we have this sample if you would like to get a copy. You need the phone number of the manufacturer and the email. They do not have a fax. So all of that is written in these particular fields, exactly how they're written here. And then you go to the importer or distributor information, which is Premier Ostomy Center, Joel Goldenberg, the president, the street number, the city and province, the postal code, the telephone number and extension, the fax number, and the email all have to be submitted into this form and written into the form. Underneath that, you have to have a medical rationale. Now, this is an example of the type of information that they're looking for. However, what we've discovered is two things. You cannot say that you're using a template. If you tell Health Canada, if they call you for any reason and you just say, well, I'm just using a template, they will reject it. You have to take whatever the particular nature is of your patient and just use this as a guide, but kind of put it into your own words and then submit it. If they see that this has just been copied and pasted and they have a run of similar descriptions, they will reject it. So just customize the medical rationale based on the unique situation of each patient. You then here you have to list the devices considered and provide a rationale as to why these licensed devices would not adequately meet the requirements of a patient. And what we put here is there are no other catheters like this available in Canada that will address the needs of this patient population. So that can go right into number 2. And then you look at the risks and benefits associated with the use of the Medena catheters, and you indicate how the benefits outweigh the risks. And again, this is just a guide here. The information's been pulled together. I would just take this and put it into the unique circumstance of the patient in your own words. And that's section number 3. And then number 4, we did do a scan in the country, and there were no record of any side effects or issues when using these catheters. And they are essential to the patient to be able to empty their cock pouch or continent ileostomy. They're safe and effective, and it's emptied by inserting the special catheter through the valve 2 to 4 times a day. So this section can be consistent, section 4, to what is written here. And it just backs that there have been no known issues. And then here, this basically describes a batch release, which they will allow. So this is when you have more than one patient and you need to order for multiple patients, then you put the reason that you need to get the cock pouch or the Medena catheters for the cock pouch procedure, and also why they need to have it, and then how many you would need in 1 month. But now, as Joel mentioned, they are accepting up to 3 months. So you can think of a 3-month time frame. And then underneath it, there's an undertaking. So you have to validate that you as a health care professional will inform the patient, and you put their initials. And if you have more than one patient, you would put like TS, comma, EM, comma, TA, comma. So you would list the initials of the patients here if more than one. And that so this would say that secondly, that you have confirmed that you've informed the patient. So if you've already informed the patient, you would click this box. If you commit to informing them but haven't done it yet, you click the first box. You exit. And then if you're doing a batch release, so you have multiple patients that will be using the product, then you again have to validate that you've undertaken to inform the patients who are to be treated with the use of the medical device. And if you can't inform the patient, then you would click the second box. And then underneath that, you have to sign and validate and put the date that you signed it. This absolutely has to be signed or they will reject it. And then you also have to sign that this statement of information is true to the best of your knowledge and date that as well. So there's two places you have to sign it after you have signed the batch release request and after you sign it to say the full document is valid. Then you take this form and you email it. It can be sent electronically. They will accept fax as well if you only have fax, but I find now they're very good to accept it electronically. And then within 48 to 72 hours, the form is reviewed. And once it's reviewed, the process is then they send it right into Premier Ostomy, and then Joel and his team act on this right away. And if you do have any questions, there is a phone number in Ottawa that you can call, or anytime you can call Joel or myself, and we will help you walk through this. And we've done this multiple times since we gave the initial webinars back in the summer. And so that's basically the form and how it's filled out. And I would just say, make sure every T is crossed and every dot is added to the I. And if you do want it reviewed before, don't hesitate to email it again to Joel or myself, and we'll do whatever we can to help you. So I'm just going to switch back over and finish up. Okay. And so for the important contact and form submission information, again, we have it in this presentation. This presentation is now available in French and in English, and we do have the form in French as well. So we have it in both official languages. And again, we're happy to help you however we can.
Kathy, I'm just looking at it, just if you don't mind, actually, now that I'm thinking about it, before you send it out, do you want to add my email address as well? Because
Yes.
sometimes it's easier to reach me by email than by phone. It usually is, actually. So just add my email address so everybody has that for those who don't already have it.
Sounds good. And then in summary, we have now a process to obtain Medena catheters within Canada using this special access / batch process form, which has been approved by Health Canada. You have to fill the form out very carefully and submit it to the email address on the form to start the process. You will receive support from Premier Ostomy with the ship to and bill to process as part of the process to be able to access the catheters. And we are actively tracking the number of patients and the Medena catheters in use over the next 12 months, and we'll have to report back to Health Canada. We've had about 7 so far. And we will make sure that our membership is updated with the numbers of patients that are accessing this program. And we will be following up with discussions with Health Canada on an ongoing basis. And again, if you have any additional inquiries, you can contact office@nswoc.ca anytime, and we'll make sure that you're connected with the right people. And so I'll stop now and we will entertain any questions that you may have.
Thanks, Kathy and Joel, for this very incredible presentation. Very informative for walking us through the background, for the importance of the Medena catheters for our Kock pouch patients, and the tireless efforts that you both do, both from NSWOCC Canada as well as Premier Ostomy Center. So we do have a few questions here that was sent to us. The first one is around, for batch release, does this have to be completed if ordering for one person?
Yes. Yeah, even if it's one person, you have to fill out the batch release and put one set of patient initials in there. That's kind of how Health Canada got us around being able to use this form, because normally we wouldn't have been able to use it. So yes, you have to put it in even if one patient.
Because also a batch is considered multiple orders. So in theory, if you were doing the batch, you'd only be able to order one catheter at a time. So that's the other reason is they consider multiple orders as a batch.
Yes.
Okay, thank you for that. And the other question here is there is wanting to know about the approximate cost of the catheters.
Yeah, so those are $30 each.
$30 each. And I saw, I think Lena Martins had put in, yeah, if you go to the NSWOCC Advance December 2021 issue and December 2022 issue, our NSWOCC colleagues, Eleanor Howard, Terry Schroeder, and Mary Engel published 2 articles on the Kock pouch history, surgical procedure, and guidance for nursing assessment and management, and a very informative case study. I know I read those articles when they came out, and they are very, very informative, and I would highly recommend that you take a look at that.
Are there any other questions from our chat? Just checking in from people. I'm not seeing anything at this time. Okay, there's no other questions, Kathy and Joel. So again, thank you so much for the valuable effort that you guys do and tirelessly, and for taking the moment to join us in today's Education Day. Really appreciate it.
Okay, thank you so much, and thanks, Joel.
Thank you guys both, and I'm going to log out because I have to head to the airport shortly to finally fly back home.
Have a safe trip,
Thank
Joel.
you.
Thank you.
And again, if you guys have any questions, please send it off to office@nswoc.ca. Now moving on to our presentation here. Our next presenter is a sponsored education from Coloplast, and the focus is on enabling effective wound care education for non-specialists by introducing a Coloplast wound type specific pathway. This will be presented to us by Erin Meager, who is an NSWOC and a clinical specialist for Coloplast wound and skin care. After graduating with a BSN from the University of Victoria, she began her career in a general medical and surgical unit at Seychelles Hospital. There she worked with patients with complex health needs and deepened her passion for wound care. In 2015, Erin returned to her hometown in North Vancouver, BC, and transitioned into home and community care. To further engage her passion for all things wound and ostomy related, Erin completed the Wound Ostomy Continence course from Emory University in 2019. As she continued working in the community as an NSWOC and provided advanced wound care treatments to patients and wound education to both patients and healthcare professionals. Welcome, Erin, and thanks for coming today. And the table is yours.
All right, thank you. Thank you, Josh. Hi, everyone. Yes, my name's Erin. I'm an NSWOC and clinical specialist for Coloplast. I'm really excited to be presenting here today at this Education Day. And I'm presenting on something that I'm actually very passionate about. And obviously all of you guys are passionate about it too, because it centers around wound care education. And that's why we're here today for an NSWOC Education Day. So today I'm going to be introducing you, or maybe reintroducing you, to the wound care pathway and the wound type, the new wound type specific pathway tool.
And Erin, I just wanted to double check before you get going here. Do you have the PowerPoint pulled up on your side there?
Yep, sorry. Thank you for
no problem at all.
my screen. I just forgot to share the screen.
No problem. All good.
Nerves.
Awesome. Looks great. Okay, I'll give it back over to you.
Okay, perfect. Thank you so much. All right. So before I jump into the presentation, I do have this little disclaimer letting you know that today's presentation is for general information purposes only, does not constitute medical or business advice. Please continue to use your own medical and clinical judgment for that. Okay, so wound care faces many challenges, but a recent global survey found that lack of education, high turnover rate of staff, and inconsistency of care are some of the biggest challenges reported by healthcare professionals. I'm sure many of us on the call today would agree with this and have experienced this. And so I thought I would take a few minutes just to share some of my experiences with these challenges. So I'm going to start back all the way back to nursing school. I graduated from nursing school in 2013. So the majority of the skills and wound and education that we learned would have been done in second year nursing school. And so that was approximately 13 years ago now, just for reference. The wound care education was minimal. It consisted of reading Potter and Perry and attending a 2-hour skills lab. So I still have my Potter and Perry. Just for fun, I pulled this big bad boy out. I forgot how backbreaking this book was in nursing school. And so I had a look at the chapter on skin and wound integrity. It's 50 pages long. It does provide a very nice overview of of how to manage a wound, how to assess a wound, and different things that are involved with wound care. But it is basically just an overview. It doesn't really provide too much information on how to manage chronic wounds. So for example, the section on venous leg ulcers consists of 2 paragraphs. The first paragraph gives a brief description of the etiology of venous leg ulcer. The second paragraph covers some treatment options. So I do want to read a little excerpt of what they recommend to help with venous leg ulcer management. So because venous leg ulcers are often hard to heal wounds, clients may have tried a variety of products, such as lanolin and topical moisturizers, topical antibiotics, or others. These products may create allergic contact dermatitis, and it is best to avoid anything but the most simple, natural products to clean, debride, moisten, and cover. Use normal saline, autolytic debriding agents, preservative-free hydrogels, and soft silicone dressings. Avoid products with preservatives, chemicals in the dressing, or fragrances. Edema control is essential, but many clients are not willing to try or maintain compression. Now, it does go on to say, talk about needing an ABI before compression, but the main advice is to contact a wound specialist who can help you with compression. And that's about it from the textbook. Not a whole heck of a lot there to support the management of chronic wounds. The skills lab would have covered a few basics. So the focus was on wound cleansing. The biggest thing that I remember from nursing school was the emphasis of how to open a sterile tray, making sure you don't contaminate it. Of course, that's really important. But the main focus was around folding the little 2x2 gauze into those little packages. Some people might call those little wontons. So they could be dipped in saline so that we can swab a wound. So again, very basic, minimal education on how to manage a chronic wound. And, for me, I felt like this didn't really prepare me very well for the types of wounds and the severity of wounds that I would later encounter when I became a home care nurse. So I want to know from all of you, did you have a similar nursing experience, or did you use Potter and Perry from your nursing school? It does say it's the Canadian Fundamentals of Nursing, so I assume most people in Canada probably read this book. So if you did, send up a little heart emoji just down at the bottom in the reactions. Okay, I see at least 1, 2, a few people coming up. So so it sounds like a few of us kind of experienced a similar sort of lack or minimal education when it came to wound care and nursing school, which is sometimes understandable because nursing is so broad, it covers so many different topics. And so wound care, I feel like maybe just got a little bit lost in the mix. But I know that we are working towards changing some of that. And maybe in the 13 years since I've been a nursing student, some of that has changed. So after I graduated nursing school, I got my first nursing job at Seasheld Hospital. And this is a rural, for anyone who doesn't know BC very well, this is a rural community off the coast, on the west coast of British Columbia. You need to take a ferry to get there, so it's remote access. At the time, the hospital did not have an NSWOC on staff. And I don't know if that's part of it, but really when I was hired, my orientation there was very, very minimal, and it did not consist of any sort of wound care education or training. Anything I would have learned would have come from any of the ward nurses that I was working with. We did have a supply room filled with dressings, but I'm not sure that anyone could really tell me what goes where at the time. It was just sort of, oh, that one's bleeding a lot, so put this, a ABD pad on it, or this one's very dry, put a Me-Pore Island on it. Just very simple sort of instruction in wound care management, and certainly nothing involving chronic wound management. After working at Seashell for a couple of years, I did move back to North Vancouver and began work at Lionsgate Hospital. And so I think she's dropped off the call now, but I'll give a quick shout out to Rosemary Hill. Rosemary Hill and her partner in crime, Anne-Marie Somerville, they're the NSWOCs at Lionsgate Hospital. They've been there for many, many years now. And so they ran a wound care education as part of the new hire orientation at Lionsgate Hospital. And so this was really my first introduction to the role of an NSWOC. And although I don't remember a lot of what happened at that orientation day, I do recall Anne-Marie was the one who provided the education. I think it centered around, assessing a wound, characteristics of a wound, and dressings that you had access to, and probably when to contact them for support. So though it was really great information and probably is what stimulated me down this path of wanting to become an NSWOC, I'm not sure that it had a whole lot of management for chronic wounds in it either. Although that may have changed. That was 9 years ago that I received that orientation. So the program may have changed since then. So I didn't stay long at Lionsgate Hospital because ultimately my goal was to become a home care nurse. At the time, Home and Community gave me a 4-week orientation into home care. That orientation did include some advanced wound care education. But basically at the time I was given a very large binder full of protocols, policies, procedures, things that I had to read independently on my own. I was given some time at work to read this information, but anything I didn't finish during those work hours, it was expected that I took it home and finished it on my own time. We also received a few weeks of buddy shifts. And so again, I was able to observe nurses, I'll say maybe nurses that had been working there longer, senior nurses, providing wound care. That might have been maybe even my first introduction to those single-use saline bottles that have the irrigation tip on there, and then my first introduction to even the technique of using wound irrigation to cleanse a wound. Also would have watched them do advanced skills like negative pressure, compression therapy. We did have a wound clinician at the time, and she gave me a demo of lower limb assessment as well as how to obtain an ABI. But I don't really remember, again, anything specific around chronic wound management, just a few tidbits on, how to care for venous leg ulcers and, just that need for that compression therapy for venous leg ulcers. But I don't remember a whole heck of a lot around, maybe diabetic foot ulcers, pressure injury. That one, obviously, there's so much education around pressure injury and pressure injury prevention. So definitely had a lot of that, but not necessarily a lot on the actual, management of a patient with a chronic wound. Now, Now, the way the education was set up in home and community, it didn't necessarily work for everybody. It was a lot of independent learning, just kind of reading modules. And that style of learning works for many people. At least it worked for me. But not everybody likes that style of nursing. Some people need a bit more hands-on approach, or they need a bit more support when it comes to the type of education that they get. And so we did have quite a high staff turnover rate when I first got hired. I just remember, people wouldn't really last long after completing orientation, or maybe they wouldn't even make it through the orientation process. And so we did have that high turnover rate. And so one of the big reasons for that, I think, was related to the fact of this lack of support and education. Also, a part of the problem might have been the fact that we don't just see wounds in our community. We also have a very large palliative care population in the North Shore. And so the program was combined. And so during that 4-week orientation, we not only had to learn about wound care, but we also had to learn palliative care. And those two specialties are huge in and of themselves. It was an overwhelming amount of new information, new skills. And so, it's not surprising that many people has had a hard time, joining the home and community team. There was also a high expectation that you were able to work independently right away after that orientation. And so that could be very intimidating and scary to a nurse who, had primarily worked on an acute care ward where you're surrounded by people that you can turn to for help. It's quite, it can be very scary being in community where you're just working by yourself and you have to figure out everything that has to happen. And so this led to the development of a home health, we call it RHEP, Regional Home Health Education Program. Some of you may be familiar with this. So this is an 8-week training program or training course. It includes reading, so self-guided reading, online modules, skills lab, instructor-led tutorials, and preceptorship. And so this program was really designed to, not only attract nurses into home and community, but also have to support them with the challenges that occur in home and community, and with the incredible amount of knowledge that you need in order to practice in home and community. And so it really went a long way to help retaining nurses and supporting them in the home health program. So I'm hopeful, or what I would really like to know is, does your hospital, community, or long-term care facility include wound care education and training? If you guys feel comfortable and want to write in the chat, yes, you have your new hires get wound care education, or maybe no, they don't. Then some of us on the call can kind of get a sense of what people have access to when it comes to wound care education, and whether or not they get any wound care education, and whether that wound care education includes chronic wounds. So I'll let you guys fill the chat. I'll come back and check the chat in a couple of minutes. So the creation of the RHEP program, it did help with the retaining nurses. For the most part, the new hires would stay with us longer, but we still had high staff turnover rate. But I think that was mostly related to, we had a lot of retirements, and then we had a lot of new or younger nurses, and then a lot of maternity leaves. And so we were still seeing a constant staff turnover, but I don't think it was necessarily related to this lack of education or lack of support anymore. Despite the creation of this RHEP program, there were still inconsistencies of care occurring in the community. And so I really saw these inconsistencies of care when I became the NSWOC of the community. So for example, many venous leg ulcer patients had an incorrect etiology. Most likely it was listed as trauma. Lower limb assessments and ABIs were done inconsistently or not at all. I remember we use a charting system called Pixelaire, and I would get these referrals from venous leg ulcer patients, and they'd been on the caseload for maybe 6 months, a year, 2 years, and the only basic lower limb or lower limb assessment that was done on admission. And so it's 2 years later, and here we haven't had another limb assessment or ABI done. And so, you know, it's hard to manage a person with a chronic wound if you don't have the correct etiology, if you don't have the correct assessments, and you're not able, because then you're just not really able to follow best practice recommendations at that time. So this led to me, you know, I just kind of really made it my mission to provide education for the community that would help maybe reduce some of these inconsistencies. And so I'm going to talk about that in just a couple minutes. I'm just going to turn to the chat and just kind of see, whoops, go back there for a sec. And yeah, we see, so I have someone, no education. We give 4 hours to the new hire, wound care education, really, that's good. LMS program, online reading, but isn't required. 1 hour corporate orientation, focusing on policies. Yes, we do. Yeah, so it looks like some of us have access to wound care education. Same thing though, lots of material to cover. It's overwhelming, and it also sounds like it's minimal education. So it sounds like I'm not alone with my experiences, and you guys aren't either. And we're not alone in the world. So this is a study from the UK. I think it was published in 2019. And in this study, they found 25% of wounds lacked a differential diagnosis, and only 15% of lower limb wounds had a Doppler recorded. So kind of similar experiences to me. They also found that dressing types were continually switched at successive dressing changes. Fewer than 1% of patients were being given the same dressing for their wound, and they found that on average, 8 different dressing types were prescribed per patient over the study period. So it sounds like, again, a lot of inconsistency of care happening in the UK. This was sort of contributing to the overall heavy burden of cost of wound care. I know a lot of us, I don't know if you attended the Wounds Canada conference, but Douglas Queen and Dr. Michael Stacey did a really nice presentation talking about wound care across the globe, and the rising cost of wound care, how much each country is spending. And it sounds like we're all just spending a lot of money on wound care, and we're all experiencing a lot of the same challenges with wound care education and consistency with care. I've got another study here. This is the Danish effect study, and it found that 51% of participants had no previous wound care training, yet 82% of them were providing wound care daily. So remember this study. I'm going to come back to this effect study in just a moment. So this global need for chronic wound care education and guidance led to the development of the wound care pathway. Many of you may be familiar with this evidence-based guideline already. The wound care pathway was launched in Canada approximately 2 years ago at the Wounds Canada conference. The wound care pathway was developed using input from over 2,000 healthcare professionals, including physicians, nurse specialists, dermatologists, pharmacists, dietitians, physical and occupational therapists, and many more. The 5-step wound care pathway guides nurses on how to assess a person with a chronic, or if you prefer, a hard to heal wound, how to develop a treatment plan, how to manage and treat a chronic wound, and how to choose a dressing, and how to monitor the patient and the wound progression. The guideline also includes a section on when to refer the patient to a wound care specialist or other type of specialist, not just a wound care specialist. If you want to learn more about how the process of how the wound care pathway was developed, there is an article published on Wounds International website. As well, it is available on CINAHL. So I know as an NSWOCC membership, we have access to CINAHL, and I have found that article there. I'm also happy to send a link out afterwards if anyone would like to read it. So the wound care pathway has been utilized by clinicians around the world and has improved the knowledge, confidence, motivation, and critical thinking skills of the generalist nurse. So it's helping generalist nurses care for patients with hard to heal wounds and just giving them a bit more of that training, that education that is needed to confidently care for a person with a chronic wound. So this is the Danish effect study that I spoke of earlier. So initially they surveyed the participants, and that's where they found 51% had no education or training prior to participating in the study. The effect study was conducted in Denmark between January 2023 and January 2024. And it included community nurses and nurses working in nursing homes. The study involved questionnaires that were answered by non-specialist nurses before and after receiving 6 hours of training using the wound care pathway. So we can see here from the results that the participants were able to answer. So when it came to knowledge, they were able to answer 37% more questions correctly. When it comes to confidence, they felt, 41% of participants felt more confident after receiving this training. And critical thinking increased as well. 77% of participants felt that their critical thinking improved because of this training. And so even though this study is a small study, I still think it's important, and it highlights the need of providing simplified tools which help to empower generalist nurses to deliver better care. If you would like to read more about the effect study, this has been published, or I believe it's been published. It was supposed to be published a week or two ago. And you can find it in the British Journal of Community Nursing. All right, so why develop the wound type specific pathway? Well, basically, healthcare professionals asked for more detailed guidance on the care and management for specific chronic wound types. The wound type specific pathway expands on the wound care pathway by offering supplemental information specific to the 5 most common wound types. Again, this article, if you would like to read more about the development of the wound type specific pathways, this article, which we see on the screen on the right, was published in Wounds International website, again, also available on CINAHL. But I'm going to go through some of the highlights of the process with you. So here we have our global expert panel. These are the nurses, or the wound care experts from around the world that met and governed the project. Some of you may be familiar with the gentleman on the far right. This is Dr. David Keast. He's the medical director of the Chronic Wound and Lymphedema Consultation Clinic at the Parkwood Institute in London, Ontario. I always think it's amazing, or I always feel very proud when I see that Canadians are contributing not only to wound care education, but wound care education that is being received on a global level. So really great to see our participation in the project. The wound type specific pathways are evidence-based. 5 separate literature reviews were conducted, and approximately 135 publications were identified and used. A global survey was also conducted, and that gathered some experiential evidence from healthcare workers or healthcare professionals to augment the research data. This survey had over 2,200 respondents from various healthcare professions. There was local focus groups that met in 6 countries to receive feedback on the pathways. And then the expert panel reviewed the feedback, the content, and approved the content for each of the wound type pathways. The pathways were then validated in 6 countries by 62 healthcare professionals. So here are the 5 wound types that were chosen. We've got venous leg ulcer, pressure injury, skin tears, diabetic foot ulcer, and surgical wound dehiscence. These 5 wound types were chosen because they are the most common wounds seen by specialists and non-specialists around the world. Now, although best practice recommendations exist for each of these wound types, they tend to be lengthy and complex, and with staffing levels and workloads being what they are these days, I think everyone has experienced heavier than normal workloads, higher than normal patient ratios. From doing a lot of research lately, I know that at least here in Ontario, you guys have a higher nurse per patient ratio than anyone else in the country. It can be really challenging for staff to find time in their really busy work days in order to read these huge documents on these wound types. Nurses these days are experiencing higher than ever levels of stress and burnout, sick leave, and things like that. And so it's hard for people when they're experiencing those things to have the energy or the mental capacity to take on new knowledge and new skills and new learning. I know from personal experience with stress and burnout that it was very challenging for me to take on new information during those times. And so it's important to offer simplified guidance in order to support them where they're at. In an ideal world, every nurse would be given time for education. But the reality is time for education is one of the first things that gets cut when you're short-staffed. I mean, we can even look on the call today. I mean, I see quite a lot of people on the call, about 47 participants, which is amazing. I don't know the actual number of NSWOCs that are in Canada, but I'm sure a lot of our colleagues would love to be here today, but they're probably not here today because of heavy patient load, because RNs and RPNs and LPNs, whatever your designation of nursing is, that is always short-staffed and in demand. But NSWOCs are also short-staffed, and where they're not creating enough positions of NSWOCs to keep up with the demand of all of the wounds that we are seeing out there. And so, it's important to make education easy and accessible for patients, that they're able, we do need to prioritize education a little bit. I know patients do take a priority, but if we don't have the education to support their healthcare needs, then we're just going to keep kind of going in circles with the healthcare, right? So I know In my community, we did have a 1 hour of wound rounds every month that was scheduled, or at least we were supposed to. I remember when I was a home care nurse, wound rounds were often canceled because of short staffing. Once I became the NSWOC, I felt it was really important to reestablish wound rounds, but I did try to make it more accessible for the nurses. So for instance, I reduced wound rounds to 30 minutes so that it wouldn't cut into their charting time and cause them to stay late. At the time, this was around COVID-19, but there was always sort of this pressure to not have too much overtime in our area. And so that's why wound rounds would get canceled if we were short-staffed, because they, didn't want to go into overtime unless they really had to. And so if I reduced wound rounds, I could still hold them and I could still have nurses attend, but it wouldn't hurt their charting time or cause that overtime. I created short presentations that centered around topics where I was seeing inconsistency with care. So some of the topics included like differential lower leg assessments review, compression therapy. I had ABI clinics. I would bring in the rep for the compression wraps to, and we did like a compression wrap clinic refresher course. Anything that I could do to try and support the nurses and support their practice. My goal was to make education short, simple, and relevant to practice, something that would attract them, make them want to attend. It probably didn't hurt that I provided snacks. I feel like nothing brings nurses to an event more than the offer of free food. And so we were able, I was able to keep wound rounds going despite the challenges of COVID-19 and being short-staffed. And so this is why I'm really excited to see the wound type specific pathways. These pathways are brief, easy to read and understand. They are designed to guide nurses through healing a chronic wound using an evidence-based approach. So it's more than just changing a dressing. We want to get them to look at the whole individual and look at everything related to the cause of that wound to help support that wound healing. I feel these pathways can be used in a variety of ways. They can be a starting point for nurses that don't have access to wound care education or training. They could also be used by NSWOCs to refresh staff on the management for these wound types. I could very easily present one pathway in a 30-minute wound rounds, and we could. And I always like to bring in local experience. So have the nurses bring up a patient with a venous leg ulcer and go through the pathway and see what we could do differently to help support the healing of that wound. Maybe the nurses would think of that patient and their care in a new light, in a new way. The guides can be used independently or as part of a training program, something similar to what we saw in the Danish effects study. So just some simple training hours could really be effective in improving the knowledge, confidence, motivation, and critical thinking skills for nurses. So the wound type specific pathways have a similar structure, format, and design to the wound care pathway. One difference is the wound type specific pathway includes a definition of the wound type. The pathways are not prescriptive. They will not tell the generalist nurse to do this or do that. It's really meant to be more of a guide, and it's not a set of step-by-step instructions. So let's take a look at one of the pathways. We're going to look at the venous leg ulcer pathway. So each pathway starts with an intro and description of what the pathway is. The pathway reminds the healthcare professional to follow local protocols and practice within their scope. So this guide is intended for any healthcare professional. Nurses, I think in Ontario we call them registered practical nurses. In BC we call them licensed practical nurses. So anyone can use the guide, and we just want to remind everyone to practice within your individual scope, which varies from province to province, and to still follow your local protocols if you have them in place. There's also a legend letting you know what the icons and QR codes mean. A dark blue QR code takes the nurse to a helpful tool, and a light blue QR code dives deeper into the subject matter. There's also some clinical references on the side here. So each pathway will start with the simple definition. It does give a brief etiology of the cause of the wound, and there are some helpful photos so that the nurse can identify what a venous leg ulcer looks like, but what each of the wound types would look like. So each follow the same structure. The assessment page takes a broad approach and starts with a holistic assessment of the patient. If the reader is unfamiliar with how to obtain a holistic assessment, this little book icon that you see at the end of the sentence is directing them to the wound care pathway. So we have to remember that this is a supplemental guide. Some of the initial basics of wound assessment, holistic wound assessment, and how to determine what a chronic wound is would be contained in the wound care pathway. And so these guides are meant to be used together, but of course you can use the venous leg ulcer pathway, the wound type specific pathways on their own as well. But there are references back to the wound care pathway. Next, the nurse is directed to perform a limb assessment, and the leg ulcer measurement tool, or LUMPT, is available via the QR code if the nurse does not have access to another limb assessment tool. So I know in my community, as part of our Pixelair charting system, we did have forms for lower leg assessments. But there might be people out there in a community who maybe aren't using a lower limb assessment tool, don't have access to one. And so this QR code is going to bring them to that tool that they can use. Finally, the nurse is directed to complete a wound assessment using a validated tool, such as the triangle of wound assessment available from Coloplast. The light bulb icon identifies something else the reader may need to consider. On this page, the light bulb is letting the reader know that characteristics of venous disease may appear differently in patients with darker skin tones, and guides the reader on how to assess those differences. Next, the healthcare professional will be guided on how to diagnose a venous leg ulcer through the exclusion of arterial insufficiency. It does not provide a step-by-step instruction on how to take an ABPI. So nurses will have to refer to their local policy and protocol for that. Depending on the scope of practice, it may or may not be within an RN's or an LPN's scope of practice to do an ABPI. And so that needs to defer to local policy for that. But there is a QR code that takes you to the European Society of Vascular Surgeons. They have a clinical practice guideline that offers additional support on assessing and differentiating venous disease from arterial disease, and also provides support on compression therapy and things like that. The how to develop a treatment plan section will contain treatment guidance specific to each wound type. So for the venous leg ulcer, it provides guidance on compression therapy. The management section takes a patient-centric approach and asks the healthcare professional to consider things like patient preference, mobility, lifestyle, and likely concordance. The management section also includes guidance on wound cleansing, debriding, managing exudate, and monitoring for signs and symptoms of infection. The little QR code at the bottom will send you to the International Wound Infection Institute's Infection Continuum and Management Guide. I've been reading this guideline a lot lately, trying to learn more about biofilm management and biofilm protocols and other things that help just help support managing a patient with a chronic wound and managing that infection, which we see all too often with our chronic wounds. So that's a very helpful guide at the bottom as well. The How to Choose a Dressing section offers generic advice on dressing selection. So the meaning you're not going to see Coloplast specific products on this page. This guide, these pathways are intended for everyone to be able to use, regardless of what brand name of product that you have on your shelves or in your formulary. So it offers very specific generic advice, one like choosing a dressing that helps manage exudate, making sure it's non-adherent, so it will be atraumatic upon removal. Choose an antimicrobial if you suspect infection. So basic advice such as that. It also will offer some adjunct therapies like negative pressure that can be used when appropriate, and again, according to scope of practice. Step 5 is how to monitor progression and provides some direction on prevention strategies such as skincare, lifelong compression, and physical exercise. So including, your stimulating the calf pump muscle by doing the ankle and dorsiflexion, dorsal reflection to get that calf pump muscle working. Each guideline, each pathway also includes guidance on when to refer to a specialist. I'm really glad to see this section. In my practice, I never minded getting inappropriate referrals. I know sometimes when I talk with my colleagues down in the US, they would complain about getting inappropriate referrals. But that never bothered me. My biggest pet peeve was not receiving a referral at all. And there were definitely times where if I had maybe been included a little bit sooner in the treatment plan, we could have helped a patient a little bit earlier on or maybe prevented some more serious complications. So I think it's really important that generalist nurses know when to refer to a specialist, and depending on the pathway that you're looking at, it will tell you to, whether or not it's a wound care specialist or maybe vascular surgery, or even infection control specialists that you might need to help support the healing of a person with a chronic wound or a venous leg ulcer. The last page contains a glossary of terms that were used throughout the pathway to help support that learning. And it also provides some QR codes to the other 4 pathways that are available. Okay, so this is just one of the 5 pathways. And as I said earlier, each pathway follows the same structure. Each pathway is evidence-based, and these were made by clinicians for clinicians. The pathways are also a living document. The expert panel still meets several times a year. We're continuously receiving feedback, incorporating new evidence-based practice, and updating the pathways as new evidence emerges. The team is also working on creating other wound type specific pathways. So stay tuned. You might see some more wound types added to the mix later on. The pathways are also available in French. So it's great to see that we have both languages represented for the pathways. And these are global documents. These are used by people around the globe, so they do exist in other languages as well. So you can find the pathways on coloplast.com. You can find them at the Coloplast professional platform. You can also just do a simple Google search of Coloplast pathways, and that will bring it up. You can reach out to your local Coloplast territory manager to obtain a copy of them. And you can also use this QR code here to download the pathways. So I want to thank you guys so much for inviting me to present, for listening to me today. And if there are any questions, I'd be happy to take them now.
Thanks so much, Erin, for this very informative session. And I like how you set the stage talking about the global challenges in wound care, which I can guarantee you when people are probably listening on their desktop, they're resonating, nodding their heads, keeping it, oh yeah, I see that all the time. So great presentation for that. And what stood for me most is when you provided some of the statistics about that, I think it was in Europe, where 82% of the patients that they actually manage have wounds, while only about 51% doesn't have the capacity to take care of them. And that is very detrimental when you think about it in the long run, because these patients will actually increase their length of stay and affect their quality of life. So great that you leverage that to use the pathways as a need for that kind of instances. So thank you very much for sharing this to us. And I love the QR code that links to different added information, because for me as a clinician, I'd like to know more about certain things, but you made it easy by linking it into the page itself.
Yeah, thank you so much. So they're pretty easy to use. Hopefully, if anyone was trying to grab a QR code from the actual presentation, it may not work because of the resolution. So download the pathways from here, because the resolution will be better. Sometimes I found it was a little tricky if the icons were really small, so I did have to increase them on my computer screen to get them. So just a couple of tips and tricks for anyone who might be struggling with the QR codes is just to make them bigger or reach out to us, because maybe it's a resolution issue.
Great. There was one question earlier, Erin, but I think you answered it. Do these guides will be translated in French? And then you did mention that it's available in different languages. So that's amazing.
Yes, and French was one of the first ones when we were going to bring them to Canada. So we had our colleagues from Montreal translate them into French for our colleagues in Canada that primarily use French. So not a problem there.
Okay, so there's another question that came into the Q&A, and that is, can a skin tear in the leg can treat with the same dressing with a venous ulcer?
I guess it depends on what characteristics are happening with the skin tear. With skin tears, we definitely want to make sure that we're using non-adherent dressings or dressings that are safe on the skin. So I know primarily silicone-based dressings are sometimes recommended, or just a non-adherent pad, maybe attached with maybe a gauze, so we're avoiding adhesive altogether on the skin. It also depends on, like, venous leg ulcers tend to be highly exudating. Whereas most skin tears I find are lower exudating, unless it's a skin tear on a lower leg, which we might be having two different issues happening at the same time, skin tear and venous leg ulcer or venous insufficiency happening. So it will really depend on the characteristics that you're assessing from your wound, the amount of exudate, and your patient, and what their skin, if their skin is fragile or not.
Excellent. And again, it goes back to understanding what the etiology is and treating the cause of the type of wound that we're dealing with. Thanks for that, Erin.
Yeah, exactly.
I am not seeing any other questions, but I do have some questions.
Oh, okay.
Because given that this is a great project and initiative that was done by Coloplast, how do you intend to evaluate the use and uptake of the care pathway from people that are using it?
Well, we do have the Danish effects study was one example of how we were monitoring the use. So a group of individuals in Denmark, as that survey found, were lacking that wound care education and training. And so that study was devised to provide them with the training using the wound care pathway. and then evaluating their knowledge, confidence, motivation, and critical thinking. I know from reading the full article that the study did, I think this happens with all research. I mean, I'm new to this new research world, but sometimes it's hard to get subjects to fully participate. So I know they started with like almost 200 nurses, but by the end, the ones that actually were able to complete the entire training course ended up being 89. So I know that's often a challenge. Sometimes it's permissions and getting permissions and consents. But yeah, because we're all struggling with our workload, sometimes it's hard to participate in this type of research. I don't know of any specific. No, that's not true. I actually was on a call with the global team yesterday, and I think there's some research going on in like France and Italy where they're implementing the pathways and training with them and monitoring that. But I don't have any publication dates for that. But once we do, we will let you know. And then, you know, here in Canada, if anyone is interested in doing a study similar to the Danish effect study and wants to work with Coloplast, we're happy to support that education and learning as well.
Thanks, Erin. And the other question I have is, given that there was all the 5 types of, 4 of them are actually like, you know, hard to heal wounds, and the rest probably would be acute wound. Is there a capacity or future plan to expand the pathways to include other types of wound etiologies?
Yes, there definitely is. I know there are a couple more pathways coming out. I just don't have a launch date for Canada yet. But definitely stay tuned because yes, we are working on a few more wound type specific pathways, and hopefully in the next year or so we'll be able to launch those ones as well. And if you have any suggestions, please let us know. We are Coloplast is always here to listen and support. We're always happy to help patients with intimate healthcare needs. And so we want to support those patients. So, you know, if you think there's a wound type that's missing or needs more support, let us know, and perhaps that can be turned into a pathway as well.
Thank you, Erin. So just a couple of comments in the chat. So they were happy about the great information that you have provided. So congratulations. And also they're happy that it's available in French. So that's there as well. I'm not seeing any other questions at this time. So I would actually just want to extend my thanks for you, Erin, for coming out of your busy schedule to join us in this such, last Friday of November, and for informing us about the pathway that Coloplast have developed.
Yes, thank you so much. It was a pleasure, and I'm really excited to hear the rest of the agenda for today. So thank you so much, everyone.
Thank you. And given as what Erin has mentioned, time is often the challenge for us healthcare providers because of sometimes there's a workload issue and of course conflicting schedules. But for rest assured that this program is actually being recorded, and for anybody who have registered for this event, they will receive a on-demand link for the event after the fact. Okay. Now moving on to our agenda, and this one is in regards to the Canadian best practice recommendations for the topical management of malignant cutaneous wounds, and knowing what the next steps would be, which is going to be presented by my colleague, Deborah Johnston. And Deborah is a clinical nurse specialist in wound ostomy and incontinence at the University Health Network Toronto Western Hospital. She began her nursing career in the community initially as a generalist before specializing in wound ostomy and incontinence care. In her acute care practice, Deborah provides consultations for complex wound and ostomy issues and is passionate about supporting staff education. Previously, she served as a core program lead for professional development with NSWOCC. She's deeply committed to promoting high quality of care and enhancing patients' quality of life by developing best practice recommendations for individuals living with chronic wounds, ostomies, and fistulae. Over to you, Deborah.
Can you see my screen okay there, Josh?
We don't see it right now. Deborah, do you want to try sharing one more time?
Okay.
There we go. Looks like it's popping up now.
Yep, I can see it now.
Okay. And you see the full screen now?
Not full screen yet. If you want to just try going into slideshow and pulling it up. Oh, there we go. Perfect. Looks
Is
good.
it there? Okay,
Thanks,
perfect.
Deborah.
Great, thanks. So I just want to thank everybody for coming in today, and thank you to Josh for the opportunity. Just to review this, I think for some of you, you're at our national conference, and this may be a little bit of a repeat, but Josh also said there was probably a lot of people that weren't able to attend. So it might be a nice idea just to kind of recap what that project was all about, how we can implement it into our practice, and then just kind of implementation where we are year to date. So I'll go ahead and begin to share this. So our objectives today, of course, I want to introduce you to the working team. So I think that every great project has a team of people behind it, and this is definitely one of those projects. So there was a working team between ourselves and the Canadian Palliative Care Nursing Association that collaboratively worked. I think it was over a 14-month or 16-month process. So thank you to everyone. And then today would just be a brief overview of the scope of the project and the recommendations. Due to time, I'm not going to read all the recommendations. I'm going to give you a high-level summary of what those are and then discuss the implementation to date. So conflict of interest, just to let you know that this was done by an unrestricted educational grant from Monoliki. So we want to thank our partners for their donation for that. It really helps to get projects like this off the ground and get literature available that all of us can use. And for our task force members, there were no conflict of interest. And so this is our group. I wanted to acknowledge all the task force members. So you'll see a lot of our NSWOCC community partners here, but you're also going to see some of the members of the Canadian Palliative Care Nursing Association. So it was everybody's hard work and dedication that really brought this inaugural Canadian document to life. So thank you very much to everybody that participated. I think there were a lot of people that worked on this document too. Behind the scenes, I wanted to acknowledge. So I think, our patients graciously allowed our team members to take pictures of their wounds and include it for educational purposes within the document. And so thank you so much for all those patients that did that. We had the valuable insight from 40 peer reviewers. Some of those reviewers may have been yourselves. And so that really helps us to fine tune and just really hone the document. So we appreciate everybody's feedback. And I can't thank Valerie Champlain enough. So she is one of our NSWOCs that lives in Quebec, works in Ottawa, I believe, and she provided the French translation. And Valerie does a lot of work for that translation, which is so needed and appreciated by our French community. So special thank you for Valerie, who does that on top of everything else that she does. To John Gregory for his writing skill, his technical writing and project management. Of course, Kevin Wu for assisting with our literature search through Queen's University, and Dr. Valerie Schultz, which I'll get to her slide in just a minute, but she provided an updated version of her malignant wound assessment tool that we can use in our practice. So our project goal, looking at the photo in this picture, we can appreciate how intricate and complex the care of these wounds can be. First and foremost for the patient living with a malignant wound, but also for the support person that was the terminology we chose to use for a family or caregiver, and then the rest of the support team and the healthcare systems. Surprisingly, there's only a small amount of literature available to guide this care. So our goal was to fill this recognized gap and to standardize the care that we provide to this patient population. We developed 23 recommendations to serve as a guide for nurses, the healthcare team, and the larger healthcare system to enhance the quality of care. One critical element we included throughout the document and the specific interventions is for the mental health and well-being of everyone. We can appreciate the profound emotional, psychological, and psychosocial impact these wounds can have on the person as well as for everyone else in their circle of care. We acknowledge that not everyone has a support person, and having a support person is a privilege. As a healthcare community continues to develop best practice recommendations and best practice guidelines, we have to continue to be cognizant of the cultural humility and strive to recommend care that addresses various factors, including health equity, socioeconomic status, and diversity. So the scope of our project. the care and management of malignant wounds is a large topic, which includes a multitude of primary and secondary soft tissue disruptions and numerous treatment interventions. However, the scope of our project was narrowed to and reflects the scope of our NSWOCC practice. Our scope included the topical management of malignant cutaneous wounds that can form from a primary skin cancer, from the local spread of soft tissue tumors, or the metastatic spread of primary tumors. What our project was unable to include was many other associated physical and psychological symptoms and treatment modalities that are also central to the care of someone with a malignant wound, but were excluded from the project just due to being able to keep it manageable. The topic treatment recommendations for pain and pruritus are not all encompassing, rather the reflection of the symptom management modalities that we noted from our literature review. The modalities included the management of 2 primary symptoms, pain and pruritus, that are very broad, knowing that the availability of medications will vary based on the site that you work in, your local policies and procedures, and also the province and territory that you live in. The inclusion of a palliative care team is instrumental in pain and symptom management. So now let's turn our attention just to the recommendations themselves. So the recommendations are structured into these topic headings here. Each recommendation is accompanied by supporting references, the level of evidence using the RNAO interpretation of evidence model, and an explanation of the rationale why we included it. The wording in the headings is very intentional, notably pain, symptom management, as well as malodor rather than odor. And then each section concludes with a summary of clinical pearls. So I'm going to briefly go through the recommendation headings, just a quick overview, and you can go into the full document if you wish. So our first section of recommendations is focused on assessment. From our clinical practice, we know that these wounds can occur in a very chaotic and unpredictable manner, resulting in very unique wounds. Our initial goal is to confirm the wound etiology, as our wound care goals and our subsequent care planning and interventions are based on the understanding if this is palliative or a non-healing wound. It is also critical to conduct a thorough wound assessment with a specific malignant wound assessment tool, if possible, to best manage their topical wound-related symptoms, conduct a holistic assessment that includes quality of life, their medical and surgical history, medications, and also a previous wound care plan if they had one. So the peer reviewers that we worked with specifically asked that we could include tools within the assessment guide. I think best practice recommendations and best practice guidelines are fantastic documents, but when they include something that we can easily take that best evidence and translate it to point of care practice, it just makes best practice so much easier to provide. And so what you'll see here is one of the tools that we wrote about in our guideline. So this is Valerie Schultz's malignant wound assessment tool. Interestingly, she developed this in 2001. She began developing this in 2001 as part of her master's thesis. So when you think about how, the work that you do, I don't think we ever think that's going to carry on for 2 decades later, but here she is, and she's still evolving this tool, and we were able to reach out to her. There's different forms of it that were online. We're able to reach out to her, and she worked with her research team just to make a couple of changes to update the tool a little bit more to more standard current care or current times. And she gave us permission to include this in the tool. And I believe she might be possibly presenting this in more detail at the next NSWOCC conference, or maybe it'll be a webinar, but she's very excited to be participating in our document and hopefully future research down the road if somebody wants to do some research with her with regards to using this tool in clinical practice. So that's just one tool that you can find in the guideline, and there's some other tools as well. The next section of recommendations focuses on identifying the goals of care and care planning. This begins with assessing the person and the support person's level of understanding of what the wound is. So what is the wound etiology? The expectations for healing, so knowing that it probably won't, and their ability to manage the wound. Often these patients may initially begin to receive care in the home and community setting with scheduled nursing visits for wound care. With this, much of the care that's needed in between visits could be provided by their support person. So it's important to understand how comfortable they are and how much involvement they would like early on in a plan of care. As we explored and retrieved literature, it became readily apparent that the health system itself played a very pivotal role in the management of malignant wounds, such as like the interprofessional team, the care that we provide, the humility that we bring. So these 3 recommendations that you'll see here on the screen emphasize the need too for mental health support for the healthcare professionals working in this field. The next section of recommendation falls under education. So while the title section is education, this section is very robust and filled with key information for both the physical wound care, but also the emotional and the psychological aspects of care as well. The education needs falls under various tiers. So first, we have the education tier for the patient and their support person, the sharing of information and the guidance with the evolving wound care needs. But equally as important is the emotional support and the resources that we also provide to them. Second is providing ongoing support and education to our interprofessional team. So thinking of our nursing profession, for example, we need to ensure that we're supporting our team with the knowledge and psychological support to provide the best care. This education impacts different levels of nursing. So for our point of care nurses that we work with, how do we ensure that they have the knowledge, skill, and the comfort to provide the physical care and convey the appropriate education to the patient? As NSWOCs, how do we educate ourselves, ensuring we're recommending the most effective topical management while being cognizant of the emotional impact on the patient and their carer and then our team? And finally, thinking about our nursing leadership. How does this level of nursing support the mental health and well-being of the nursing team? And this can be through in-services, opportunities for sharing, and debriefs when something tragic happens. Almost without exception, every paper we looked at acknowledged and described the impact of pain and pruritus for patients living with malignant cutaneous wounds. And consequently, we put this into our paper and we discussed it ahead of bleeding, malodor, and moisture management. And so you can go directly into those, into that paper to see what these recommendations are. In the literature, malodor is probably the most distressing symptoms that the patients talked about. The level of malodor can range from nil to strong or sometimes permeating. The level of odor, too, has a profound effect on the person's body image and also a significant effect on the relationships with those around them. And so isolation is something that's very common with these patients. They're very likely to be sensitive to reaction of other people around their wound or during wound care. This section of recommendations focuses on strategies to decrease and manage malodor topically through wound care cleansing, the use of topical antimicrobials and antibiotics, as well as environmental strategies. It also discusses the role of debridement. So this is something that we had to put within the paper. So debridement, as we know, can have some benefits, but it's knowing the patient situation, being aware of the practice setting that you're in and within your scope of practice. So it's important to understand the goal of debridement with these wounds is not to achieve healing necessarily. It's not to achieve healing at all, actually. But instead, it's a way to improve the quality of life, to reduce odor, and to decrease the risk of infection from that devitalized tissue being on the wound base. When it comes to debridement, as always, it depends on a multitude of factors. Using a palliative care approach, suitable debridement methods can be considered to improve quality of life, where removal of non-viable tissue can help to reduce odor. So managing malignant wounds with aggressive debridement is not recommended due to the risk of pain and bleeding. Debriding by way of autolysis is preferred, and depending on the person's prognosis, it may be pertinent to leave dry, stable, hard eschar intact and just simply protect the area. In some patient care settings, the cautious use of conservative sharp wound debridement can be an effective way to control odor by removing non-viable tissue, which will slow down the bacterial growth and the odor. So it's important that we know our scope of practice, we know the setting that we're in, and we're operating within the risk factors, and of course, with the patient's informed consent. Our recommendations will now turn to the management of other common wound care needs, such as bleeding and moisture management. The bleeding from malignant cutaneous wounds can be a source of anxiety for the person and their support persons. It can be a very traumatic experience, especially in the case of a hemorrhagic bleed, which is why it's important to anticipate bleeding as much as possible by identifying high-risk situations. I included an extra slide about bleeding just because of just the nature of bleeding and how difficult it can be sometimes to manage. I think bleeding from a malignant wound can often be unpredictable, and it's very imperative to anticipate that risk and have a plan in place ahead of time. The level of bleeding, so as many of you know from your clinical practice, the level of bleeding can vary very much. You can have small vessel rupture with just small amounts of bleeding, or you can have profuse bleeding with erosions of larger vessels, especially from head and neck wounds. Bleeding from a wound, even if it's not fatal, can be distressing to the person living with the wound, the support person that's there with them, and to any member of the healthcare team that is present at that time. Support should be available for all these individuals before and after the incident. Advanced care planning should be in place to ensure that every potential event is covered and that the person or the support person, especially if they're in the home environment, have the education and the necessary supplies available to provide the right care during that moment. So there's a lot of recommendations in our guideline with regards to bleeding. Anything from, wound care, topical wound care management with dressings, to what do you do during catastrophic bleeds. And I think this is something that's helpful for all of us to review. I think when we're working with nurses and there is a risk of a catastrophic bleed, sitting down and having a plan of care with the nurses is very important. I know palliative care comes in, they talk to the patients and also to the nursing team as well about medications that can be given during that critical time. But I think also thinking about wound care, what things can we have in the room? So in my personal experience, when we're anticipating a high-risk situation and a risk of a severe catastrophic bleed, we'll have green surgical towels in the patient's room. Often we kind of keep them off to the side. So it's not necessarily right there for the family and the patient to be seen and be aware of, but at some place where the nurses can easily access them should they need them at that time, because there isn't sometimes a lot of time. You just need to act very, very quickly. And just having that nursing discussion, I think, about how do we manage the fear and anxiety around the staff nurses that need to provide the care? And then what do they do should something happen during the wound care management itself, or they walk in and they find somebody bleeding. So I think, reviewing that part of the guideline is very helpful for our practice. I think for anybody that's ever been involved in a catastrophic bleed, it is something that we'll never forget. And we learn from it and we get a little bit more prepared each time. But I think that's a really critical point of managing malignant wounds, especially if it's around larger vessels or head and neck, just to make sure that the nurses feel comfortable having in-services and debriefs, throughout the care, and then definitely at the end of life afterwards, having those debriefs is very helpful for everybody that's involved. And so finally, we're going to turn to moisture management. So the topical management of malignant wounds can often increase the wound exudate due to the vascularity and the permeability of the blood vessels, which can result in a high level, sometimes profuse level of exudate coming from a wound. And so in the document, there's a lot of different wound care supplies. It's not exhaustive, but there is a list of different wound care formulations that we can use to manage the moisture that are atraumatic, to best manage that moisture, hopefully reduce the frequency of the dressing changes if we can. It all depends on the wound. And we had to put in a slide as well around negative pressure wound therapy, because that was something that came up in several of the articles. And so we spent a good deal of time considering discussing the use of negative pressure wound therapy. So while its use is widespread for moisture management of exudating wounds and is recognized for its ability to sometimes remove devitalized tissue and manage the odor, the research on the use of negative pressure around malignant cutaneous wounds is very sparse. And so its role in, decreasing the dressing changes, definitely that is a bonus for it. But its use in palliative care, specifically alleviating pain, is inconclusive, or it is very, very limited at best. So our recommendation is that negative pressure wound therapy, and again, you'll have to use your knowledge, skill, and judgment within your clinical practice, but it is not used on a malignant cutaneous wound. It may be different if you had a tumor that was resected, and then you had a subsequent surgical incision that reopened. And so that's different. Some people have discussed that. That's different. What this guideline is talking about is the topical management of malignant cutaneous wounds. And for that wound etiology, we're not recommending the negative pressure wound therapy. And finally, evaluation and research. So we need more research, of course. So I think in terms of evaluation, I think we all do this in our practice. So it's looking at the care plans that we have created for the nursing staff and for the patient, and just continually reassessing those. So as a wound evolves and things change, we change the topical management as needed. In terms of research, this is kind of exciting. I think, if there's people that are looking, for work to do, I think having collaborative research projects is something that would be very beneficial. There'd be a larger group of us and probably a larger group of patients that we could work from. But the literature, like I said, is very dated, what we were able to find. I think there's exciting opportunities for research that we can do within our practice. So when you think about just even wound care products, so the efficacy around, wound cleansing and wound care dressings, their effect on pain and pruritus, the reduction of odor, it's difficult sometimes to do long-term research on these patients, because by the time they have a malignant cutaneous wound, the research says that often their prognosis is very limited by that time. But we know there are some patients that live a little bit longer with malignant cutaneous wounds. So I think understanding the formulations of the dressings that we use and the unique nuances of different dressings, how can we maybe determine what would be the most effective wound care, topical wound care dressings that we could do. And then, of course, looking at the quality of life of patients, but also the caregivers that, they're there all the time, and they're seeing and they're taking in these experiences and they're remembering them. How can we improve the quality of life for the patient, but then also to the caregiver? How can we look at, maybe designing more patient care centered approaches, and then looking at financial resources too. I think sometimes the care that we provide is limited based on what sector that you're working with and what services are available, and products as well. So that's something for future research. So implementation to date, I think, Josh, we're still kind of in the sharing sector right now. We presented this at the NSWOCC conference in May of 2024. And during that conference, the English version came out, and then shortly thereafter, the French version was available. So now both are posted on the NSWOCC website. I think NSWOCC did a fantastic job of e-blast to all of our industry partners and different healthcare partners as well about the publication of the document. Shortly after the NSWOCC conference, we were told it was adopted by the Alberta Health Services. which is very exciting. Cano too became aware of the guideline. Just to kind of say, they were initially invited to participate in it, but they didn't get back to Kathy Harley. So we just, we just moved forward. But they were very excited once it was published. And so we did a webinar for them in the summer of 2024. And there was a national conference that just happened, I think in St. John's in October. So one of our members did a presentation at Cano. And then the Canadian Palliative Care Nursing Association, we did a webinar for them, and that was in June of 2024. And there's a national conference opportunity. It'll be next year in the fall of 2025 that we will, hopefully one of our team members will present at. And then as for publication, I'm excited to say I just got word this week that this will be out the next JWOCN. So in the November-December issue, we have two different publications. So the executive summary that talks about the development of the guideline, and then also a feature article filling the gap, establishing the standard for topical management of malignant cutaneous wounds. So I think now that's published in JWOCN, it'll attract a lot more attention because it'll be received by a lot more professionals outside of Canada. So we're excited to maybe see where that takes us. And then as far as it, we go here, I think, how we take the guideline and we, embrace that and adopt it into our practice. We can share that within Ontario of how we're maybe doing that within our institutions or maybe within the home care areas that we work in, and then just share how we're adopting it and utilizing it and making an impactful impact on patients' quality of life, and then also the care that we provide, I think, in the support for our nursing, generalist nurses as well. And is there any questions?
Well, thanks, Deborah, for that. I'm looking at the chat box. There's no questions right now, but a lot of congratulations to you and the hard work that you and the team have made in this, Canadian Best Practice Guideline. There was a comment here by Joni sending her thanks for the happy work that she had while working with you in this project. And she did say that she's actually going to engage a 3-hour training session on malignant splints next Tuesday with my son, Michelle Sarrazin, for any French speakers who might be interested to join that event.
Oh, fantastic.
A lot of congratulations, a lot of clapping hands emojis everywhere. So Deborah, congratulations to the work that you and your team have done. This is an incredible Canadian best practice recommendation that is much needed. And congratulations to the upcoming JWOC and publication that's up on the works. And I think Kathy Harley did provide a link to the abstract or the executive summary. So thank you so much for the incredible work that you do.
Thank you.
Okay, I think yeah, there are no questions here. Thanks, Deborah.
Thanks to everybody. Bye.
Okay, everybody. So we are now going to go and switch gears, and we did talk about using this platform to leverage the roles of NSWOC and SWANs. So for our first set of talks regarding this particular domain, we will be joined by Jason Lau, who will talk to us about the impact of SWANs and NSWOCs in the community setting. So just to introduce Jason Lau, Jason is a dedicated NSWOC with extensive clinical and leadership experience in acute, community, and long-term care settings, holding a Bachelor of Science in Nursing from Toronto Metropolitan University and a Master of Science in Community Health from the University of Toronto. Jason has cultivated a robust skill set in wound care, ostomy management, and holistic patient support. In their current roles as an NSWOC at the VHA Home Healthcare, along with being a wound and ostomy care specialist at Toronto East Health Network, Jason is committed to delivering evidence-based, patient-centered care across a variety of settings. They excel in managing complex wounds, supporting individuals with new or existing stomas, and promoting independence and quality of life, thereby empowering patients to take an active role in their health. Without further ado, I'd like to bring in my colleague, Jason.
Hi, Josh. Can you hear me?
Hear you loud and clear.
Okay, thank you, everyone. Happy Friday. Very busy day, but happy to be here. So I'm going to discuss with you guys the impacts of NSWOCs and SWANs in the community. I am currently an NSWOC supporting VHA Home Healthcare, and I'm also at Michael Garron Hospital as their wound and ostomy nurse specialist. So I can kind of see the gaps, the deficits, what's working and what's not. So I'll just give you an insight. Okay, my next slide. I don't have any disclosures.
Jason, sorry to interrupt you there. Would you mind sharing your screen on your end?
Oh, yeah, sorry. Yeah, let me see. Let's do that. Okay.
There we go.
Josh, everything's good? All right. Sorry, I have a really, really antique desktop here, so I have to go easy on it until it gets replaced. So I don't have any disclosures. So as an NSWOC, when I'm in the community, it's interesting because when you follow with clients that have had support from an NSWOC, they will always remember them. I'm not sure. I think it's at that time where they're at a critical, vulnerable phase, and then they have someone that's established this rapport and supported them, and they will always remember them. Challenges, we don't have enough. They're constantly, every community agency is hiring for NSWOCs. There's plenty of jobs, but you know what? There's just not enough support. Uh, One of the reasons is it's a lot of work. It's a lot of paperwork. We're like investigators, detectives, because it's just so much work to have to dig through to find things. There's poor documentation. A lot of times when I get consults for the wound, I don't even know where the wound is. And then you have to kind of collaborate with the family and the patient to find times. And a lot of us, we can only do it in the evenings, and sometimes that doesn't always work, especially if they have PSW support. So it does take a lot, and I can see why a lot of NSWOCs find it really challenging to kind of manage in the community because it is a lot of work. So Ontario Health at Home, their role, is to coordinate in-home and community-based care, and it's for a referral process. So anyone can make a referral. Most of the referrals usually come from hospitals or through doctors' clinics or for family physicians. But even if you are a concerned neighbor, you notice someone that may not be managing well, you can contact the Ontario Health at Home and to refer to for a care coordinator to assess to see if there's any services that they need. So this past June 28th of this year, they changed their name. So previously they were the HCCSS, Home Community Care Support Services, which took us a few years to get used to. Prior to that was the LINS and then the CCAC. And over the last few years, they were really pushing for the community nursing clinic. It's a first approach. So across Ontario, we do have over 135 nursing clinics supporting Ontario, but I believe those numbers might be shrinking because I believe previously Ontario Health at Home has been subsidizing these clinics for a bit for their rent, but now I believe that may have stopped. So some of the clinics have shut down because most of them are operated by home care agencies to provide the services. So these clinics, predominantly a lot of wound care, compression therapy, antibiotic therapy, chemo disconnects, PICC line, portacath management, a lot of Foley catheter care. Lots of services they provide, and they're operated 365 days a year, usually from 8 a.m. to 8 p.m. So their goal is really to reduce unavoidable emergency visits. Now, the challenge is, especially from an OSCE perspective, a lot of patients are referred to there. These clinics don't usually keep supplies on hand. And when I've always seen some patients come for clients, and then we don't have the appliance to support them, and sometimes they don't even bring their own supplies. So it's a waste of a visit. And another challenge is a lot of the nurses at the clinics may not be able to support because they may not have the knowledge for ostomy bag changes. So that's a challenge. So the criteria for a nursing clinic nowadays is to have a palliative performance scale of less than 50, unless you're completely bedbound. Let me see. Severe dementia. As long as you're able to ambulate, kind of shift and transfer to a treatment bed, you're going to a clinic. It's very, very difficult. Doesn't matter how old you are, even if you're over 100. And it's unfortunate because I think these care corners need to really think of what is the purpose of the treatment and which environment is really susceptible for them. I honestly, it breaks my heart when I see a 103-year-old coming, simple traumatic wound, and then unfortunately they trip on their way and they develop more wounds, sustain new wounds, and then we have to manage that. Recently, I had a client and their spouse came. They were over 80. They knew no English. They spent about 3.5 hours trying to locate our clinic. And that was unfortunate because we were on the phones talking with strangers on the streets, trying to help them pinpoint where our clinic was. And I think that could have avoided if they just sent a nurse to their home. So that's unfortunate there. Okay. So the referral process this is a really, really common form. I think most of us have come across it. Nowadays, a lot of hospitals is done with the electronic e-referral, but this still does exist. Okay. So recently, this past September, we've had the equipment and supplies modernization, streamlined contract changes. So Bayshore Specialty now is overseeing most of the majority of the wound care, catheters, ostomy supplies. There was a significant reduction and removal of supplies from the formulary, which is unfortunate because there were certain things that we were accustomed to that are no longer existing. But they did add quite a few items to the formulary, and I'm quite happy with those, especially with some of the better antimicrobial dressings and antiseptic cleansers, which previously required either a medical order or authorization from the care coordinators, and that really took a lot of time to play phone tag going back and forth, and it really kind of discourages nurses because they just don't have a lot of time on hands because in between they're seeing their patients or their clients, and then they just have to manage, and this is unnecessary waste of time. So I'm glad that restriction has been lifted, but they do still limit the quantity, so we still have to be mindful of that. Okay, so these are the updated order forms for the wound care, urinary continence, ostomy supply form, and the negative pressure wound therapy. This is not all inclusive. There's actually quite a lot of items that are still on their actual regular formula that is not listed under these forms. So I'm not sure if they're going to update these forms. The clinics are also receiving back orders that they've ordered and were denied prior to the changeover. So we don't know if those products are actually still existing. So we have to wait and see, because to go back and forth, and when we talk with Bayshore, their representatives kind of don't have an idea. Sometimes the names are not what's listed on the form. It's just utter chaos. So there's also the negative pressure wound therapy form process, which is what you're supposed to do if you want a client or patient discharging from hospital to start on the negative pressure wound therapy. So you select, the size of the foam, or if you want the single-use disposable, that's completely fine. But this goes to the care corners, and what will happen is Kalia is still responsible for the Activac pump. So they'll send that. And then what happens is they actually don't send the foams or the track pads. And then what happens is the nurse has to order, and being at the clinic, it's just it delays the process. And sometimes we see these vacs delay up to 2 weeks. And then an issue is if a vac breaks down, or we had an issue where the electrical plug, the prongs were broken. We requested the replacement from Kalia. We heard nothing for a few days. We followed up. They said they needed authorization from the care corner. So we had to actually contact the care corner, who has to reach out to Kalia. So this process is definitely horrible. I remember they didn't have an Activac. They sent one of the single-use disposable vacs. And what happened was the trackpad with the foam has been on back order since July. So you send one piece but not the other. What was the point? It was a complete waste of time, and we just have a disposable vac that is useless, that we can't use because we just don't have the track pack and foam component. An issue with this form is that on the hospital e-referral forms, this is not embedded in it. So yeah, I think this particular process has to be looked at. And as per the Ontario Health at Home policy, in order for negative pressure wound therapy to exceed a month, actually they want a reassessment by NSWOC monthly. Okay, so if you've had any patients or clients that had to pay out of pocket for their supplies, they can get reimbursement. So there is a form on the Ontario Health at Home website where they can just fax, email, or even mail the form and the copies of the receipts, and they can get reimbursements if they were affected from the contract supply change issue, the shortages. Okay. So, in discussion about the SWANs, what I'm very happy about the SWANs are organizations are starting to invest. They are supporting the frontline nurses, especially RPNs that are considered kind of key opinion leaders or considered having, strong, evidence-based wound bed practices, that can carry on wound care best practices, and they're supporting them through this program. We're starting to see increased number of jobs. From the Ontario Health at Home perspective, that's still not there yet. Some of them don't even know what SWANs are. Some of them do know, but apparently they don't pay. So for those that have completed the SWAN programs, make sure you talk to your HR to let them know you've completed so they can kind of boost you up on your ladder ranking in terms of your pay, because you do have the specialized training, so you should be compensated hourly for it. We're seeing a lot of jobs looking for them because organizations in community and in long-term care, they want to build capacity and they need to. There's not enough NSWOCs to support, and a lot of these visiting nurses are just their practices is too weak. And one thing I always notice is the risk of contamination. You go in there, you see that one same pair of scissors sitting there that's sometimes covered in rust. They're probably using it to cut, their old bandages, and they're probably using it to cut a newly opened dressing. So I often encourage nurses, order a box of alcohol wipes, clean your scissors, order them. Ontario Health at Home, they limit you one pair of scissors per order, and now those are actually on back order as well. So it was a couple of weeks ago at a clinic that I was supporting, we were using paper towels. We had no gauze. We really had to use whatever we could. Some of the clients had to go purchasing maxi pads because we didn't have abdominal pads. We had no Mesor. So that was really tough. We had a client bringing Bounty paper towels because that's what they were using to manage the moisture. So it's been tough. Community nurses are strong. They're very resilient and they like to MacGyver a lot, and that's what they've been doing. A lot of the nurses have been, paying out of pocket to purchase things to support their clients because they feel bad. They feel horrible. And they're just ashamed of the quality of care that they're providing because they don't have the resources and supplies. So as an NSWOC, it's tough, but hopefully it'll get better. It'll take several months until things I think will streamline down. But we did lose a lot of super absorbent dressings that were quite useful, and then we were replaced with some. I know from an IPAC perspective, that's pretty good because they, less contamination, less leftovers, a lot of waste, but you're also generating a lot of waste, especially with these 4x4, 5x5 antimicrobial dressings that you're going to need probably a dozen, for certain wound beds. So that's been tough. Let's see what else is there that we can address. I think that's it on my end. Is there any questions or concerns? I'd like to open up the floor.
Thanks, Jason, for that. I'm just looking at the chat here, and no questions right now, but there's a lot of some comments that was presented here, and one by Carly Lindsay, and she mentioned that there are medical supplies as a few other vendors depending on the geography. In the southeast, we have OMS, and Carly did indicate here a couple of links regarding how to access some of these reformulary, as well as potentially the referral forms or negative pressure wound therapy. So check out the chat box for that. Vita Johnston also noted that She is the program lead for the Skin and Wellness Associate Nurse Program. And if any RN, RPN would like more information of the SWAN program and NSWOCs, or if NSWOCs would like more information about the SWAN role and the SWAN NSWOC team approach, please contact her at vjohnston@wocinstitute.ca. Carly also mentioned OMS and Bayshore also have order trackers, which are usually up to date. Okay. So Jason, I do have a few questions here, not seeing some questions on the chat box, but thank you so much for the valuable time that you have given to us and giving us some insight about your role in CCC in community, as well as the challenges that you present. It is sad that we are a first world country, but we still see such existing challenges that you can that could be detrimental to the lives and the outcomes of the wounds that our patient population experiences, our clients in the community. Now, you did mention about the increase in the uptake of the SWAN role. Can you kind of specify more where you have seen this in certain areas in your community practice?
Well, I know a lot of it's quite their role is still kind of being, I think organizations, they want them to build them to train their nurses. They want to kind of build a stronger evidence wound-based platform. But the challenge is it's how are they being compensated? Because, Ontario Health at Home is not going to pay for a SWAN to do an ET visit or an NSWOC visit. So that's something that we're looking at. And that's why I encourage them, they need to talk to their HR because to see how can they be utilized and if they can boost up because of their specialized training. But I also think that if a patient is referred to be followed up, especially for ostomy, if they haven't been assessed by an NSWOT or you think that they're struggling, on the referral, you have to make sure that an NSWOT assessment is required, or at least a SWAN, because what happens is they're going to be sent either to a clinic, which is not ideal because these client visits are slotted at 20 minutes apiece. And that's not an environment you want to be able to assess if a client can empty their bag, can properly clean their stoma, can apply the appliance. That can't be done in 20 minutes and to have education in. It should be done in their home environment. And that's something that I've always pushed for because you got to do it in their space where they're comfortable. And then you get to the clinic, where you're going to go? You're going to have to go with them to the public washroom to do it. It just does not make sense. Even for those that are vulnerable, susceptible to infection, especially those that are just so weak from chemo, it just doesn't make sense for this clinic first approach. It works for people that have a fixed schedule and can't wait around all day for a nurse to drop by, or those that are just very ambulatory, that don't need to drive. And quite often, the clients that go to the clinic usually don't adhere well because they're tired. Sometimes transportation issue, Wheel-Trans cancel them. They don't have a family member that can drive them. Or sometimes with these snowstorms or poor weather, what happens? Things deteriorate. So that's why I said push for, in your referrals to be seen by and supported by SWAN, especially for for complex wounds and for ostomy care.
Thanks, Jason. And one of the things that actually stood out for me when you were presenting is that you mentioned that sometimes for clients, for a reassessment of an NSWOC, it takes about a month on a monthly frequency. Is that correct?
Are you talking about for the VACs?
For reassessment of NSWOCs, you mentioned about
Well, that's what they require by Ontario Health at Home if they want to continue approving, because what happens is they may not approve for supply delivery of VACs if the NSWOC assessment is not done for negative pressure wound therapy.
Okay.
Yeah.
Because I find sometimes monthly is such a long time. The patients may probably, or clients may actually need to be seen more frequently than just monthly for those types of reasons. But thank you for sharing all those information. Are there other questions for Jason that our attendees would like to present? I'm just checking in the chat box here. There's a few comments here about other things, but not so much about a question. But thanks, Jason, for bringing us a whole load of challenges that you are experiencing in the community. And this is being recorded, so we will review we will review the content after the fact and really highlight some of these challenges and hopefully see where NSWOCC can come into place in terms of advocacy for future purposes, and hopefully we can address some of the issues that you have identified. Okay.
Thank you, Josh, and everyone.
Thank you. Very informative session. So Jason is our last presenter for this morning. So thanks, Jason, for your time. It is currently 11:40, 39 a.m. Our next presentation will happen at 12:30. So we'll give you guys adequate time for lunch for about 50 minutes, but please come back as soon as you can. We're going to start fresh and right on the spot at 12:30 for our next presenter. And I'll see you guys shortly. Thank you. All right, welcome back, everyone. Hope that everybody had an opportunity to have a great lunch and some time to take a break, stretch, and walk around and relieve some sources of pressure if you happen to be sitting the entire morning. So thank you once again for joining us wherever you are in Canada for this important NSWOCC Education Day. And now we're going to be starting our afternoon's session with a sponsored event by Hollister, looking at the context of ostomies, tackling pouching challenges, prevention and management of stomal and peristomal complications that will be presented to us by both Rosemary and Tarek. But before they do, I'd like to give them the honor of introducing themselves properly. So Rosemary Hill has been a nurse for over 35 years and is the recipient of the Award of Excellence in Practice and the Association of Registered Nurses of British Columbia. She works at Lionsgate Hospital as a nurse specialized in wound, ostomy, and incontinence. Her past volunteer activities include the role of president for Nurses Specialized in Wound, Ostomy, and Incontinence Canada between 2016 and 2018. As well, she participates as a member of the BC Provincial Skin and Wound Committee, chairs the Provincial Ostomy Committee, and is an expert speaker at national and international events. In September, she was honored with NSWOCC Award of 2024 from Ostomy Canada Society. Congratulations, Rosemary. Rosemary will be joined in by Tarek, Tarek Alam began his nursing career as a registered nurse in acute medicine and surgery at McGill University Health Center. He obtained the position of enterostomal therapy nurse clinician in 2000 and completed his training from the Canadian Enterostomal Therapy Association. Tarek joined Hollister Canada in 2008 and presently works as a senior clinical affairs manager. He completed a master's degree in clinical science in wound healing from the University of Western Ontario, and he is a former adjunct clinical professor at the University of Western Ontario in the wound healing program and currently lectures in the Department of Nursing at Dawson College in Montreal. So without further ado, over to Tarek and Rosemary.
Thank you so much, Joshua. Just a little disclaimer here, Rosemary Hill has received a remuneration for the work that she has done on this presentation. The objectives for today will be to describe the incidence and major types of peristomal skin complications. We'll explain the impact that these complications have on a person's quality of life and the time spent managing on these complications. And finally, we'll illustrate the management approaches to peristomal skin complications using a case study approach. What's amazing is that the literature tells us for up to 73% of people with an ostomy have a peristomal skin complication. And this is really a global issue, and it's not isolated just to one country. The literature also reports that some patients may not recognize that they have a peristomal skin complication. And as a matter of fact, less than 1 in 5 people with an ostomy seek treatment for a peristomal skin complication. So is this the new normal? No, we always tell our clients or our patients that the skin around the stoma should look identical to the skin on the alternate side of the abdomen. In other words, it should be free of redness and lesions, and that's not normal. We do know that stoma output can vary in nature and damage the peristomal skin when in contact. It contains moisture, which can lead to skin damage, and in some cases has digestive enzymes, which can lead to peristomal moisture related skin damage, or PMASD for short. This is the most common form of peristomal skin damage and can be related to poor fit, creating leak and skin damage. There's also another form of skin damage. Think of a person with an ostomy. Their always wearing some type of barrier, removing the barrier and reapplying the barrier. And what that does is it does strip off skin each time the barrier is removed. Sometimes this is daily, and sometimes this is more or less frequently. We hope to achieve greater wear times to minimize the disruption to the skin. Either way, peristomal skin is at risk from skin stripping, which can lead to peristomal medical adhesive related injury, otherwise known as P-MARSI. This in turn can lead to moisture loss through the skin, which is transepidermal water loss, or TEWL. There's a monetary aspect to peristomal skin complications, and it's quite a huge impact. And again, this is not isolated to Canada, but this is a global problem. Research conducted by Hollister with 456 ostomy nurses in 7 different countries revealed that the time these nurses spent on peristomal skin complications, whether you're in the community or in acute care, is astounding. It's about 50%. And as I've traveled across Canada over the last 2 years, I've asked many Canadian ostomy nurses and NSWOCC nurses about this, and they state that they spend easily 50% of their time managing peristomal skin complications. Peristomal skin complications have a profound negative impact on the quality of life for a person living with an ostomy. And 2 studies published by Nichols and Bell allow us to compare peristomal skin irritation to other disease states. Here we can see a person with a normal stoma, and they will rate their quality of life very similar to a person without a stoma who's in good, who has a good quality of health. However, what's really interesting is someone with a mild peristomal skin complication will rate their quality of life similarly to a woman who has their first recurrence of breast cancer. And in severe peristomal skin ulcers that you can see on the right-hand side, a person with an ostomy will rate their quality of life very similarly to a person who is in the hospital, going to a hospital to get kidney dialysis. So the take-home point is, we choose nursing as a career to make a difference in people's lives. And quality of life is just so important for a person with an ostomy. We have to do everything we can to try to minimize these occurrences from happening. When we look at peristomal skin complications, they can occur at any point in time after a person has had an operation for an ostomy. We can divide up a person's life journey with an ostomy into 4 distinct categories, and I'll go through each of these categories, and we'll use case studies to illustrate some of the potential problems that can arise during these problems. For example, the journey starts on day 1. As the person has an operation for an ostomy and who is in the operating room, it's at that point, as soon as the barrier is placed on, that leakage problems can occur. And what we can anticipate in the operative room is that abdomens look different. Their person's abdomen is flat when they're lying on the table. There may be distension if there's medical conditions that have created it. And hopefully a person has had stomach marking before, but we realize that's not always the case. And there can be some degree of edema after. So when we look at the evidence, there's some great evidence in there showing us that preoperative stomach marking should be considered the standard of care. We have agreement on that from the NSWOCC organization, the Urology Group of Canada, and also the colorectal surgeons. We do know that convexity should be considered in the immediate postoperative period to get a good leak and reduce the risk of leakage. And that is from a 2022 publication in JWOCN. So essentially, we can use convexity. There's different forms of convexity as soon as the stoma is created. I'll pass it on to Rosemary.
Thanks, Tarek. And I like you managing the slides, so I'll just say the word next for the next when I want to pass along to the next slide. Is that okay? This particular picture shows what I came across probably almost 2 years ago, where I was seeing constantly in the recovery room leakage on a newly created stoma. In this case, it was an ileostomy, and it was leaking, and the patient was awake, and he said, and he was quite concerned about this situation. And right at the get-go, it was, how can we change this? And I think getting called to the recovery room on a frequent basis made me begin to say, let's look at things differently. He had a fairly large BMI, and I knew right away his stoma needed some form of convexity. In this case, we use soft convexity. If we go to the next slide, back in January 2023, with a fair bit of background work before that in the December, began to then switch the appliance so that instead of it being that flat pouch, it would be a soft convexity that was applied to the patient's abdomen or to their stoma. And except, of course, in the instance where there was a rod and we had the suitable large pouching system for those who had a rod. But you know, what got me to this place of introducing it, and to this day, we continue to use soft convexity right in the intraoperative period. And I have to say, if I did a quick peek at Cerner and how many referrals I've had, even in the last year, for stoma leaking or ostomy leaking, it has been substantially reduced. And also, never mind leaking, but also peristomal skin damage. But what got me here was the next slide was I found that it often was with my urostomy patients. So the next slide, you'll see the stoma with the stents. And that was almost 100% of the time I was called into the recovery room. So my first thing, often when I do something new, I started out small, and I moved the urostomy, urology suite when they did ileoconduits, that they would always put them in soft convexity with a moldable ring, just a thin moldable ring. I saw the success of that, and that's what took me to January 2023 to introduce it for all fecal ostomies and urostomies, that we would immediately start with soft convexity. And you'll see by the next slide that I had the surgeon there, and when we put on the flange, he even said, oh, sort of helps the stoma pop out a little bit. And in that case, that gentleman had quite a high output, very thin effluent. And so it was really helpful that right at the get-go, we had that soft convexity, because we find that generally there's a tendency to leakage when you have high output or thin effluent. And you'll see on the next slide that sometimes our stomas are quite retracted, and you can appreciate that had there been a flat pouch used in that instance, it would have leaked. And so days later, I can look at that abdomen and see that it was beneficial to have the soft convexity because it wasn't leaking. So those are my, I want to impress to maybe think of that journey, think of it preventatively, think that you're doing something in anticipation that there might be a leak, but that you're starting that soft convexity right at the get-go. And we have moved all of our supplies on the shelf on the 6th floor surgery, but also in the central processing, which supplies the OR. We had to modify the physician's order, the surgeon's order sheets. Really wasn't too hard. And the gains for the patient, as you can imagine, they're not waking up and leaking. They're not thinking that their life with this new stoma is going to be having a leak, but rather there's a fairly good seal. Let's take the next slide. I had a chance to begin to share some of this work at conferences around starting with case studies with my urostomy cases, then fecal, and then ultimately I've moved it to the intraoperative phase where Tarek was talking about that journey from the intraoperative period. But now we'll move along to the postoperative period, and I'll let Tarek introduce us into that journey section.
Thanks so much, Rosemary. I mean, certainly, after surgery, the patient will be transferred onto the floor or the ward or after the recovery room. And this really marks the beginning of the postoperative period, which you can consider between 1 and 8 days. And leakage in the immediate postoperative period can cause numerous problems. Think of the person's quality of life, the effect on their mental state, and of course, leakage onto the fresh incision site under the postoperative dressing can certainly be a problem. We do know that in this period, we see people increasing their mobility, which is seen as positive. There can be some changes to the abdominal topography. The stoma size and shape may change in this first week as the edema begins to subside, and the stoma generally will become more active in the cases of an ileostomy or a colostomy. So these are the changes that we see. Again, when we look at the literature, we do know that a person with an ileostomy has a much, much higher chance of leakage and more likely to experience a peristomal skin complication. And interestingly enough, when we look at surveys done to people with a urostomy, up to 40% have stated that they've had a leak, at least once in the last month. Certainly, we do know that liquid or liquidy effluent can be an indicator of trying to get a better seal, and that often can be achieved by using some form of convexity.
So now we're going to get to the nitty-gritty and the interesting part of our presentation today, and Tarek and I wanted to share some case studies. We tried to group them into that journey, so we're going to look at a few case studies in that post-operative period, and then we'll also move to case studies in the next part when they're in the community. But this particular lady was 77 years old, and she had rectal cancer. And her journey begins by the surgeon in an emergency fashion having to create a colostomy. So you'll see that little colostomy on her left-hand side, but you'll notice that it's really retracted. It certainly is in a crease, and she's got valleys. But what happened was she later had midline dehiscence, but worse than that, the stoma, the bowel retracted, and stool began to come out of her midline incision in all 3 places. So all 3 places she had stool emerging. So what we thought we would do is well, let's try to, as you can imagine, it's hard to even get 3 different appliances on. So we thought, let's try and get one area cleaned up. We would irrigate it with an antimicrobial solution, pop an antimicrobial absorptive dressing in with a little bit of a stick of strip paste, and we would cover that up. And then, next slide, we began to look at pouching those 2 openings and using soft convexity. And we even tried to put her in a close-ended disposable bag for the midline, because lo and behold, you know what happened? The midline had more stool coming out of it than the colostomy. However, in the end of the day, it worked better to have a transparent pouch, so the nurses were alerted to her output from her midline. Next slide. And you'll see we did this technique where we used both a 2 3/4 and a 2 1/4, and then after we had them suitably prepared, we put the flange on, and then we would even hedge our bets by taking some strip paste, and or rather paste, ostomy paste, and we usually dampen the Q-tip, and which helps us guide where the paste was going to go around those open areas, because you can appreciate they're not protruding. They're lower than skin level. And we would actually get pretty reasonable wear time and protection of peristomal skin. Eventually, by the way, just, I don't think I have a picture there, but it was very helpful using that 4-inch ring. You saw that in the previous slide. Often that 4-inch ring helped provide some stability for the wound. Tara, can you just go back one slide? I just want to show them. There, that's our 4-inch moldable ring, which really protected the peri-wound area. Okay, we'll go back. And so eventually this lady actually continues to be cared for in long-term care, and we managed to actually get finally less output from the colostomy side, so she now just wears a cap on the colostomy side, but we continue to do 2-piece pouching on her midline incision. Just so you know that these people, although her situation is somewhat palliative, she's continually to do reasonably well. And many people said, well, can you not take her back to surgery? But the surgeons declined. In light of her situation, the nature of her illness, it was decided not to do surgery. And she continues to eat a normal diet and be cared for in a long-term care setting where one of our NSWOCs is looking after her and overseeing her fistula. Next slide. This is another very difficult case where a person had a perforated bowel with diverticulitis, very large abdominal wound. And you can see that wound is beautiful and granulating in, but guess what? You wouldn't know it, but there's a stoma in there. There is a stoma, a colostomy, and so there's a red arrow showing where the bowel is. You can imagine to try to pouch that, exceedingly difficult. So we did have her on TPN. We had some bowel rest. We worked feverishly on getting that wound healed. Next slide. And then finally, with that wound healed, now weeks later, we now have that. Now I'm looking at her stoma. As you can appreciate, it's really in a fold, in a tucked in little crease. And so I managed to do a little bit of a cyanoacrylate in the corner, because you can appreciate that's where stool would leak to. Again, love that 4-inch ring, a little bit of paste, and then of course used an oval, deep, soft convexity type of pouch. I had to get creative there. Next slide. I want to share with you, I had a lady with very large BMI, and the surgeon called me right afterwards and said, oh, Rosemary, it's very difficult to pull the bowel up to her skin. And within 24 hours, the stoma had retracted, and I had complete mucocutaneous separation. And I thought, what can we do? And this was very upsetting for her. She never imagined waking up to having a stoma. The surgeon, of course, told her it was a good possibility, but living a life in her mid-70s with a stoma, but yet worse yet, having it leak frequently. So I moved her immediately just into a 1-piece throwaway. Next slide. And to be honest, that is what we discharged her in, and that is what she stayed in. And in a way, it gave her, but I will say, normally you don't have to with a 1-piece close-ended, but I did use the accessory product just to help a seal. And virtually her stoma, her os, was a good 2.5–3 centimeters below skin level. But it meant you were changing it several times a day, and I thought to keep her fresh and clean, it just seemed easier to change her to a 1-piece throwaway. Sometimes with these patients, you have to get really creative. I want to take you, while we're talking about mucocutaneous separation, I want to take you to the next slide. And, the work I did starting in January 2023, I decided to take a look back 6 months later to say, as a result of using soft convexity in the OR, was I seeing any more mucocutaneous separation? Was that occurring? And I'm pleased to report that out of the 29 cases, when I look back, only one had that mucocutaneous separation, and that was the person with the large BMI, or actually within 24 hours, she had complete mucocutaneous separation, which the surgeon half anticipated, because as you know, it's so hard to bring the bowel plus the mesentery up to skin level, especially with somebody who has a large BMI. And so I managed to, because I think that's been often our fear when we look at introducing convexity, or in this case, soft convexity, right away in the intraoperative period, there's a concern, or has been from the past, that what if that will, add pressure to the mucocutaneous junction. But I'm pleased to report that we have not seen any of that in our patients that we have at Lionsgate. And so I had a chance to share that work both in Canada and the USA, and in Scotland at the World Conference, to share, just to encourage people to think about anticipating that potentially with some flat stomas, with situations that there might be leakage. So how about if we right away at the get-go start addressing potential for leakage? Now, Eric, let's take us, I'm going to hand it back over to you to our next journey, our next piece of the journey in the transition period.
Yeah, and certainly thanks, Rosemary. I mean, you've even gone to Japan to share some of this, and that was an amazing journey, because the clinicians in Japan were saying that leakage in the immediate post-operative period was a problem and could have devastating complications, and on the mental health too of a person. I think these cases and the posters and the research, it's so important, to share what we do as an NSWOC nurse. And the NSWOC conference is coming up. It'll be held in Montreal next year. We're really excited. I encourage all of you to think about, research topics that could potentially be presented as posters. It's just a fabulous experience to share, network, but also to optimize patient and client outcomes through the knowledge that we acquire at these conferences. Well, we do know that in the transition period, we're looking at a person who's now discharged from the hospital, either to a home or a intermediate type setting. It may be a residence. Abdominal topography continues to change. Creases may become more apparent. We do know that the stoma size in general will tend to decrease in size as time goes on for the first couple of weeks and even months. According to some research. There's more physical activity, which sometimes may lead to leakages if the pouching systems are suboptimal. And certainly support from home care resources and family members and NSWOC nurses is really critical to optimize a person's life. But when we look at the evidence and the research, again, there has been so much research published in the last couple of years. It's just amazing to see. We do know that, plain and simple, people with an ostomy who have a crease are much more likely to develop a peristomal skin complications. And flush stomas are a huge problem because leakage is also problematic here. Many surgeons do try to pull out the stoma, the intestine, to have it protrude, but it's not always possible, especially in loop stomas, where one of the portions may be at skin level, or unfortunately, due to different abdominal girths, may be impossible to pull it out. And in some cases, a person might have to go to the emergency room when they don't have other resources. And we know that in the emergency room, things don't always get better for a person with an ostomy because they just don't have that experience. So I'll pass it over to Rosemary to talk about some complications that can happen in this community type, in this transition period.
Yeah, Tarek, I'm going to go back to just what you were saying about the emergency room. I'm doing a new initiative right now. I feel lately we've had so many different staffing changes, and there's a nice fresh new group on, and particularly in our emergency department. And I had to reacquaint myself and saying, okay, what's on the shelf? What's going to make it easy? So I'm working with a clinician in the ER. We're changing what's on the shelf to make it simple, and we're creating an ABC. You know, in emergency, it's about ABCs: airway, breathing, circulation. I'm creating ABC on ostomy care because I go back, I felt for the girls this week. They really wanted to make a difference. But honestly, in their early training, they actually hadn't looked after somebody with an ostomy. They weren't sure. They weren't sure about the appliances. And it was just me feeling, okay, renewed efforts again to remind everybody about how to just, remove it. Number one, I guess it's not an A word, but it's remove it. So that I was talking with a clinician, don't forget if it's leaking, first start off, remove it, clean, and then I'm going to present them with a picture sequence and do a bit more talking and chatting. Because, you know, when the patients come into emergency, because you're right, Tarek, that's where they're coming because they're not really sure where to go to. And our resources are tight. And so I want them to have confidence in those emergency nurses who are doing their best. And so feel free, everybody on the call, check out with your emergency department as we go into the Christmas season to make sure that they have readily available. They know where their go-to products are, what they're going to do when they see a person leaking. No, the person often hasn't brought their own supplies in. So you're just going to put your hospital supplies in and make it work for them so they can feel clean, safe, and secure. Anyway, I'll have to report back to you, Tarek, on some of my findings as I do this in-servicing over the next few weeks. So getting back to mucocutaneous separation, there's many, many different ways to handle it, but I thought I would just throw this example. I recognize maybe on this virtual workshop today, we may have people who are very well seasoned in their ostomy practice, but there might be some people on the call who are relatively new and wonder, hey, what am I going to do when I have that separation from 12 o'clock to 6 o'clock? We do a variety of things. Sometimes we would clean it with an antimicrobial cleanser. We would fill it with a hydrofiber. Then we would cover it maybe with a hydrocolloid and then put a little bead of paste. But rather than saying all those words, I thought I would show you a picture sequence. So often mucocutaneous separation is beside wound dehiscence, which has drainage. So, and then I try to offset the flange so it doesn't sit right on that dehisced midline incision. So just a quick example, because we're talking, we want to keep going into those places where there's challenges. So we're going to be doing a deep dive further into ostomy challenges. So stay tuned. Tarek, take us back to the community.
Yeah, thanks so much, Rosemary. You know, after about a month, people are getting back into their lifestyle. Before they had ostomy surgery, maintaining a good seal and optimizing skin health is really paramount to having a good quality of life while living with an ostomy. And we do see that people, again, are becoming more active and weight gain can happen. In some cases, weight gain loss can happen too, but more often the person will gain weight because it's after surgery. They may be feeling better in terms of health and overall well-being. You know, leakage is not normal, and when leakage happens, it can be really problematic and can have a devastating consequence on a person's well-being and quality of life. And it costs money, pure and simple. It costs money to the person with an ostomy, time off of work in some cases. But one of the other complications that we've seen is peristomal hernias. And, you know, I was fortunate to work on the task force that published the best practice recommendations for prevention management of peristomal hernias. And I encourage all of you to look at that at some point in time because it gives really useful tips and tricks. Essentially saying that, you know, if you have a peristomal hernia, there's a whole bunch of things that can be done. But in terms of leakage, if you need convexity, choose a form of convexity that is softer. In other words, a flat barrier with a ring or a soft convex type barrier. are really optimal choices when convexity is needed in a person with a peristomal hernia. Rosemary, take it away.
You know, something that I'm finding is so often the patient presents in those early days of being home and they're trying to get back to their usual lifestyle, but they're leaking. They're leaking sometimes daily, several times a day, and they'll present themselves to my outpatient clinic, and I'll take down, always number one, take down the flange, have a look and see what is the story. What's the story on the flange? And you can see the leakage. But now, more importantly, take your vision to the stoma, and particularly those loops. That distal lumen often is at skin level, and yet the person arrives in a flat barrier. And so one of the most simple techniques is to clean it and say, you know what, this is going to be, we're going to keep you in this familiar system, but we're just going to change the shape of the flange you're using. And so I'll introduce soft convexity. So always be aware of that distal lumen, or know, is this an end ileostomy or is it a loop? And then explain to the patient, it's fine that it's a loop, but we have to realize that the opening sometimes has mucus coming out, and so therefore we need to pouch to the lowest common denominator, or to pouch to that which is at skin level, which generally soft convexity can help. Sometimes, next slide, you get a situation, and it often can occur with loop ostomies, you get a prolapse. And so this gentleman presented saying, Rosemary, also, you can see he has a hernia. He said, I'm really got a bit of a situation here. What should I do? And so a couple of things. Some of our newer nurses think we need to call the surgeon stat. But no, actually, you can see that bowel is well perfused. So that's the first thing we want to reassure the patient. You've got some really nice, healthy bowel. When we get worried is if that bowel was changing color. But what I found worked for this gentleman with his hernia, next slide, was to move him to a pouch that was larger. Because you see, in a way, I needed a pouch that could house his prolapse, because he was not eligible for surgery right away. And so in the short term, we had to figure out how he could have something that would hold effluent, but also hold his significant prolapse. And we ended up using a high output pouch that worked fabulous for him. And so I just want you to entertain that as a notion when you're dealing with prolapse. And of course, did use some extra barrier strips to help support the one-piece drainable pouch on him, and always making sure to put those strips on, or to put the pouch on, when the hernia is pronounced. So I would teach the patient, you know what, when you put your pouch on, I want you to put it on not when you're lying down, but when you're standing up, so that so that they won't have epidermal stripping. Next slide. We're going to go into a new topic area, and that is around when you see unusual growths. I had this lady come to me. She was always a faithful 2-piece, 2 1/4 soft convexity user. She was experiencing leaks and bleeding and noticing changes. So when I saw her stoma and I saw the various polyps, I said, "Oh, this is considerably more than usual." And she had, of course, a history of familial adenomatous polyposis, FAP, as many of you have heard of that. And her dad had passed away when he was 30 of FAP. So what I did was I took pictures with her permission, sent it to her surgeon. And he said, well, we'll certainly deal with that. And you can see she had surgery. He removed that area, but you know, during that time, they were like wounds. And I really didn't know how those wounds, it was like burns where he had removed all the polyps. So I moved her into the same appliance, but only bigger. So I kept her in a 2 3/4 soft convexity. Next slide. And you'll see some of the healing that happens as from where it was removed to the point in February it healed. But here is the takeaway, most importantly. And her surgeon was kind of, surprised, and so, to tell her that actually those polyps, some of them, were an invasive adenocarcinoma. And that was quite concerning. I'll never forget when she phoned me to say, Rosemary, those polyps, there was actually cancer. So that ended up having her have further diagnostics where they did discover a 6-centimeter duodenal ulcer, where she ended up having a Whipple procedure. And to this day, I'm pleased to report to you, she is doing very well. She's at home, has had the surgery in the summer, and is doing well. So my take-home point to you is not to just dismiss when a patient says they have unusual findings. Next slide, Tarek. Is I had another patient who has Gardner's syndrome, which actually is a subtype of FAP. And it's, again, an autosomal dominant form of polyposis. Again, she said, Rosemary, I'm just having bleeding, and they're kind of growing. Sure enough, I looked at her sizing. She was cutting it very small. Changed the size, notified her surgeon or her gastroenterologist. And just about a week and a bit ago, she's had an ileoscopy performed. There were some difficulties. There was stenosis, and we're waiting for biopsies. So again, when you see these unusual growths, immediately get them back involved with their either their gastroenterologist or their surgeon for further investigations. Next slide. Yeah, I did just in the short term, did some work with silver nitrate, but also most importantly, you see so often patients, when they're having leakage, they think, aha, I know what I'm going to do. I'm going to go smaller. Well, all that did was provoke more bleeding because there was more trauma around her where the polyps were. So I presented her with a new template. Next slide. This is your case, Tarek.
Yeah, thanks so much, Rosemary. Well, detective work is part of an NSWOC's job, and this is an interesting case. This is a 47-year-old male who came to see me when I was in clinical practice. He had a history of Crohn's disease, and he was complaining of persistent leakage. That's all the information we had from him on the message. He came in, and on examination, we saw many nodules. The actual ostomy was about centered here and covered with numerous nodules. There was skin stripping from repeated barrier changes due to the leakage. And he had mentioned that these nodules had started to appear over 6 months and were treated in the community as hypergranulation tissue. This is a very atypical presentation for a person with a colostomy to have increasing nodules. So again, referral is really, really important. We called his gastroenterologist, who came up to see him right away. He was in the hospital, and it was interesting, but this was actually a reactivation, exacerbation of the Crohn's disease, the underlying cause. And the gastroenterologist put this gentleman on immunomodulating type medication used for Crohn's disease. The way we managed this was using actually a 4-inch ring was a lifesaver. We made the opening of the size of the stoma, and then the 4-inch barrier covered pretty much everything else. And that really gave an amazing seal over all the irregular surface of the nodules. A flat barrier was used over that with a belt to add a bit of pressure onwards. And lo and behold, over 6 months, this did completely resolve. So it just shows the importance of, as in Rosemary's cases, doing a bit of detective work and consulting other colleagues, when needed. Peristomal ulcers still is a problem today, especially with the high incidence of peristomal hernias. And this is an example of a lady who had developed a peristomal ulcer, and she had no idea how it started, but she was using firm convexity, but she developed a peristomal hernia. And of course, the pressure of the hernia with the firm barrier caused an ulcer. So this was treated initially with an absorptive alginate dressing covered with an extra thin hydrocolloid. And then once the wounds began to fill in, we were able to migrate just with the hydrocolloid. And this creates a flat pouching surface. Different products can be used, but these are really ideal for many cases. And then you can see we got with a barrier ring, over it just to get a bit of a better seal. We were able to achieve complete healing in this case. I'll pass it on to Rosemary for a complex peristomal ulcer case.
Yeah, I tried to throw quite a few images here on this slide, but I had this lady come down from a very rural spot of British Columbia, and when she arrived, had to just start from the beginning, and she presented with fairly deep peristomal ulcers. In fact, the one even at around 11 o'clock, literally there was a hole there. But I want you to know the key thing was when I looked at her pouching system, her sizing was just for the stoma, but not how the mucosal had spread. Do you see at 3 o'clock? There's sort of like a triangle. And so the first thing I had to do was modify her pouching so that we incorporated the mucosa, her whole stoma, versus just a portion of her stoma, because that's probably why she was having leaks. And then got a little bit creative. I did throw some special collagen type dressings in each area, used a bit of methylene blue, gentian violet, then a ring, and those had an antimicrobial element, but you can see that as in the days and weeks ahead, how it cleared up quite nicely with that dressing. But you got to remember first to address the size. What size was she using in terms of her opening on her pouching system? Next slide. Again, a gentleman presented with another prolapse, and again chatted with him about the color, the changes, what to look for. In that instance, we had more success still with a large high output bag, but again, I do reach for that 4-inch ring where I just taught him simply how to roll back the 4-inch ring, and it did seem to offer additional stability to the flange, and yet gave some, sufficient opening to accommodate his prolapse. Prolapses can be tricky, and they're very kind of frightening for the patient when they first happen. But in general, I see it mostly on loop stomas. Next slide. I wanted to show you this quick example of when somebody has wrinkles. And just to remind you, always a good idea, the importance of lifting up the skin, teaching the patient that before you put the appliance on. Generally, you're going to need some convexity and maybe even a little bit of a filler to that valley, and maybe a belt. So there's some strategies you do, but I just thought it was a beautiful example of, don't forget, you've got to lift the skin up when you're putting your flange down. Next slide. And then sometimes we come across maceration. I usually see this in a particular person with a urostomy, where the urine has just made that area really wet and boggy. And again, you can see how the whole stoma area is sort of a little bit retracted in a bit of a shallow valley. So again, had to deal with that maceration. And I did tend to use a cyanoacrylate first. There's lots of ways you can begin to help deal with that macerated skin, and then deal with the underlying problem and add some soft convexity versus a flat barrier. Next slide. So this is another case I can't get over how many times I see incorrect sizing. And this lady had been quite a while, but do you see the big opening here? I don't know if you can see my cursor, but she's got a really large opening, and yet her stoma was just that size. And so again, had to teach her the new size. But here's another case where the person, again leaking, said, no, I just kept making it smaller and smaller. Gosh, quite frankly, I don't know how. You see the cutting of their templates are below, but sometimes it's not even so much moving them out of a different product, but just looking at sizing. I can't emphasize that much. Or the placement. Look at that urostomy. When this person came in and said, Rosemary, I keep having leaks, but look at that. Their little stoma is just peeking out outside the opening. So it's so good to have a look at the patient. And sometimes it's difficult over the phone. So when you have the ability to see the patient, either through telehealth or in your clinic, so much better, because you learn what's been going on and getting the details. When are the leaks happening, at night or during the day? Next slide, I had a case where I had a person with some intermittent high output, and you can see not a great stoma, not a great stoma at all. And so again, had to choose a soft convexity where she's been fairly successful with soft convexity, a moldable ring, but then using a high output pouch. And that has managed her intermittent. She sometimes tends to have some blockages and then suddenly gushes of output. And we switched her to the high output pouch, which she's able to use the tap. I know we're coming to the end, so I just want to go to the last case where I had a person, although it's on the left-hand side, it is an ileostomy, nasty peristomal skin damage, and you can see why. The os is tilted downwards. She has a little dip. And so again, had to look at what appliances she was using and move them to some form of convexity. But first of all, treating the peristomal skin with, in this case, you can see it was a cyanoacrylate, but do you see how days later that skin is recovering? And now we can begin to do suitable pouching to that stoma that is sort of tilted, flat, and in a crease, at a belt, all of those things. Tarek, anything else? I think we've got some references.
Yeah, thanks so much, Rosemary. I mean, looking at the objectives and what we've done today, we've described the incidence of major types of peristomal skin complications. We've explained the impact on a person's quality of life, and we've illustrated the management of common approaches to these peristomal skin complications using a case-based approach. If anyone would like the references, it'll be a pleasure. Please contact me. My email is tarek.allam@hollister.com. Just wanted to announce some exciting news that the Ontario Health at Home provincial formulary that was officially launched in September 2024 has provided access to material. And we're pleased to share that the updated formulary now includes Hollister products featuring our latest innovations, including SeraPlus technology and soft convexity solutions. Additionally, we're in the final stages of adding the two-piece soft convex and the one-piece high output pouch products to the formulary. In the meantime, the one-piece soft convex product is readily available on the OHAH list. And if you'd like a copy of these forms, please get in touch with your Hollister representative, and it'll be a pleasure to get you that information. We'll take some questions. There is a question in the chat box. If you'd like to fill out an evaluation form, please use the QR code to scan and fill out a brief evaluation. It's really important for us to get some feedback about this session today. We're always looking to bring out interesting lectures and to always do a better job the next time around and improve on things. I'd like to, while you're doing that, take one question. There was a question here. Hi, Rosemary. Wondering about mucocutaneous separation, the case that you used the one piece with the barrier material. How did you justify the extra cost and the need for pouch changes? In Ontario, we can only access $970 per year, which will not cover costs of this particular treatment plan. Would you also not consider using some type of convexity to help with stoma protrusion when healing?
Absolutely. In this case, the person had funds, and so she wanted the simplest approach. She also had dexterity issues. So in her case, you're absolutely right, finances weren't an issue. I have had other cases where finances are an issue. In British Columbia, our funding is different. It's based on people's income level through Fair Pharmacare. And actually what I have done is, yes, I've absolutely reached for typically deep, soft, convexity, drainable. And that it keeps the price point down with a belt. And even so that is a preferable route. But it's all about individualizing our care and where that person's at. This person had arthritis and was mobility challenged. She was in a scooter. So going to the one-piece throwaway was, of course, much preferable, and she could afford it. But absolutely, not everybody is in that scenario. And so drainable, deep, soft convexity, and there's a number of products on the marketplace right now that have that with taps or outlets that are easy to work with. And so that would be my approach. And absolutely, I would definitely use convexity. It seems to work better than just going flat drainable. And accessory products. So I would use accessory products like a moldable ring, deep, soft, convexity, and a belt. And I might even maybe have to use extenders.
And it's an interesting question, can you use convexity on mucocutaneous separation? Actually, in 2019, Louise Tremblay, an experienced NSWOC nurse, actually had a poster showing when she had stomal mucocutaneous separation in the hospital environment, she would actually use convexity to drive the skin down, and over a period of days to a week or two, that would actually be highly beneficial because it would pop the stoma out, and the stoma would actually heal in a position more protruded than before. So very, very interesting. And we do know that it is generally safe to use and even beneficial to use convexity and different kinds of convexity when there's mucocutaneous separation. Joshua, any comments or any questions?
Yes, Tarek and Rosemary. Before I do my comments and feedback, there is a comment and a question here from Wesley that, according to the person, is thank you so much for the great presentation. I wonder how long that can take to fix a peristomal skin for damage.
That's a great question. And I think sometimes I tend to, Joshua, depending on the nature of it, I step up the changes. So if I can get it like it's just one particular area, I step it up to Q48 so that I get attention to that wound, like I treat it like a wound. And if you're in a place where the resources are such that you can do it every 2 days, I do that, and then stretch it out to 3 days, 4. Sometimes, Joshua, in those early days when you've got some multiple deep ulcers, you got to go daily. You got to go daily because if you got a deep, large peristomal ulcer, there's a lot of wound drainage, and just like our wounds, you've lost the balance with moisture. But I usually tend to rinse them with something antimicrobial. So I give them a good cleanse, then saline, and then I begin my care.
Awesome. So Tarek and Rosemary, I can't really thank you guys enough for this incredible presentation. When I reach out to both of you and ask about complex colostomy cases, you just went above and beyond. So this is quite a treat. I like the fact how you guys kind of walk us through the entire journey of a patient from the surgical intraoperative phase all the way down to being in the community and seeing how all these types of peristomal complications can occur and the likelihood of the need for us for a soft convexity and initially introducing it at the get-go to ensure that we can avoid any type of peristomal skin damage. So highly appreciate. Thank you very much for this incredible presentation.
Hey, thank you, Joshua, for just you and Kathy Harley for setting up this day, and Troy for managing all the tech stuff in the background. So thank you to the team.
Thank you.
Thank you. Okay, on to our program now, switching gears again to highlighting the role of NSWOC in rehab. I have requested a colleague of mine, Carol McAnuff, to do a presentation for us about the impacts of NSWOCs in the rehab setting. So Carol, professionally, she has an NSWOC certificate and she holds a master's in nursing and currently works as a clinical nurse specialist in a spinal cord program where she has an interest in wound, ostomy, and continence. She's a solution-focused dynamic healthcare leader known for collaborative approach, advocacy for her diverse patient population, and strategic thinking, and is dubbed the PIP conveyor. She has demonstrated expertise in professional practice and is committed to enhancing the patient experience and outcomes through continuous quality improvement, education, and mentorship. And now I'm going to pass it on to Carol.
Can you hear me, Josh? Just a test.
Carol, we can hear you, but can you
My camera is not working. I've struggled with it all morning, but can you hear me?
we can hear you.
Wonderful. Thank you so much. And I am going to share my screen.
We can see your screen, Carol. You just have to click on these.
Yes, I'm going to do the
Awesome.
thank you so much. How is that?
It's perfect. Thank you.
Okay, great. Thank you. I just want to thank you, Josh, and thank you to the NSWOCC organization for having me here today. And I also want to thank the speakers before me. That was very informative and educational as we hear from our very own NSWOCC community. So as I was asked today to present on the NSWOC's impact in rehab, and that will be my goal today. So I'll move on to share my objective. And again, the objective is to share some experiences of how my role as an NSWOC have impacted the rehab setting where I work. So before I continue on, I just want to, for those of you who may not be familiar with Toronto, to have an idea of the organization that I work for. So I work with UHN, which is a University Health Network. It's quite a big network, as you could see here. We have two acute care centers. There's the Toronto General Hospitals. And for those of you who were on the meeting this morning, Deborah is one of her nurses who also works at Toronto General Hospital and Toronto Western. And we have the Cancer Care Center as well, which is a Princess Margaret Hospital, and our education institution, which is the Missioner Institute. Now to our rehab sections, we have approximately 7 or more rehabilitation centers. Recently, West Park joined our institutions. So moving across here, as you can see, the lakeside is the long-term care, the E-Bickle Center, that's where my colleague Josh works, and Toronto Rehab. And if you move to the bottom of the screen, Lyndhurst in that little corner, that is where I work. And my neighbors are the Cardiac Center and the Neuro Center. So just to give you a bit of the background. And in terms of my program, which is the, sorry, let me see if I could get this down more. In terms of, are you able to still see my slide, Josh? Hopefully so.
Yes,
So
I-
in terms of the program overview, we're located in the Midtown Toronto area. We are a regional spinal cord program, and we do have 60 beds. However, recent months, we have downsized to 54 beds. We have a mixture of traumatic and non-traumatic spinal cord injuries, and our average age is an adult population, housing patients from 18 years and above. There's at times that we have had patients younger than 18 years old. And the length of stay is between 21 to 90 days, average days about 59 days. And we do have 3 inpatient units, all our spinal cord injury units. And we do have 7 outpatient clinics that includes a skin and wound clinic as well. So in terms of the wounds that I see, just to give you an idea, as you could see, predominantly there are a lot of pressure injuries, sometimes multiple pressure injuries on one patient. We do see a fair bit of surgical dehiscence, some trauma wounds, but just to kind of set the landscape here to let you know that I do focus and support a lot of work around pressure injuries. So to also give you a bit of a background with the how the NSWOC was introduced into rehab. So many years ago, so prior to 2016, there was no NSWOC in the rehab program at Lyndhurst, which is the spinal cord program I'm referring to. So years of advocacy from one of her colleagues who was an NSWOC in the clinic, from nurses, that did not go too far. Anyway, years later, it was impossible for the leaders to ignore the calling because as it related to patient safety. So now the doctors were really being the whistleblowers and seeing some of the issues in practice. So some of the practice gaps, some of those were wounds. And let me just back up here. So back in those days, lenders did not accept patients who had a pressure injury that was greater than a stage 2. However, within the program, they were noticing wounds that were worsening, wounds that were not healing. And there was at one point where a patient had gotten maggots in his wound, not intentional treatment, but unfortunate treatment. And this was when the physicians really became serious and gathered all the information together and went to leadership. So of course they could not ignore the calling. So in 2016, a contract position for a CNS with a wound ostomy incontinence background was developed and it was executed, and noted it was on contract. So once, and of course, the lucky candidate was myself, I was happy to be part of the organization, to have such people who are already advocating for an NSWOC. So months later, I would say within 6 months into the program, we presented a briefing to the leadership, and many letters and conversations from the team. And of course, they hired myself. And this picture is to illustrate, so the very year, that was March 2016, there was a retreat, and this excerpt was actually taken from the retreat to kind of highlight the work that was happening with the introduction of the NSWOCC CNS. So I was very happy to already have support going into the program. So nothing but success. So some of the impacts, and it would take an entire day to talk about all the stories. So I've tried to summarize it as best as I could. And because I'm a CNS clinical nurse specialist, I'm going to kind of categorize some of the findings using the CNA framework. So under clinical care, as we highlighted here, I do a lot of assessment, a lot of development of and evaluation of plan of care. So basically assessing from the ground up, assessing with the team, developing that plan of care with the patient. So I preach this all the time, that the patient must be first and foremost be part of that plan of care. Otherwise it will not be successful. So making sure that is our standard of practice. Identifying the goals of the wound with the patient as well, because if you have a wound, say a stage 2 pressure injury, and I know I'm preaching to the converted here, that is healable, but this patient is not going to be adhering to the recommendations. You know, we have to basically establish if our goal would be healing or maintenance. In terms of my role as an NSWOC clinical nurse specialist, there are times where I have to intervene in other complex and unpredictable clinical management, maybe not related to wound, but maybe indirectly related to the wound, looking at the whole picture of the patient or using a holistic approach. Also as a consultant, I am the consultant for the patient, for the caregivers, for my community partners, for my nurses, for my allied health physician, and the entire team. We work together, we hold each other hands. And as I mentioned before, they were already embracing the role before I got there. They knew the need of this role and they were desperate. So having me there, they really just gravitate to having an NSWOC. And the picture that I'm sharing with you, this was a story that was published, and some of you may have recognize this photo from maybe the hospital news or through Wounds Canada. Joshua, my colleague here, and myself, we did a story about the importance of patient education around pressure injury prevention. So in moving forward, looking on their system leadership, what it is I do to support this as an NSWOC, and somebody mentioned it earlier, we are change agents. We're grounded in change, right? And leading initiatives is so important for us to do. We are always front and center, and I find myself always front and center in and leading many initiatives in my program, because again, I'm the only CNS, I'm the only NSWOC in that program, and also influence in practice and always advocating. So here I have a photo on the screen. This was back in, I want to say in 2016, when UHN, through initiative called Caring Safely, was recognizing pressure injury as one of the hospital-acquired conditions that should be a never event. So part of my role as a system leader or a leader as an NSWOC was to make sure that all of these bundles were implemented and sustained. Today, this lives on our huddle boards. So staff who are new, staff who are current, are always having this as the forefront. And this at times is reference to during our safety huddles, which happen every morning. In terms of a leader, you also have to lead change, lead things to, or initiatives to educate the public, educate our patient. And this picture is just a depiction of that when we had our Pressure Injury Awareness Day at Lyndhurst. And this captured over, I think it was over 100 participants who came to the table for information, for advice, and just to have a sense of what we were about, what it is we, the news that we were spreading and the information that we were providing. In terms of advancing our nursing practice, I've provided leadership around skin health as a resource, as a facilitator, as a role model, and as an advocacy. And I can't stress enough how important it is for we to be role models and for us to be the greatest advocate for the care of our patient around skin health, and again, around just this holistic approach to patients. So even though we went in to assess the wound and we noticed other system issues in terms of organs or symptoms presentation, it's also important to advocate for the care of those symptoms as well. And in terms of the role model, it also influences your nurses to be thinking of getting higher education, looking towards motivation into advancing their knowledge in wound care, and maybe eventually taking some of our NSWOC courses, whether there be RPNs or nurses who are moving into becoming an NSWOC. So fostering educational development by promoting best practices that are evidence-based, this is what I live by. We do use the Canadian best practice for pressure injury prevention and the RNAO best practice and other research that is compatible with our practice. And from using the learning theory and recognizing that, adults are motivated when the information is relevant to their practice. And when it is, concise and put some interest in them. What was born from, thinking and using the adult theory was one of her education sessions that I've given the name is Let's Talk Skin Health. So every time somebody would hear this, Let's Talk Skin Health, they know what's happening. They know there's going to be an education session. That session probably won't be more than a half an hour. So we try to make it as succinct as possible and also bringing it to the nurses. So respecting their time. I know someone earlier mentioned how stressed and overburdened and overworked nurses are in today's work. So also respecting that. For example, so this photo was was taken at one of her sessions, and within the session, I can tell you it's a representative of PSWs, nurses, and there is a PCC who was actually part of this education session as well. So again, just motivating the nurses to seek advanced wound care education is key with our NSWOCC role. In terms of education and research, have I made an impact in that? Maybe I have done so with leading many product evaluation. One recent one was looking at and this was not solely my working alone, but working with my group as I collaborate across with my colleagues across UHN, but looking at our wound hygiene product. So we're now using I must say hypochlorous acid without putting a name to it. So that was one of our recent evaluation. Another one was evaluating the turn and reposition system as we were struggling with repositioning some of our patients who were on the bariatric side or their injury was so high, so they was quadriplegic, so very difficult to reposition them. And if they had pain in their shoulders or wherever the pain was such a challenge for the team. So that was another one that was very successful. In terms of research, I have never led a research. I'm not a principal investigator, but I have participated in a few research projects. One was looking at a more a specific or more a risk assessment with more specificity for the spinal cord patient population, as we're currently using the Braden, but we know that's not specific enough. So I've worked on a project and right now it's still under review. So hopefully that will be coming out soon. It's been, I think, 2 years now. And in maybe further or earlier next year, we'll be participating in another research that will be looking at frequency of repositioning using sensors with researchers from the Kite Institute, as they will be looking at our patient population, looking at the surfaces to see if there should be a different recommendation in terms of every 2 hours, every 3 hours, or is it every hour to reposition some of our patients? So in terms of technology, research, and just making sure that we're current in our practice. So these are some of the modalities that I have supported and continue to support and continue to provide education for our patients and our nurses. So in summary, collaboration with leaders in wound care industry to support best practice is forefront, collaborating with our UHN clinical wound care team, who I cannot work without, is so important. So I thank them for helping me make an impact in the rehab sector. And also supporting our conferences. So for those of you who are currently on the line and would like to attend our UHN conference, which will be held in February 28, 2025, please do so. Reach out to Josh. He could provide the information. And the other important thing is I have done a lot of participation in and structured patient and family education around skin health. And I think we are coming to time. So I just want to really wrap up and to present some more of her highlights. 4 to 5 nurses have completed their NSWOC since I started in 2016, so there's got to be some motivation. I know one might be currently, actually 2 is currently on the line right now, and we have 2 RPNs enrolled in the SWAN program. Managers are currently encouraging PSWs to take the NSWOC PSW course, so there's a lot of motivation and encouragement happening, and the practice have improved. Is there work to be done? Yes, there's still more work to be done, but the fact that nurses are taking the initiative to write their own medical directive, to escalate wound care issues, it has made me proud. And nurses have expressed being confident in articulating and escalating wound concern without reaching out to me, but knowing exactly what to advise the doctor about if I'm not on site. And then the other thing I'd like to say is that our incident report around any skin issues have improved. And we continue to encourage that. They're not always a negative, but very happy to see that. And there has been decrease for patients to be transferred out to the acute care. There's been more urgent delivery with IV initiation on site. And I should just back up and say, as a NSWOC clinical nurse specialist in a rehab program, you do have to have some type, if you don't have another clinical nurse specialist, you have to have skills around medical surgical skills. So those skills that you've had prior to doing your NSWOC, whether you work in eMERGE, whether you were an ICU patient, or as long as you do have some med surgical skills, that was important. It was important for my role, as when I started, I was the individual that was doing all the IV starts, the ECGs, the blood works, and making sure that the patients were able to have an IV antibiotics on site versus transferring out. So that actually built the confidence with the doctors, and they became more comfortable of initiating orders for IVs when they reach out to the ID department. And then I think more profoundly is that our leaders are aware of the current state of the wounds. They have, and I don't know how my director did it, but she has found money or funds to improve care. She has donated funds towards equipment. We now have 100% therapeutic mattresses. And I'm so proud to say this. The turn and reposition system, again, that was supported by her. And I know earlier Josh mentioned that I'm a convener for PIP huddles, and that is just once there is a report or an incident completed by a nurse about any skincare huddle, it is my absolute duty to gather everyone together to talk about it, to see what the insults are, and to see the plan, and then go to that patient to also hear their story, and then formulate a plan with the involvement of that patient in the center. And in summary, just the respect from the peoples, and when I say the people, everyone in care, from the patients to the caregivers to the director to my colleagues. It's very rewarding. The fact that you're appreciated, that makes you want to work, even when you're not at work, you still want to see what's happening. So, which it might not be a good practice, but it's just motivate you. And the fact that you're trusted with decision making, as families or our staff are seeing that there's an improvement, or knowing your style when you said, oh, if the wound looks like this is what we should do. Reaching out to you and telling the doctor, if you're not there, this is what Carol would recommend. What do you think? And and you get back and they're saying, all I could hear is this is what Carol would recommend. So just having that. So it's rewarding. The other thing about trusted with decision making, I just want to shout out to our boss here today. She's the director of nursing, and she is so supportive of the work that we do, so much so that for the 2024-2025 goals, pressure injury prevention is part of that. So seeing how much interest she takes in skin and wound or skin health is so important. And once you have a leader who has the interest in skin and wound, you're going to get what you need, and you're going to always feel appreciated, and you're going to feel that you are impactful to the people you serve. And also just building the confidence of the nurses. So I want to thank you. I hope I didn't go over time, and I'm still trying to get my camera on. Sorry.
Well, thanks,
Any
Carol.
questions? You're
That
welcome.
was amazing.
Thank you.
I'm looking at the chat. There are no current questions there, but I do have a few questions for you,
Yes.
if I can ask them.
Yes.
First and foremost, thank you for highlighting the crucial role of NSWOCs in the rehab setting. When I was listening to you, you were actually throwing me the word advocacy, and that has brought in the role of NSWOC in the rehab setting. At the same time, you as a person have been advocating for your clients and for your patients for their specialized needs to ensure that they have the appropriate care that that they receive at the time that they need it. So thank you for being such a great advocate. You're emanating what NSWOC, the principles of NSWOC should be. And so thank you for being a good role model for that context. I like how you align your role in the sense of the CNA pillars of advanced nursing practice. So thank you for that. That gives us a different perspective of the complexity and comprehensiveness of the NSWOC role in different sectors of care. Now, again, jumping back to my question is, being that you are the only NSWOC in the rehab setting that you are at, are there any present challenges that you're experiencing that you wish could have been addressed, that could be improved, that can better provide, care for the patients, and that can also enable you to fulfill your role in a better manner?
Oh, yes. Thank you for your question, Josh. There's a few components in it. I'll start by the challenges. So being challenged to be the only NSWOC, which is changing. As you know, we do have our NP colleague who is really supporting and will be there. But say we took her out of the equation, it would have been amazing to have another NSWOC in the clinic who is actually focused on running the clinic while I would be focused in doing my inpatient's duty and making sure that I have time for other, quality initiatives. Because I kid you not, over the last maybe 7, 8 months, I have not been able to focus in doing, quality improvement project because of the competing priorities with both sectors. But the fact that I have this dedication to my patient, I haven't, complained about it, but just tried to continue on to do my best and to make sure that, my patients are first and foremost. So definitely that's what would have been lovely. So it was amazing when my colleague was in the clinic. We work on a few initiatives together. We were able to collaborate in a few ideas. And that's when I was able to really focus on my baby project of Let's Talk Skin Health a lot. Yeah.
Great. Thanks, Carol, for that. And
You're welcome.
my next question is just to want to hear about your perspective. What can you say about the potential role of SWANs in rehab settings? Now that
Okay.
we are a family of NSWOCs and SWANs, and we're hoping to have more collaboration, what is your perspective about this?
So my perspective for this is very positive. I think there would be an extension to the NSWOC. And I have been thinking about it over a couple months and then put it away, as how would that be operationalized in the rehab sector? And with me, as I was just explaining, having to compete, with inpatient in the clinic and, doing all of that, I could see me having an NSWOC, which would be very positive, would be an asset to my program. I could have my NSWOC doing, the lay of the land on things that I don't really have to see, but then, escalating the needs to me and having some free time to do projects, work and quality initiatives, maybe including the NSWOC as well. So I see it as a positive move, and it's something that we should adopt as an organization. If it works for us, it may not work for everyone, but I could basically see it working in my program. And that NSWOC doesn't have to have the entire week dedicated to wound care, but it could be the days where I do wound rounds, because right now wound rounds has dwindled down. We started out as an interprofessional wound rounds team. It's just dwindled down to maybe at times the dietitian who we had some changes with, maybe a nurse or a PSW. So having an NSWOC there would make it, I mean, a SWAN there would make it very successful, or would, you know, make things positive for my wound rounds. So it doesn't have to be 5 days a week. I couldn't see the role being that, but those specific wound rounds days.
So thanks, Carol, for that perspective. So I will actually vouch for you and I that you and I have a lot of advocating to do to ensure that
Yes.
we have our SWAN family come together to work together towards our complex patient population to ensure that patients are seen at a more needed basis and they get attended to. Now, there is one last question here that was sent to us on a Q&A, and that's from Joanne. How often do you meet with patients with stage 3 or 4 hard to heal wound resistant or fail to heal to negative pressure in context of neurodegenerative disease? It seems to do something to be something recurrent.
Thank you, Joanne, for your question. So basically, it depends. So if I have a patient with a stage 3 pressure injury, and I have made a recommendations again in collaboration with the patient and the team, and it is working. So if the plan is working, I'll probably just follow up with that patient maybe every 2 weeks. If it's a wound that's I have to go back for sequential debridement, I probably seen that patient every twice a week. And again, if it's a wound where at times we're waiting for this wound to manifest itself or to transition to maybe into a crater, you know those wounds, with deep undermining areas, I usually like to pop by every so often to see what's happening. And if it's a wound where I'm really worried about maybe the clinicians who are assigned to the patient, because right now, you know, there is a time with retention, so you do have newer nurses who needs support, and you know, you want to make sure that you set up your nurses for success. So if they were nurses that are more greener or kind of new to their role and new to wound care, I can guarantee you I make appointments to be there every morning. So try to be as early as I can to say, this is the time I'm available to see that patient. I want you to be there. I want you these skills to build up. And if it's a patient who things are transitioning well, and he meets me in the hallway and said, oh, I'd like you to reevaluate my wound this week. You know, I know you're not coming until 2 weeks, but I just want to feel a little bit more confident because I'm not hearing from the nurses how exactly the wound is progressing. The pictures aren't telling me much because they're either too bright, too dark, or I don't understand. So it depends, but I guess the bottom line is to always know when you should be assessing and the plan around when you should always be following up with your patients.
Again, thank you so much, Carol, for that comprehensive answer and for your time for joining us in today's Education Day. Thank you,
Yeah,
Carol.
thank you so much, and sorry for the camera.
No worries.
Okay.
You know what? When you're speaking, we can see how your face is already. You're smiling, and
Okay.
it just emanates a lot of positivity. So thank you.
Thank you so much. Okay.
Okay, everybody. So we are now moving on to our next part of the program, and that is another sponsored event, this time by Ergo Medical. And the topic will be around the role of hypochlorous acid in managing irritant contact dermatitis related to incontinence. And I'm actually very excited to introduce the next speaker here, and that's no other than Dr. Kevin Wu, who is a full-time professor at Queen's University, Faculty of Health Sciences in Kingston, Ontario. He is an affiliate scientist at the Institute of Education Research, University Health Network in Toronto. He is a certified NSWOC and a clinical nurse specialist at the University Health Network. Dr. Wu serves as a research program lead for the Doctor specializes in wound, ostomy, and incontinence Canada, and he is the founding president of the Canadian Pressure Injury Advisory Panel. So over to you, Dr. Wu.
Great. Thank you so much for a very kind introduction, Joshua. And it's always difficult to speak after our inimitable Carol and her lovely voice and lovely energy. So, but I'll try my best to keep the group entertained. So the topic I want to sort of share with you today is about the role of hypochlorous acid in the management of irritant contact dermatitis, especially in the context of individuals who are incontinent. So there are a few objectives that I would like to achieve today in the next 45 minutes or so. First of all, I want to review and examine the concept of skin pH. And I think there's a lot to say about the role of pH and the mechanism and the intricacies around how incontinence can disturb the skin pH, rendering and leading to a lot of downstream undesirable effects. And we're going to come back and talk about discussing best practices for skin hygiene and the role of hypochlorous acid in the management of IAD. So, of course, we had to try to make this more interactive and more fun. So I think you've been listening to a lot of different talks all day, and afternoon is always tough to keep people awake. But at least you're in your home comfortably sitting around. So first of all, let's see. I cannot really see maybe I can see the chat box somewhere. Here we go. True and false question. The skin pH on buttock is about 4.5 to 5.5. If you want to put in your chat box to tell me whether you think this is a true statement or not. I can't really see the answer because I'm not in the same room. So perhaps either Troy or...
I'm seeing it, Dr. Wu, they're coming in. Most of the answers so far are true.
Okay, interesting. Okay, I think you'll be surprised to hear something different after this presentation. All right, saline is effective cleansing agent for skin and wounds. Oops, what do you think? Some true, okay. Again, we'll come back to address the role of saline because I think it's one of the most common agents that we use for cleaning wound and cleaning skin. And the other question I typed, my sticky finger was too fast. Antiseptic solutions should not be used on intact skin, true or false? Okay, there's some true, some false. So there's a lot of debate about, we recognize the value of perhaps using antiseptic agents for wounds. So now the question is whether it should be used or is safe to use on intact skin, or is it really valuable because we don't want to just pour the expensive antiseptic agents on an area that that is not going to benefit from the antiseptic material. And then the other question I have for you to think about is whether chlorhexidine is considered to be cytotoxic. A lot of times we think that, well, chlorhexidine is widely used. We use it for MRSA, decolonization protocol. Is it really safe to use chlorhexidine on wounds and on skin? I'll try to address that a little later. Hypochlorous acid is produced by fibroblasts. What do you think? Well, the answer is false in this case, because hypochlorous acid is produced by the body, but it's not by the fibroblasts. So hopefully by the end, you'll find the answer. I'm not going to give all the answers to you right now. The other question is whether hypochlorite and hypochlorous acid are the same, both chlorine-based solutions. Well, it's a tricky question, and I see some of the answers here. They're both chlorine-based solution, but they're not the same material. And I'll come back to clarify in terms of how they're different from each other. Hypochlorous acid is an oxidizing agent. Think about it. True, yeah, it is an oxidizing agent. And that's how hypochlorous acid is an effective antiseptic agent in killing bacteria. A high pH on skin and wounds promotes bacterial proliferation. Well, I think this is an easy one. That I think we can all kind of agree that when there is a high pH, when there's alkalinity on the skin, disturbing the acidity, and that actually create an environment for bacterial growth, proliferation. Okay, this is very good. I'm going to jump. Oh, yes. Okay, here we go. I do have a last question for you. Hypochlorous acid is able to affect biofilms. Okay. I'll let you think about that too, because I'll have a little of preliminary answers for you to address that. So first of all, why do we need to think about wounds? This is one of the most recent published material in Wounds Canada by Douglas and Miriam, and they tried to estimate the true cause of wounds based on some of the demographic information, and estimating the percentage proportion of individuals affected by wounds, and using some kind of a formula to calculate the true cost of wound care services. And you can see that we spend volumes of exorbitant amount of money on wound management in Ontario, $4.5 billion. Ooh, that's a lot of money we spend. And that's why, in terms of the prevention strategies, if we can preserve the skin integrity and minimize the occurrence of wounds, we can actually save a lot of resources, and not to mention about human suffering as well. So let's come back to talk about healthy skin and the relationship to the skin pH. Some facts. Yes, the healthy skin is approximately 5.5 pH, and that is the ideal environment. But remember, pH, the level may vary depending on anatomical location. And you can see on this cartoon here, depends on where the pH is being measured. What we talk about, the 5.5, the lower pH is around the face, around some of the exposed area, versus in the buttock area, in the feet, the pH level could be quite different, significantly different. In fact, around the buttock area is about 6, around the feet is about 7. It's just the nature of a number of ingredients on the skin that is very, very different compared to the face, and the amount of sweat and sebum, and which I'll come back to explain a bit more. And also keep in mind that skin pH could be quite different across different types of people, depends on the skin color. It's more acidic among people with darkly pigmented skin, and also with the older adults, we have a very different pH level as well. So why do we need to worry about pH level with the acidity in the skin? The analogy that you've been hearing about from your NSWOCC course describe the skin as a very intricate structure, mimic this sort of brick and mortar kind of arrangement. Which is a very, very nice analogy. Basically, the skin cells are bricks. In between the bricks, you have some of those sort of gluey stuff that stick, that align the skin cells together, keep them in the right shape, and in terms of that staggered arrangement in sort of this what we call lamellar layers. So, what those glue. Basically, the key compositions are intercellular lipids consisting of cholesterol, free fatty acids, ceramides, and some of these esters type material. So in order for the enzymes, in order for ceramides to function properly and produced in the adequate amount, it has to be in an acidic environment to activate some of those lipid processing enzymes, such as beta-glucocerebrosidase, and also the acidic sphingomyelinase. It's a long word. So anyway, the end product is the production of ceramides and some of the other material that form the natural moisturizing agent within the skin. So without the acidity, you can see that skin tends to get drier, skin tends to have less hydration, and it can affect the permeability function of the skin barrier by because of the excess amount of desquamation due to the change of pH on the skin. So in other words, the pH of the skin has, play a very important role in terms of regulating the skin microbiome, the type of bacteria, the amount of bacteria on the skin, maintaining the structural stability that we have just talked about, the brick and mortar kind of arrangement, and also the inflammatory response on the skin. So what sort of what's the magic? How do the skin maintain its acidity? By creating this acid mantle, which is on the surface of the skin, is a buffer system on the upper stratum corneum, and it is a combination of sebum, oily material produced by the sebaceous glands, and also some of the amino acids in the sweat. There are two basic mechanisms that are responsible for production of acid mantle. There are two theories. One is called the acrin and sebaceous gland-based mechanism. As the keratinocyte continue to mature, one of the protein inside the keratinocytes, filaggrin, would get decomposed and degraded into different components, producing free amino acid producing acidity on the skin. There's also the carboxylic acid and also the urocanic acid. So they're all very important ingredients to maintain this acid mantle. And there's also lactic acid and free fatty acid from the sebum. That's part of the major function of the sebaceous glands. There's also a second mechanism, is called the keratinocyte-based mechanism. Basically, the cells has a active transporter that export the hydrogen ion to the extracellular environment to maintain the acidity. So you can see the intricacy around maintaining this acid mantle. And why it's so intricate? Because it is important to maintain skin pH at the optimal level. You can see this is a very, very busy slide just to illustrate some of the various factors that can influence skin pH, including the filaggrin that we've just talked about, some of the proton pump antiporter, and the outcome is affecting the bacteria inflammatory response. To simplify things a little bit, this may be a little bit more palatable for you to take into some of the key elements around surface pH. Many factors can influence, our body produce oil and sebum and sweat to maintain skin pH. And the key outcomes and the key desirable pH level is going to help the body the skin maintain an antimicrobial barrier to reduce and maintain a normal inflammatory response, and also to address this sort of permeability barrier, avoiding and regulating desquamation process. So hopefully that kind of makes some sense. I thought that, it's interesting to dive into some of the physiology and science behind the acid mantle that we don't often spend a lot of time talking about. So what can change skin pH then? If low pH is the ideal situation, there are many things that can alter the normal skin pH. As we age, as you can see on this diagram here, older people tend to have slightly more acidic skin, and newborns have a more alkaline type skin. And that's basically depends on the type of oil and type of sweat they produce on the skin that we have just talked about in terms of the different mechanism involved. Occlusion can also change the skin pH. The more occlusive the environment, the more likely you can create alkaline skin pH. And that's why with COVID, with isolation, nurses have lots of complaints about wearing masks. One of the huge concern is from a cosmetic perspective is with occlusion, it can alter the skin pH with the reduction in acidity of the skin, allow more bacterial proliferation, and people develop acne problem. And that's part of the reason why masks can be responsible and related to to some of the sort of emergence of very, very bad acne. And along with occlusion is the intertriginous area, because with the skin fold depends on whether it is the axilla in the groin, in the below the breasts area. When there's no airflow, when we don't have a lot of ventilation with increased occlusion, it can also change the pH. Reduced or increased hydration of the skin, and also increased washing. And this is an interesting study. They evaluated people doing hand washing using alkaline soap. It can actually increase the skin pH by 3 units for a period of time up to 90 minutes after washing. And that's why we don't like people to wash the skin too much. And if we have to wash the skin, try to use something more neutral or acidic as agent to wash the area. So now we have a better understanding in terms of the skin pH and the variety of mechanisms, the area of mechanism responsible for maintaining the skin pH. Which now switch our focus to moisture-associated skin damage. And another sort of more general term is the irritant contact dermatitis. It is the type of dermatitis or contact dermatitis account for 80% of all the different types of dermatitis associated with exposure to irritant substance. It could be fragrance, it could be detergent, it could be metal. And in this case, we're talking about exposure to incontinent effluent material, stool. And also think about the peri-wound skin environment. People can also develop irritant contact dermatitis or moisture-associated skin damage as the corrosive wound fluid, enzyme-rich fluid spilled into the peri-wound skin area. In the peristomal area, I think you have heard a very excellent talk from Rosemary and Tarek, talking about the variety of different techniques to prevent peristomal problems. And also the intertriginous area are very vulnerable to irritant contact dermatitis. So in fact, it's estimated that the prevalence of ID is about 5.6 to 50%, very wide range, depends on the type of environment, depends on the type of tool being used to collect the information about IAD. In other words, I think the key message is a very, very common problem. I would bet any money in ICU, you probably see maybe even 50 and higher percentage of individuals suffering from incontinence-associated dermatitis. So this is a very simplified version of the pathophysiology involved in IAD, describing that depends on the type of agent that the skin is exposed to, whether it's urine, fecal material, perspiration, or the frequent washing with soap. In case of the urine, we know that there's urea in the urine that can be converted into ammonia. And ammonia can actually raise the skin pH. And the other scenario is the exposure to fecal material, not just the fluid itself, but now you have all this fecal enzyme, digestive enzymes that can cause direct erosion and damage to the skin. So all these different types of fluid and moisture can increase the permeability of the skin, compromising the barrier function, and with the change of pH promoting bacterial growth, and also other pathogens, and especially with fungus, it can feed on the keratin cells, creating wounds, and also with the bacteria and decrease in the barrier function, it can weaken the skin, making the skin more vulnerable to other type of injuries. So very, very true that when people have incontinence-associated dermatitis, there is an intricate relationship with bacterial growth. With people who have incontinence, with alkaline environment on the skin, it can promote bacterial growth. Most of the bacteria, most of the microorganisms, they like to grow in a pH around 6.5 to 7.6. So it's a very, very alkaline environment. In fact, our body produce antimicrobial peptides only work effectively in acidic environment. So bacteria become very smart. They actually produce enzymes, produce a material that can facilitate the conversion of pH to more alkaline environment to stop the antimicrobial peptides from working and also promote a better environment for other bacteria to grow. So you can see that kind of a very synergistic and very smart mechanism to help proliferation of bacteria. Along with bacteria, biofilm can establish, and it's also influenced by the pH level. Increased pH can promote biofilm production. Just to give you a comparison to a normal skin pH 5.5, when you raise the pH to 7.5, 169% increase in the biofilm production versus now you increase to the pH to 8.5. It can increase the production to almost 200%. So there is a direct relationship between the incontinence associated damage with, sorry, I'm just getting a little window here. My apology. Let me just go back to share my screen one more time. And there is a direct relationship between IAD and pressure injury development, as we mentioned earlier, with the disturbance to the normal barrier function, weakening the conjunction, the cell-to-cell junction, making the skin more vulnerable to mechanical stretching, shearing, and pressure. So individuals who are incontinent and with IAD are more likely to develop pressure injuries, as you can see in some of the pictures here. So, and this is a nice little table that Professor Beckman and other people have developed and tried to capture the nuances separating IAD from pressure injury, recognizing that a lot of times IAD involve an area away from the bony prominence and also in the area that exposed to stool material. And you can see that usually in the perianal area, right in the anal cleft, very diffuse, often, there may be rash, there may be other septal lesions involved, depends on whether you have coexisting fungal problem at the same time. And in order to address the MASD, we need to think about optimal skin care. And this is sort of very basic principles around skin health strategies, optimize skin health, looking at avoiding alkaline soap, not to use too much friction, and not to massage the reddened area. And I think at the same time, we have to think about, the type of cleansing and type of cleansing agents that we use as well. We actually just finished a survey. Dr. Blanc and myself had, in collaboration with Ergo, launched a survey to explore the attitude, knowledge, and practice of wound cleansing and peri-wound cleansing. And there's some interesting results, and I just want to share with you, and this is unpublished data. We're still in the process of writing this up. So we asked a question, as part of the routine wound care, what solutions do you use to clean the wound? And no big surprises here. Saline continued to be the most popular product. I'm actually surprised that hypochlorous acid is the second most common material being used. Perhaps we're asking, perhaps the respondents are very smart people and have exposure to many different agents, antiseptic material available to the practice. But anyway, this is encouraging to see that people using some better agents compared to surfactant or compared to soap and water. So what are the three top factors that you would consider when choosing a wound cleanser? Again, no big surprise here, and it's good to see that people choose a cleanser because of their concern about infection and not too many people actually have identified peri-wound skin condition. And that's one of the areas that I would like to maybe raise some awareness and address that as a problem in my following presentation. And we also asked a few different, asked the respondents to rate a few different statements, best practice statements. And it's good to see that actually most Canadians in the survey, they are able to identify what's considered to be the best optimal practice for wound cleansing and peri-wound hygiene. Basically, wound cleansing continue to be a very effective way to promote wound healing, maybe reducing bacterial and bioburden problem. And also, I think it is important to look at the different types of cleansers to minimize the tissue damage. And also, I think a lot of people agree that when we're cleansing the wound, also address the peri-wound skin and use the antiseptic agents potentially for peri-wound skin. And that seemed to be a 50-50 split. And that's why I think we need more research to address the use of antiseptic agents for peri-wound skin management. So based on some of the, the best practice documents and recommendations, there are a lot of key ideas out there. And I think they're summarized on this slide here, recognizing that saline is actually not the best ideal washing agent to address microbials, whether it's on the wound or in the peri-wound skin area. And also looking at the cleanser, we need to think about the purpose of cleansing is to disturb and remove the microbial agents on the wound environment, I would say in and around the wound. I think we also need to think about avoiding damage to the fragile granulation tissue and the cells in the wound. There are a variety of different agents out there. I think there have been a lot of discussion about hypochlorous acid, and that's why when we did the survey, there's a lot of people have recognized the value of using hypochlorous acid in the practice. And we continue to debunk a lot of myths around the differences between hypochlorite and hypochlorous acid, and also recognizing that what we assume to be non-cytotoxic, for example, chlorhexidine, actually has some evidence to prove that they're actually potentially could cause damage to the cells and keratinocytes. So along with some of those key recommendations, the IWII also recommend the importance of using an adequate amount of irrigant to wash the wound, and also, again, peri-wound skin management to ensure that all the bacteria burden is being removed and addressed, minimized in order to facilitate the healing process. And we have done some imaging study using the fluorescence imaging light to evaluate what we actually has hypothesized that a lot of bacteria, a lot of those pathogens are actually in the peri-wound skin, because we're so good at cleaning the wound, but a lot of times when we ignore and when we omit the peri-wound skin area, that can actually be the place, a reservoir for bacteria to grow. And you can see that even in a huge closed surgical area. So the comparison in this slide shows you the comparison of non-antiseptic agent versus antiseptic agents. And you can see that I think on the graph on your left-hand side, it's quite interesting. And with antiseptic agent, it has the ability to reduce the bacteria to a very significant amount versus a non-antiseptic agent. Now, recognizing that in the research, there is very little evidence to suggest that any significant antimicrobial activities across different antiseptic agents. A lot of antiseptic agents, they could be very effective in terms of killing bacteria. In high concentration, a lot of things can kill bacteria. But what we need to be concerned about at the same time is the cytotoxicity as well. We don't want things to be toxic to the skin. So that's the impetus for a group of people to look at different cleansing agents and create what we call the therapeutic index. So what the index is a calculation informed by the ability for the antimicrobial ingredient to kill the bacteria, and in comparison to the cytotoxicity level. So the antimicrobial function versus the cytotoxicity level. So to interpret this therapeutic index, the higher the number, the more effective it is. And you can see on the graph here, let's see, chlorhexidine, very effective against MRSA, but a very low number for Pseudomonas, a very low number for Staph aureus. What is suggesting to us is it is, first of all, may not be very effective against those type of bacteria, and it has a potential to be cytotoxic. And look at povidone, even worse. It's not effective against a lot of those different agents. Versus hypochlorous acid, right in the middle here, you got the 5.49 for E. coli, 8.81 for Pseudomonas. Just to convince you in terms of the evidence around chlorhexidine gluconate, and this is a paper published in 2018 looking at the cytotoxicity of chlorhexidine gluconate on human fibroblasts, myoblasts, and osteoblasts, the different types of cells. And the conclusion basically is that a concentration of chlorhexidine at 2% can actually slow down the cell migration and also significantly reduce the survival of those cells in the in vitro environment. So in other words, there is some good evidence suggesting the cytotoxicity of chlorhexidine, a very, very common agent that we use, and we used to think that it is innocuous. So what about hypochlorous acid? What is it? Well, hypochlorous acid is actually produced by your body. Just a reminder, it's not from the fibroblast, but it's actually coming from the white blood cells, from the neutrophils. So when there is bacteria, when there's foreign material, when there's pathogens enter the body, it creates this whole cascade of physiological response with chemotaxis, sending signal to attract more cells, more inflammatory cells, more white blood cells to the injured area, to the invaded area. So what the neutrophils can do is they involve in phagocytosis, and once the bacteria being engulfed by the neutrophil or macrophage, there is a process inside the cells that the material can produce, the cell can produce the hypochlorous acid through a very complex pathway from oxygen, combining oxygen to hydrogen peroxide through an enzyme producing hypochlorous acid. So it is a body defense mechanism to produce hypochlorous acid, and that's why it is not a foreign material that we use to treat wound infection or treat the pathogens on the skin. And the pathogen can kill bacteria, and the pathogen is being killed by the hypochlorous acid. And there are a few different mechanisms how hypochlorous acid can attack the bacteria. As you can see on the slide here, it can enter into the cell structure because of the neutral molecule, so it can easily enter into the cellular environment, and it can bind to the DNA structure, break down the DNA material, stop the synthesis process, and also reducing the respiratory mechanism of the bacteria and bind to other enzymes as well. Now, just to keep in mind, hypochlorous acid is about 80 to 120 times more effective than sodium hypochlorite. You may ask why? They're both, chloride-based products, right? True enough. But remember, sodium hypochlorite is a charged molecule. It has a negative charge. So on the surface of a bacterial cell, it's also covered by a negative charge. So when you have two same charges meeting in the same place, they're going to repel against each other. And that's why it's very difficult for sodium hypochlorite to enter into the bacteria to perform the antimicrobial function. Versus with hypochlorous acid, there's no charge, it's a neutral molecule, it can penetrate into the cell more easily. And the other interesting thing is when I looked at the literature, there's some good studies done indicating hypochlorous acid can reduce the activity of histamine, interleukin activities, and the downstream effect is to lessen the production of matrix metalloproteinases. So in other words, it has some anti-inflammatory function. So chemically, how is hypochlorous acid different compared to sodium hypochlorite? It's all about the pH. Hypochlorous acid has a pH level, it's an acidic pH level. As you can see, it's sitting around 4 to 5 pH of 4 to 5, versus sodium hypochlorite is a very alkaline material, very, very potent, corrosive alkaline bleach. And you can smell the bleach is a very alkaline material, and Dakin solution is even more alkaline. And in other words, the hypochlorous acid is at the pH level that is very similar to intact skin. And also keep in mind that as the wounds become more chronic because of the presence of wound fluid in the presence of bacteria, there's a lot of mechanism trying to convert and produce more enzymes that make the wounds more alkaline to promote bacterial growth. That's why we see pressure injuries tend to be more alkaline, chronic wounds, or the wound bed is more alkaline. And they are not the environment that can promote wound healing. And that's why we need to think about ways to acidify the wound environment to promote better wound healing. And that's why we're quite familiar with the VASH solution that is a pure hypochlorous acid. It does have ability to kill bacteria, but at the same time, not killing all the good cells, including fibroblasts and keratinocytes that are vital to the healing process. And you can see that in terms of the broad spectrum of bacteria that hypochlorous acid is able to exert its antimicrobial action against, for example, MRSA, VRE, and including all the other common pathogens that are responsible for wound infection. So just to summarize at this point, hypochlorous acid is an endogenous material that your body actually produces. And now we're able to produce pure hypochlorous acid that we can use externally to promote and acidify the wound environment, or acidifying the skin to promote better wound healing, or reduce inflammation, modulating the bacterial, the micro ecosystem. And also recognizing that the hypochlorous acid is more effective, has the ability to penetrate into bacteria 80 to 100 times more effective than sodium hypochlorite. Okay, I think just same bullets there. So in terms of the assessment, there are a variety of tools, and again, Dr. LeBlanc and her group had done some work summarizing in a document about the variety of tools available published in the literature, including the Globiet, the Gantt tool, the tools developed for the assessment of peristomal area and peri-wound area. They're great tools. However, we recognize that those tools have limitations because they categorize the skin condition into different types based on the severity. But they're not designed to track and monitor progression over time. We need a tool like that. And that's why we have Josh and Kevin's plan. Just to declare that you're not looking at our skin. This is not our butt, so don't worry about it. Our plan is to develop, and in collaboration with NSWOCs, to develop a tool that is validated, that is reliable and valid to evaluate how MASD, how IAD can progress and improve over time or deteriorate, because we need to determine whether the intervention that we use instituted effective or not. And you can see there's a few different parameters, and I'm not going to speak too much about that because I think you hear more about that in the future. And I think what's important is by recognizing and by producing a score, a tool like this, it will guide in terms of our treatment protocol. And this is not our protocol, and this is something that actually Brittany Butt had done with Norfolk General Hospital in the past. And she developed this protocol based on the Globiate, the Gantt tool. Depends on the different types of MASD or IAD. So there will be different types of cleansing protocol and different types of protective agent being used. And that's how we recognize the importance of guiding, using those type of tools to guide the use of hypochlorous acid for IAD and MASD. So just to give you a case example in the end of my presentation. So this case, all the personal information has been altered to protect confidentiality. So this lady has a multiple sort of medical problems, cerebral palsy, respiratory failure, and traumatic brain injury at the Rehab hospital. She's quadriplegic, have a stage 4 pressure injury that was actually improved and healed with a surgical procedure. And the complexity of care involved, she was on a new enteral feeding tube that rendered her and a lot of stool production. As you're aware that people have feeding tube tend to have problems with bowels. And she also have a tracheostomy. So she have multiple medications that they need, the patients need them, but at the same time, some of the medications may actually affect the bowel. So let's take a look at the picture. So we were asked to see this individual, and you can see that there's a lot of erythema going on in the perirectal area. In the interest of time, I'm not going to ask you to respond to all those questions, but you can think about it as I go through them. So what type of wound is it? Is it, so the nurses ask, is it pressure injury? Is it deep tissue injury? Is it stage 2? You can see there's a little flap that is kind of detached from the wound. It's actually, it's not a tunnel. It's not a deep wound. It's a very shallow area. My guess is that this individual had multiple pressure injuries before with recurrent friction and shear problem. This area is so fragile. The skin it's because of the scarring, because of the reformation of skin, it has a very altered structure and tensile strength. It can detach itself very, very easily. So it's really just a thicker skin flap. And it is quite friable. You can see the amount of bleeding that is going on. At some point, I was cleaning it and it was bleeding like nonstop. I was just so worried that I have to send this patient out to emergency, and I don't even know what they can do. You cannot suture up, right? But anyway, yeah. So coming back to the question. So what would you do? Do you see it as a secondary infection problem? What kind of interventions may you consider with this type of probably incontinence associated dermatitis? So we did a few things, and again, summarizing some of the assessment and some of the complexity of care. This individual continued to sit in a chair for a prolonged duration of time. And we actually identified there's a need to address multiple things. Potentially, there may be a little bit of a fungal problem going on. So we tried some ketoconazole, and locally we applied the hypochlorous acid as a compress, use a silver nitrate as a hemostatic agent for the friable bleeding area, and cover with ABD PET daily. And by the way, this is a plan that is developed by Joshua as well. So I cannot claim credit for all the wonderful work that has been done on this individual. And also, I think, with the multiple team member involvement, we try to promote better adherence, to encourage patients to stay in bed for longer duration of time. We don't want people to be on bed rest completely, but at least we want to have a reduced sitting time and also evaluate the sitting surface. So we can see that there's after a couple of months, there's some improvement in terms of the reduction in the erythema. You can still see a little bit that sort of erythematous advancing border, and not too much scaling going on, and you don't see the satellite lesions, and the friability has reduced, and there seems to be some new epithelium growing into the area. I don't think we can ever change the flap configuration. I think it's kind of a chronic thing, and definitely the color is better, less dark and less inflamed. So we continue with the ketoconazole. I don't think it's actually making a huge difference, but we decided to continue for 14 days, but definitely continue with the hypochlorous acid as a compress. And you can see that another couple of months have passed and the condition has improved so much. You can see that there's a reduction in erythema, and as I said, those sort of rough texture is basically from the chronic friction and chronic pressure change due to the restructuring of the skin tissue. And you can see that that the flap was being sort of pushed back to expose what's underneath there. The wound is almost healed. Definitely a significant improvement. So again, I don't think there's a need to change the plan, but continue with the hypochlorous acid. And this is the most recent picture. I do apologize. This is not the most pleasant picture, especially this is after lunch, because I was trying to take a picture, and then I cleaned up the area. And then, of course, as we are all aware that by looking at the wound, that seemed to have a stimulating effect on the bowel. So you can see a couple of things. The erythema has actually virtually disappeared, improved so much. I think what's left at the scar, sort of pink scar tissue. The flap is actually much better. But now we have a concern about potentially some of the darkened area, indicating it's a pressure, not so much about irritant dermatitis anymore. So there's another sort of upstream battle in terms of looking at how we can offload the area better. So it's important to think about when we're using hypochlorous acid, and whether we're dealing with wound, peri-wound skin, or dealing with MASD or incontinence-associated dermatitis, there's a need to consider agent that can promote local acidification as part of the treatment plan. And so the important part is to clean the wound. We need to soak the area for a duration of time. Usually the recommendations were 5 to 10 minutes. That will allow the agent, the oxidizing agent, to release into the wound environment, interact with the skin, acidify the area, and then change. So this is a nice, interesting study done by Dr. Robson, published in today's Wound Clinic. It's not a peer-reviewed journal, but I still think that is a very interesting study, one of this kind, indicating to us comparing the duration of time and the effectiveness of hypochlorous acid on biofilm. The longer the contact time, the more effective it is. I'm comparing from 0 minute, 1 minute, 3 minutes to 5 minutes. But beyond 5 minutes, you don't really see a extended benefit. In fact, most of the oxidizing agent would have disappeared because it would interact with air. So so what it means is beyond 5 minutes or more, there's very little value in terms of what the hypochlorous acid is doing on the pathogens. So I think that's why we need to think about hypochlorous acid to optimize debridement. There is a term introduced in some of the debridement documents coined oxidative debridement because of the oxidizing property of hypochlorous acid. that can soften the bond, the structural bond of the necrotic tissue, allowing it to detach from the wound bed more easily. And so hopefully that gives you some idea in terms of why and how we're using hypochlorous acid for MASD and for peri-wound skin management, and not just for wound bed preparation. Thank you so much.
Thanks, Dr. Wu. And we have actually a couple of questions for you. So we generate a lot of interest on this topic. One question specifically asks, can you speak to VOSH or hypochlorous acid use and bleaching? I have had a medical doctor stop use for this reason only and would like more rationale for this. And when I ask about the bleaching, they're referring to the wound bed bleaching. Can you talk more about that?
Let me sure I'm hearing this correctly. Bleaching, is that right?
That's correct. Yep.
Yeah. So, and hopefully some of the points I made in the presentation clarify some of those that question a little bit. So bleaching it's Dakin, so using Dakin solution, using a bleach, very alkaline solution to bleach the area. And bleach is a very alkaline material, very corrosive, very damaging the skin. It has ability to kill cells. And at the same time, the bleach material, the sodium hypochlorite, is not able to get into the cells as much as hypochlorous acid. And that's why I find emphasize there's a huge difference in terms of in between the hypochlorous acid and hypochlorite. Not only just from a functional perspective, but the cytotoxicity level is very different. So hopefully that kind of makes some sense to you.
I think, Dr. We're going to rephrase that question. I think the person that asked this question is that they found that the hypochlorous acid was the one bleaching the surface of the wound. And have you found that in practice? And do you have any comments about that?
So again, it's interesting question, and I'm trying to understand the term bleaching. So what's the evidence of bleaching? So I guess it means discoloration and the wound tissue looks pale, perhaps. I would think that my explanation, I think when you soak the wound for duration of time, so the tissue can get, in the wound tissue, the granulation tissue can be superhydrated and absorb the fluid to a certain extent. So it may change the color. And if that's what you call bleaching, for lack of a better way of describing it, I think it can happen. So hopefully that is in line with what you're asking.
Okay. There's another question here in terms of hypochlorous acid kills many bacteria in 15 seconds. So is there even any benefit to do 10 to 15 minute soaks with hypochlorous acid?
Yeah, that's an excellent question. So I think there are two key benefits of using hypochlorous acid. As you have pointed out, the one key thing that we think is advantageous of using hypochlorous acid is to kill the bacteria, to reduce the bacterial burden. And what I'm trying to also emphasize is the skin acidification as part of the continuum to promote better skin health, to maintain this acid mantle, to restore this acid mantle. And that is not going to take a few seconds to restore that.
And so I'm just going to jump onto that same similar context. Since effectiveness of VOSH or hypochlorous only lasts for 5 minutes, is there a bonus to packing wounds with this solution, or should it be used more as a compress and pack with something else?
That's another excellent question. So George, you may want to chime in because I know you use a lot of packing material as well. I think it really depends. In some of the more occlusive environment, there may be value to it to facilitate the diffusion of hypochlorous acid into deeper space. I think, just like, if you're using povidone for packing or other type of antiseptic solution for packing, there's no ideal solutions that can be used for packing purposes in comparison. Same as, betadine, povidone iodine, the activity would disappear in minutes. But we still use it for packing purposes. So it really depends on the amount of fluid, depends on the space. I think more evidence is required to provide a intelligent answer.
I can provide my 2 cents on that one. So I do in practice when I find that their wound has high bioburden and there's a need for us to reduce that kind of surface bioburden, we do compress the wound for as long as possible, 5 to 10 minutes. And I do pack it with a moistened or even soaked hypochlorous acid gauze. And now the ideal scenario, as what Dr. Wu has mentioned, is keeping that gauze moistened. But so if you're going to be doing that routine basis, it would be better and more ideal to actually do it more frequent than just daily to get the benefit of it. But in practice, I've seen a lot of good outcomes from patients where I have used historically povidone iodine packing and allowed me to switch over with lesser toxicity and then more benefit for the wound and of course safer for the patient as well.
Yeah. I think with this popularity of hypochlorous acid that we see nowadays, perhaps there's some people are thinking about using some slow release mechanism to facilitate to ensure that we have a long-acting hypochlorous acid available for us. Finger crossed.
So the other question here as well. I think it's coming from Jim, just looking after here. Sorry, apologies for missing the bit about barrier products and hypochlorous, dimethicone, acrylates, or zinc. When and how to include hypochlorous in the skincare?
I think if there's any concern about the skin pH, I would definitely consider using a hypochlorous solution to acidify the skin environment, to restore the skin pH. And, in the context of course, we want to protect the skin if individual patients, they have lots of incontinence, you want to use an effective barrier. My preference is to clean the area and compress the area. If there's IAD, especially, compress the area with hypochlorous acid. And after that, to remove the compress and then apply the barrier. And, again, there's no one barrier that is more effective than another. And as far as I know, none of the ingredient in the most available barrier cream and products have any interaction with hypochlorous acid.
And the last question I'm going to ask, just in the interest of time, Dr. Wu, is can we use hypochlorous soaks to replace acetic acid soaks as part of the management plan to treat pseudo wound infections?
Another excellent question. I would think so. Because they're both acidic agent. I know in the past, without the hypochlorous acid or it's not readily available, we use different percentage of acetic acid, whether it is 0.5% or 1% or 2%. And I think now we have the advantage of a more stabilized, pure hypochlorous acid solution available to us. Remember, acetic acid compounded by pharmacy, and they will continue to change sitting on the shelf. So what we see patients, let's say they're staying in hospital for 5 days, 10 days, a month. At the end of the bottle, there's actually just really fluid left. If you don't believe me, next time when you dip your fries in vinegar, wait for a few minutes, the vinegar would taste different for you.
And the other thing about that, Dr. Wu, as well, is with acetic acid, the mode of action is reducing the surface pH to prevent from bacterial proliferation. So a similar effect, you will actually get, a better action when you're using something that's a bit more pH friendly, that's also friendly for the wound bed surface and the skin by using a form such as hypochlorous acid.
Yeah.
So thank you so much, Dr. Wu, for coming in today and for actually sharing us your insights or taking us a deeper dive into the skin anatomy, the importance of microbiome and pH, as well as the functions and effects and benefits of utilizing hypochlorous acid, also beyond the context of wounds, but also looking into the use of it in incontinence dermatitis and in managing moisture dermatitis as well. And I like the fact that you highlight the importance that we should not only pay close attention to wound cleansing, but also peri-wound wound skin cleansing as well, where all of these pathogens and microorganisms may breed and can cause potential infection. So thank you so much for your time, Dr. Wu.
Thank you so much.
Okay, so on to our last presenter in terms of our representation for NSWOCs and SWANs, and I'm so privileged to actually introduce to you Dr. Kimberly LeBlanc, and for actually taking her time to be with us this afternoon. So Dr. Kimberly LeBlanc is known globally as an innovative nurse leader. She is the current academic chair of the Association for Nurses Specialized in Wound Ostomy and Continence Canada, Wound Ostomy Continence Institute, and Advanced Practice and Certified Wound and Ostomy Continence Nurse working with KDS Professional Consulting. Dr. Kimberly is the current president of the Canadian Nurses Association. She holds a doctorate of philosophy in nursing from Queen's University. In 2020, she was inducted as a fellow of the Canadian Academy of Nursing and is a past recipient of the Canadian Nurses Association Order of Merit for Nursing Education. Dr. Kimberly is an adjunct professor at Curtin University, an affiliate lecturer at McGill University, and an honorary senior lecturer at Cardiff University. Kimberly is a past president and founding member of the International Skin Care Advisory Panel and the past co-chair of the Canadian Pressure Injury Advisory Panel. She is currently a board member of the World Union of Wound Healing Societies, the International Wound Infection Institute, and the Commonwealth of Wound Care Resource Alliance. Dr. Kimberly has lectured extensively on wound and ostomy care and is considered a global expert on wounds and ostomy issues in the aging population and has numerous publications and book chapters on wound, ostomy, and continence-related topics. She sits in the editorial boards of the International Wound Journal, Advances Skin and Wound Care, and Canadian Nurse. Dr. Kimberly maintains an active clinical practice addressing the wound and ostomy and continence needs of individuals across the spectrum of care. So without further ado, Dr. Kimberly will talk to us about the impact of NSWOCs and SWANs in the long-term care sector. Over to you, Dr. Kimberly.
Thanks, Josh. And I will say that it's always very intimidating to be last and even more so have to follow Dr. Wu. You're never ideal. My advice to all of you is say no when they ask you to follow Kevin, because he's always so dynamic. So let me just share my screen here with you and we'll get this going. Are you seeing my screen okay there, Josh?
Yep, I can see it right here.
Okay.
You just probably, there we go.
There we go. Move that out of the way, and then I think we're good to go. So what I really want to talk about today, and it's a bit of a dry topic, I guess, for the last topic of the day, but one that's very near and dear to my heart. And any of you who work in long-term care, you need to understand how things are working in Ontario. And if you don't work in long-term care, it's even more important, because especially if you're working acute care and you're getting patients from long-term care, you need to know some of the barriers that we have to live with. So I just want to start by saying that I have the pleasure of living, working, and playing in the Algonquin Anishinaabe Nation, which is unceded territory. And in Canada, we have the privilege of we live, learn, and work on traditional Indigenous territories. We pay our respects to First Nations, Métis, and Inuit ancestors and affirm our commitment to respectful relationships with one another and this land. And as nurses, we have to take ownership for past hurts and traumas and really work towards truth and reconciliation with open and honest hearts. And it's our duty to not expect our Indigenous colleagues to teach us, but for us to go to our Indigenous colleagues and ask those questions and make it our business to learn. So today, what I really want to do is I want to talk about our roles in long-term care, look at the challenges, and look at potential solutions. This should say NSWOCs and SWANs in long-term care. So let's take a step back. Our sector is in crisis. Our long-term care facilities are expected to be safe havens for our most vulnerable aging population. And I would like all of you to think about it for a minute. If our daycares were not daycares, but our junior kindergartens, our kindergartens, were in the same situation that long-term care is in, there would be massive public outcry. It's estimated that among individuals living in long-term care, 28% are going to develop a wound. Think about that. So, basically, more than 1/4 of people will develop a wound, and 50 to 75% will suffer from some degree of incontinence, which is going to predispose them to falls and pressure injuries. So we need to put that in context, that the majority of individuals in long-term care will have some form of continent-related issues, and that 1 in 4 will develop a wound. In Ontario, as much as 50% of healthcare services are allocated to wound management. So if we look at the provinces as a whole, and we know that urinary incontinence is one of the main reasons for long-term care admissions. So patients, their families just can't manage them at home. So despite 92% of Ontario's long-term care homes stating that their focus would be decreasing the number of facility-acquired pressure injuries, there's only been a decrease of 0.4% of incidence rates in the 5 years since the commitment was made. So nothing has moved forward. One of the issues is that there's been a lot of what I call mass education. And look, the Institute, we have a program as well that is self-paced online, 6 weeks, that's meant for providing foundational education. And foundational education is important. But if you don't have leadership and mentorship within the facility, then people cannot grow, they cannot apply their knowledge. And this is where SWANs and NSWOCs are so valuable for making sure that we have that continuing mentorship. Because we've seen time and time again, where we've had mass education, we see little blips of improvement, and then poof, we're right back down. So let's look at Ontario. Well, there's over 78,000 long-term care beds spread over 630 facilities. The number of long-term care beds plus new or worsening pressure injury incidence rates of 2.6%, it's an estimation, and an estimated cost of $70,000 per pressure injury. This means that our costs can be as high as $140 million annually for wounds in long-term care. A recent study reported that 20.1% of long-term care residents will suffer from a skin tear for an estimate cost of 1 million Canadian annually. If we look at, if we do economic modeling. Now, for full disclosure, this is a study that Dr. Wu and I did. But you look at that, that's an enormous amount of money spent on a wound that's purely preventable. Wound care related concerns are not the only financial burden that we see in the long-term care sector. We know that there's such a high prevalence of incontinence, and that continence products cost as much as $2,100 Canadian per resident per year. So it's estimated that we have 59,000 Ontario long-term care residents are going to require containment products at a potential cost of as much as 123 million Canadian annually. So a reduction of just 5% would save as much as $6 million in products alone. And one of the things that I do when I go into long-term care is one of the first things I start asking the questions of is, what are we doing for continence? And often, you got to realize I'm being brought in as a specialist in long-term care. So I'm not there necessarily for preventative measures, but when we start talking about preventing, all I get is barriers. We can't do a toileting schedule because we don't have enough staff. And when I actually sit down with them and work it out, that you actually use less staff if you develop a toileting schedule and you save money, we can get programs in place. And I'm going to talk about that a little bit more in a little bit. So we know that the plight related to wound, ostomy, and incontinence issues in the long-term care sector has started to be reported in the media, right? There's now been deaths. But despite the public outcry in the media, little has changed in the way that we're doing any of our care in long-term care. The COVID-19 pandemic really, any of you who listened to the news knew it just blew the cap off. None of this was new. We've been raising the alarm for this for over a decade, those of us who work in long-term care. We know the military was deployed and that facilities, they were there to provide relief, but their report would really bear witness to the substandard care being provided to long-term care residents in Ontario. This isn't the fault of the individuals who are working in long-term care. They are working understaffed, under-resourced. They don't have the access to education, supplies, or mentorship. And we know that wound care was one of the biggest concerns that they highlighted. They talked about the gross lack of appropriate wound management due to supply shortages and educational deficits. We see this on a routine basis. I will go in and there's no supplies because the ordering hasn't been done, or they don't have the budgets to order what we need. So for those of you who work in acute care, imagining wanting to go in and order something that you know is best practice for your patient, in our case it would be a resident, and you're told you can't have it because of budgetary reasons. We get this time and time again. It was noted in the report that when there was a lack of access to specialized nurses, wounds were significantly deteriorating. Poor catheter care was also reported, with reuse of non-sterile supplies and abnormalities going unreported, such as bleeding. We know urethral erosion is also huge, and that's something I do a lot of education around, is the prevention of urethral erosion, because we see it time and time again. Now, the Canadian Nurses Association back in 2020 released a report, the vision of the Canadian CNA Vision 2020 Vision of Long-Term Care in Canada. They highlighted that the lack of specialized nursing services, including those specialized in wound, ostomy, and incontinence, negatively affects residents. So NSWOCs are the only nurses certified by the CNA in wound, ostomy, and incontinence, as you know. And the Skin Wellness Associate Nurse Program is the only wound, ostomy, and incontinence program for practical nurses that's accredited by the CNA. The CNA has accredited other wound care courses, but we are the only, the SWAN program is the only course that graduates nurses who have increased specialization in wound, ostomy, and incontinence. So let's look at numbers. So we only have 69 NSWOCs providing care and support to long-term care clients across Canada. And only 20 of us are dedicated to solely working in long-term care. Think about that. Now, I don't solely work in long-term care, but that's a huge part of my practice. Only 20 across Canada. So think about it, there's even fewer in Ontario. It's thought that with 630 long-term care beds in Ontario, the fact that the majority of which are not serviced by an NSWOC is contributing to the crisis in Ontario long-term care facilities. And currently, there's only 50 SWANs working in Ontario long-term care facilities. Now, in my daily practice, I'll tell you that I always like to have 2 to 3 SWANs per facility I work in. So if it's a 200 or 300 bed facility, that we have a team of SWANs in the facility. And I manage about 10 long-term care homes. And I need the SWANs who are my eyes and ears. So you start doing the math that if we have 630 long-term care homes in Ontario, we need way more than 50 SWANs. We need to have SWAN teams in every long-term care facility. But not only do we need SWANs in the long-term care homes, they need to be allowed to work to their full scope of practice. So what frequently happens is, of those 50 SWANs, the majority of them have regular caseloads. They are a regular nurse within the facility with the added, oh, well, if there's a wound, you can go and look at it. Versus imagine what they could do if their job was actually prevention and management. So I have a couple of facilities that I consult in that have teams of SWANs, and they actually are in the position of a SWAN. And what they do is they go in, we set up continence prevention programs. So we go in and we look at continence. We looked at all the residents in one facility to determine who are functionally incontinent. So who could we get back to a state of continence? So we looked at all that. They go around and they just look at how they can prevent pressure injuries, or how can they prevent them from worsening. They do education on the prevention and management of skin tears, for examples. So there's so much more we can do if we just have SWANs working to their full scope of practice versus them just being another number. So we need to look at outcome metrics. That's always important. There's been a number of government programs such as Health Quality Ontario, Restoring and Promoting Continence. The program was as well as medical device company driven wound, ostomy, and continence related programs, which have been made available to long-term care staff over the past decade. These programs have led to no marked improvement in care. Zero. This was a report done by Health Quality Ontario in 2010. Previous programs have demonstrated that education alone is not enough to ensure a sustainable improvement, and change is desperately needed to improve the lives of individuals suffering from wound, ostomy, incontinence, and long-term care. So we know that education alone won't do it. We need to have those nurse leaders in the facilities. Now, we have something called funding in long-term care. It's called the High Intensity Needs Fund. It is designed to supposedly prevent and or shorten hospital admissions and to prevent people from needing to go to long-term care into acute care. About 10 years, 15 years ago, they changed the funding. It used to cover having the facilities bring in NSWOCs. It used to cover all dressing supplies and other preventative tools. The program was changed. They no longer cover specialty nurses. And in order to qualify for the program, you have to have an irretractable wound. We're not sure what that means. We've never been able to get a clarification on the definition. The most we've been able to determine is that it's a non-healable wound. So I can get covered for a wound that's non-healable or a maintenance wound, but I can't sign off on it. It has to be a physician. So despite the inclusion in the High Intensity Needs Fund manual of the benefits of including an NSWOC were actually listed in there as part of a skin health program, there is zero funding allocated to long-term care facilities to include NSWOCs in the care of long-term care residents. Now, this High Intensity Needs Fund was developed before SWANs came into existence, so SWANs aren't listed either. Access to HINF funding requires assessment by a physician or nurse practitioner, with zero requirements for them to have additional education or knowledge related to wound, ostomy, or continence issues. So I fill out the form. I have to ask a physician or nurse practitioner to sign it. So given the lack of NSWOCs involved in the care of residents residing in long-term care, it's not surprising that recent reports have highlighted the lack of appropriate knowledge and supplies for wound, ostomy, and continence. Not surprising. So we look at access. Currently, Ontario legislation mandates that long-term care skin care programs demonstrate recognition of skin health as an important issue. Yet the legislation stops short of including guaranteed access to NSWOCs or SWANs. There is nothing in there that says that they have to have a specialist in wound, ostomy, and continence. Now, personally, I would love for them to use NSWOCs and SWAN titles, but I would be happy if they just put in there the legislation that you had to have a specialist in wound, ostomy, and continence, but they don't. Specialists such as physiotherapists and dietitians are required by legislation. But yet one of the biggest financial burdens is not covered. Previous solutions have included education and various funding models. All have failed to meet the requirements of long-term care residents and those who care for them. So for us, there are times when we feel like we're Band-Aids on a hemorrhage. Funding and stopgap education have been shown to be ineffective. Those with specialized knowledge and skill set to manage wound, ostomy, and continence prevention and management have not been included in funding, education, and access to service decisions. If we're going to improve long-term care in Ontario, we have to rectify this. And I can assure you that Catherine Harley and myself are working very hard to try and reach all of the provinces, but Ontario is definitely being targeted to try and change this. So why have previous education and funding models failed? As I said, lack of mentorship, lack of access to specialists and leaders in long-term care, lack of priority on prevention, lack of resources for WOC management. So we often don't, even if we have the expertise, so the homes where I have my SWANs, I have my dream team. Okay, I'm coming in as the expert. We've got our teams of SWANs. We have a great wound and skin program, but we have no funds for prevention and we don't have access. So I have someone who needs a low air loss mattress. The only thing that they have is this mattress that kind of vibrates a little bit. Okay, it's like the vibrating beds from some of those really sketchy hotels they have. So we don't have access to the proper equipment. Research has demonstrated by having an NSWOC, patients' clinical outcomes are improved and costs are reduced. We know that agencies employing NSWOCs demonstrate significantly improved outcomes. These outcomes include improvements in pressure injuries, lower extremity wounds, surgical wound healing rates, and management of urinary incontinence. Now, this study was done before SWANs came in, so we need to start doing some research on the involvement of SWANs as well. And I know Jennifer Bilby and I have been talking about doing such research in long-term care. Living with urinary fecal incontinence, we know that that can have huge impact, right? It leads to physical discomfort, skin irritations, infections, emotionally distress. We also know it can contribute to worsening dementia. Access to NSWOCs, we know, can dramatically improve the lives of these individuals. We provide expert care in managing incontinence, promoting skill health, and preventing complications. And, you know, sometimes it's very simple. I get patients who are, you know, residents who are sent home from long-term to long-term care from acute care. Think about this scenario. Someone breaks their hip, they go into acute care for surgery. They have their surgery. Post-operatively, they're constipated. They're given laxatives. They're then sent back to long-term care. Well, what happens is they're sent with a med list of everything that they had in hospital. That med list is often the attending physician in long-term care or nurse practitioner will often take that med list and it's now back into the system. Nobody assesses to see, do they still need their laxative? I will get called in because somebody has been oozing stool for 3 months. First thing I do is I do a med review. Most of the time they're on laxatives. So if somebody's oozing stool, why are they on the laxative? Often I will ask, are they impacted? Or is this they don't need their the laxatives anymore? So I'll ask, has a rectal exam be done? It's never done. So I've done more rectal exams in my career than probably most nurses, because that's one of the first things that I do, making sure they're not impacted. If they're not impacted, which most of the time they're not, we stop the laxatives or we change to a different laxative. And the oozing stool stops, their skin improves, and we're often able also to do bowel retraining where we sit them on a toilet. We sit them on the toilet after every meal. After a few weeks, a pattern emerges, then we just sit them on the toilet for that time of the day. And lo and behold, we actually use fewer sewer absorbent products, and their skin is improved. The residents tend to be much happier because they have better evacuation. Staff is happier because they're not having to do all the changing when someone's oozing stool all the time. So that's just one example how if you have a leader in long-term care who can work with the staff, provide the education, and be able to implement a program, how we can greatly improve care. Okay, we offer personalized care plans, education, and support to residents or caregivers. I do so much work with the residents and families to improve outcomes. So we know that by our involvement, we can help. So wounds are going to heal faster. We know that the stage 3 and 4 pressure injuries decrease, resulting in cost savings. Healthcare professionals become focused on prevention, best practice, and cost savings instead of crisis intervention. We get proper use, product use and monitoring. So, you know, one of my pet peeves, both across the spectrum of care, is that people put silver dressings and other antimicrobial dressings on everything. I come in and it's always less is more, only use it when you need it, right? And don't underestimate the power of the cheap and cheerful hypochlorous acid. Dr. Wu just gave you a great presentation on the use of hypochlorous acid. It can be such a cost saver, and you can, you know, heal wounds faster, and you don't need those antimicrobials in many cases. It's the education and resources and the mentoring that's so important, right? The nurses need to have constant mentoring and updating, right? Our job is to make sure that we're up to date and have best practices, and we move in and we provide that education. Coaching and mentoring of professional and non-professional staff is ongoing. I do a lot of work with our support workers, and many a time if you come into long-term care, you'll find me in the tub room. It's a great place to get in there and see, not only to see the resident's skin from head to toe, but it's a great opportunity for education as well. So for formal education staffs that are targeted on prevention, assessment, and management, we do them in little bites and chunks. And then evaluation staff knowledge before and after these education sessions are always important. You know, and really, you know, we provide those resident-specific consultations. We look at developing care plans. We assist with writing programs, protocol development, policies. We participate in committees. We work with staff to monitor appropriate purchasing and use of supplies. I attend a lot of case conferences. I assist with chart audits. I lead a lot of prevalence and incidence studies. I look at developing teaching aids, assist with product selection. We review stats and making recommendations to decrease number of issues, identify gaps in education, assist with development and implementation of prevention programming, and looking at needs assessment and staff and making recommendations. So there's a lot of different things that we do in long-term care. So if we break it down, our roles, it's assessment and management, education and training, consultation, collaboration with the SWANs. It's a team approach. So we collaborate together. We make sure that we're working together. So while the SWANs will assist with routine care and patient education, we'll work with it and provide that oversight. But my SWANs, I call them my SWANs, but we're a collaborative team. They really provide a lot of that education on the ground, a lot of that one-on-one education. And some of the SWANs are doing more formal education where they're actually doing presentations and educational seminars to the other workers as well. The SWANs really help us to have that continuity of care. It's a true partnership. We look at research and advocacy. So SWANs are so great at preventative care, right? When I have SWANs involved, my consults go down. That's great. But the consults I get are always really complex, right? They're complicated, they're complex, and we work together as a team. And this is what we want to see happen, right? We want the consults I receive to be appropriate, and they should be the unstable and the complex. I used to see so many consultations for stage 1, 2 pressure injuries, skin tears, IAD. I'm not seeing those anymore because when I have a SWAN involved, because they're managing them. They're preventing them, and they're preventing them from becoming more complex. So the SWANs, they support the NSWOCs in developing and implementing care plans. SWANs educate patients, family, and healthcare teams on best practices, and they collaborate with the NSWOCs, right? It's really a partnership, and we collaborate together. So this is, if you want to read a little bit more, this is an article that Corey Hershap, now Dr. Hershap, for those of you who don't know, Corey recently received his PhD. Well, he will be formally receiving it, but he passed his dissertation. We did write an article meeting the needs of long-term care residents with wound, ostomy, incontinence issues, a sector in crisis, and this can be found in the Journal of Wound, Ostomy, Incontinence Nursing. So I think I've given you a bit of an overview of the ideal situation and some snippets about the reality, but the big reality is we don't have enough NSWOCs or SWANs working in long-term care in Ontario. The majority of facilities do not have access to an NSWOC and do not have SWANs. As well, many of our SWANs do not have designated roles as SWANs in long-term care. So they're working as generalist nurses, and they're expected to do the SWAN role on top rather than be a designated SWAN role. In some cases, they do have it, but the majority do not. So they're in a sense being set up for failure right away because they don't have the position, nor do they have the respect, and they're not given the opportunity to work to their full scope of practice. So this is the reality we're dealing with. The other issue is that when we have these mass dumps of education but no mentorship, we don't see sustainable changes and improvement in long-term care. And the amount of money that has been wasted in Ontario on these mass education programs, either industry-driven, and this is by no means to diminish what industry does for us, because they're providing education when nobody else will. When there's no funding, industry comes in, and any education is better than no education, and it's always evidence-based. So this is by no means to put down our industry partners or to put down the program, our foundational program that we have, or any other individual associations that have foundational programs. These programs are needed, very much so, but we need to have the mentorship in place in order for the learning to be sustainable. So thank you, merci, Megwich. That is the end of my talk for today. So open to any questions. I know I kind of sped through it. I wasn't sure how long I was supposed to have, but That's long-term care in a nutshell, people.
That was great, Dr. LeBlanc. And we do have actually a comment and I think a potential question here. It says, a common complaint from NSWOC and residents, LTC homes do not want to acquire recommended products. Would we have to advocate for contacting the Ministry of Health if the LTC home is not willing to acquire or provide suitable alternatives?
So here's the problem. It's not normally that the homes don't want to acquire the products, it's that they don't have the money. So here's a primary example. I want to do negative pressure wound therapy for a resident. Okay, they have a lot of times we inherit these wounds, not always, but we inherit a lot of wounds from acute care. So just not that long ago, I inherited this massive pressure injury. And one of the problems was there was a lot of discharge. We had to change dressings multiple times a day. If you were in acute care, first thing you would do is slap a vac on them, right? First thing you would do. Well, we sat down with the director of care and the administrator, and we laid it out. This is why I want this product. We all know how expensive it is to put negative pressure wound therapy on someone. Matter of fact, they would have really benefited from negative wound pressure with installations. And so we mapped it all out. We figured the cost of it. And the director of care looked at me and said, I would love to be able to provide this for you. You just need to know that our budget is so tight that if I provide you with this, I have to lay off a practical nurse or 2 PSWs for the duration while you have that product in place in order for us to be able to afford it. So if we run to the ministry with this, it's not going to change anything because unless the ministry is going to give them more money. Now, sometimes what we'll do is we'll complete the high intensity needs fund, and I will write pages and pages of pleading a case. Sometimes they'll cover it even if the wound is healable. But, you know, it's so complex because their budgets are so tight. That's the reality that when you work in acute care or home care that you're not faced with. In long-term care, their budgets are so tight. And we have the other complex that we have for-profit homes and we have not-for-profit homes. So that's also an issue as well.
Thank you for that comprehensive response. I do not see any other questions in the Q&A as well as comments in the chat, but there were a lot of clapping hands earlier and some hearts when you were presenting. So this is very, I find for me personally, such an eye-opener. I never have known that about the numbers, but I know that there is such a significant lack of NSWOCs and SWANs in LTC, but not to the point that it's like 69 NSWOCs only working LTC in Canada. So I really value the information that you have provided, and thanks for providing the information about the important role of NSWOC and SWANs. And I like the fact that you highlight mentorship, because there are times that we like to educate staff, but there is, as what you mentioned, there's lack of sustainability. And if we want to make sure that we sustain the practices and the better outcomes of patients are achieved, then we got to have to make sure that we have people that are experts on that role, that are solely focused on doing the role that they're supposed to. So thank you for that, Dr. LeBlanc.
Well, thank you so much for inviting me to speak with everybody today. I encourage all of you to think about working in long-term care. I'm a little bit biased, but I love my residents. I love working in long-term care. I love the population. I am spoiled. I do work because of other areas I work. I get to work with patients across the spectrum of care, but I'll take a 90-year-old with Alzheimer's over a crying 2-year-old who's spitting at me and kicking me any day of the week. So thank you all so much for sticking in there at the end of the day and attending. And Joshua, thanks so much for organizing such a great Ontario Education Day.
Thanks, Dr. LeBlanc. It's something I can give back to, of course, NSWOC Canada. Thank you. And thanks for your time. Okay, everyone, we are now down to our very last component of the day, and that is to provide you some updates from NSWOC Canada. So bear with me as I share my screen here. Okay, Troy, can you see my screen?
Yeah, it looks great.
Okay, awesome. Thank you. So now for some exciting update on current and future initiatives from NSWOC Canada. We mainly have two main objectives that we would like to accomplish this afternoon. One is, of course, to provide you an update on the current initiatives and its progress, and also to demonstrate the transparency of the NSWOCC Canada initiatives. So this slide just highlights how the flow of funding is facilitated to support ongoing operational needs and initiatives of NSWOCC Canada members. It is really important for us to highlight that we have a robust internal control process that reviews and approves funding or money that moves across the organization. And I'm very happy to announce to you that our annual financial audit was deemed to be successful. So thanks to the people that have gone beyond and above and beyond to making this a success. Last Monday, November 18, 2024, the Canadian Pressure Injury Advisory Panel, which is the official interest group of NSWOCC Canada, in partnership with the University Health Network and NSWOCC Canada, held its first ever Pressure Injury Summit. Now, the hybrid event was indeed a success because we had about 300 attendees of various stakeholders, whereby we have 104 in person and also 196 virtual, representation from clinicians, healthcare leaders, decision makers, and persons with lived experience. The event plays a pivotal role as CPIAP collaborates with various stakeholders in advocating for meaningful change in pressure injury prevention and management across Canada. We had a great set of speakers, as what is highlighted here on the screen. They identified key gaps in our system, from the need for a nationwide framework and policies, the need for standardization of practices, a better process for PI injury data collection, repository review and analysis, and a need for seamless transition in care where pressure injury prevention and management is well supported. We also had an opportunity to hear from a person with lived experience who shared her own experience living with a pressure injury, which was a very impactful moment for the attendees who saw her resilience through her journey. Overall, the event generated a lot of interest for collective action and partnerships towards the CPIAP initiatives. So a lot of work that will go through this particular working group, our panel in the new year. Now, just a bit about background about the key strategic priorities within CPIAP. As you can see on the slide here, there are four main strategic priorities, mainly making pressure injury a national priority, supporting standardization, leading advocacy and policy change, and of course, supporting knowledge translation or mobilization. Currently, working groups exist within each of the strategic priorities, and I would like to extend the invitation to any of the NSWOCs and SWANs online, and of course, any NSWOCs and SWAN members who may be interested in joining in any of the working groups, particularly if pressure injury prevention and management is your passion, which it should be. Now, to know more about CPIAP, please visit www.cpiap.com. As what was mentioned by Tarek earlier, our 44th National Conference is taking place on May 21st to 25, 2025 in the beautiful city of Montreal, Quebec. Our theme will be on ideas, inclusivity, diversity, equity, accessibility in wound, ostomy, and continence. Our venue will be in the Hotel Bonaventure, Montreal, which is centrally located in the city. So you can be close to the shopping district, you can be close to entertainment, and even the Old Montreal. It's the hub of everything. And registration and hotel booking opens mid-December of 2024. Now, for us who have attended prior NSWOCC conferences, you may be aware that our networking lip sync event has always been a blast and a popular demand during this conference. So our theme next year is about disco nights. So get your groove on and dance the night away as our DJ take us on through our lip sync battle. So hoping to see a lot of our NSWOC and SWANs online today to be joining that event. Fast forward 2026, a very exciting and historic collaboration is within our midst with the WCET and NSWOCC Joint Congress. The Congress will take place in the picturesque Vancouver, British Columbia. The joint WCET and NSWOCC Congress offers a unique opportunity for nurses and industry partners from across the globe to come together, learn from one another, and engage with WCET and NSWOCC and their partners. The theme of the Congress is In It Together, Moving Mountains to Create a World of Better Wound and Ostomy and Continence Care. There will be a call for abstract submission in the middle of 2025, so we will keep you posted and up to date when this opens. So as what Tarek has mentioned, it's always a great opportunity for us to really engage in research, to see new innovations and see how our practice can influence the future of our recommendations and guidelines for practices that can be usable for other of our colleagues. So please, if you have something down the pipeline, this is an opportunity for you to send those abstracts in. Being a registered charity, NSWOCC Canada supports patient initiatives of other registered charity organizations such as Ostomy Canada Society, where recently we were a gold sponsor for their Step Up for Ostomy event. And for transparency, we also have donated about 10% of our earnings obtained from the swag and shirts that we collected to support a camper to attend the Ostomy Youth Camp. Now, we've been hearing a lot about advocacy throughout the day from our NSWOCs and SWANs representation. More about the advocacy for NSWOC Canada. NSWOC spearheaded the development of a new model of reimbursement for ostomy supplies in New Brunswick. This involves several meetings with the ministry, and currently an economic analysis is also being explored in collaboration with Coloplast to support the new model of care. So NSWOC Canada will continue to pursue this initiative and ensure to see this through. Further advocacy and our first talk from this morning from Joel and Kathy, we have learned that NSWOC Canada has advocated to have a specialized process to enable patients with a Kock pouch to access Medena catheters. So again, as what Kathy and Joel has mentioned, if you need further information, including PowerPoint, webinar, and sample forms on how to complete the forms to guide you through the process, please contact us at office@nswoc.ca. And thanks again to Joel and Kathy for spearheading this process to ensure that our specialized population receives the appropriate equipment that is safe and that will meet their unique needs as they go through with their day-to-day lives. So earlier this summer, the Ontario Wound and Ostomy Continence Summit was held. Now, the summit raised awareness on the pressing need for better access to specialized care, the economic burden of living with an ostomy, and highlighted several initiatives aimed at supporting the wound, ostomy, and continence needs of Ontarians. It also provided a platform for NSWOCs, healthcare leaders, and various stakeholders to network, reflect, and potentially collaborate on the identified needs. Now, the impact of this summit resulted in 3 follow-up meetings with the Ontario Minister of Health and Long-Term Care, where it looked at expanding the NSWOC and SWANs in the 620 LTC facilities across Ontario. As what Dr. LeBlanc has mentioned, this is a massive gap that needs to be filled, and that will then be part of this summit proceedings and meetings to ensure that these gaps for specialized services in the sector of healthcare is fulfilled and filled. So we are currently waiting for the final decision for this plan and stay put for further updates. So exciting news, fingers crossed, and we're in it to make this happen. Now, another exciting news is our NSWOCC Advanced peer-reviewed journal is being rebranded and relaunched in March of 2025 with a new name and a more scientific look. I am so excited for everyone to see its sophisticated look because I got a chance to get a glimpse of it. So I cannot wait for you to actually have a look at this new facelift of our NSWOCC Advanced Peer Review Journal that will be launched next year. Our Wound Ostomy Continence Institute continues to expand its comprehensive academic programs, and recently the Institute has added courses on 2S LGBTQIA+, paramedics, practice enrichment series, and the PSW and Caregiver Skin Health Program. Now, in honor of World Pressure Injury Prevention Day that was held last week, the WOC Institute has sponsored a significant number of personal support workers, healthcare assistants, and caregivers to take the PSW and Caregiver Skin Health Program. And if you know of any person interested in advancing professional development and may benefit from any of these courses, please kindly share this information to your colleagues. For more information about the programs offered by the WOC Institute, please visit the website at www.wocinstitute.ca/programs. Now, as what we have discussed earlier today, the sponsorship that we are receiving from our industry partners, from Hollister, Coloplast, as well as Ergo Medical, will go through the harms reduction project. So in May of 2025, a new set of best practice recommendation on harm reduction in wounds will be launched. And I do look forward to seeing how this much needed BPR can influence our practices. So more to come as we get to see this unfold. Now, in terms of projects that are down the pipeline as the new year comes in, a new best practice recommendation will dawn among us at the beginning of 2025, and that is around the pediatric ostomy best practices. Now, this project will be led by our pediatric community of practice. It is currently an established community of practice, but if there are any NSWOCs and SWANs who have expertise and interest in this particular field, please reach out to us and let us know, and we can see how you can collaborate with this very exciting new best practice recommendations. An exciting new project is also around wound packing and sinus and tunnel care, which will begin in January of 2025. This will be led by Dr. Kevin Wu and Mary Hill, and they are currently on the lookout for experts in this area to participate in a national consensus statement and the development of a clinical decision aid tool. So we are also, if you are interested in working together with Dr. Wu and Mary Hill, please send your interest in at office@nswoc.ca. And also we are open to seeking funding to support this particular project. Now, Dr. Wu did kind of give you a glimpse, but this is a work that's so close and dear to me, as this new project is related to moisture-associated dermatitis, which I will be co-leading with Dr. Kevin Wu. It's basically the Canadian Moisture-Associated Skin Damage Tool, or CAN-MNASD. As what he has shown you earlier in his presentation, we have developed a tool that monitors skin changes, improvement or deterioration in moisture-related dermatitis lesions as influenced by various assessment parameters related to skin changes, symptoms, lesion, and presence of secondary infection. So we will also be seeking for experts in this area to participate in further refining the tool and validating the use of the tool in clinical practice. So very excited about that. So more about the CAN-MESD tool will be presented in next year's NSWOCC Canada conference. So again, reach out to us if this is of interest to you. In February of 2025, a project revolving the review and revision of the National Standards of Practice for NSWOCs will be launched. Now, funding will be provided by NSWOC, and currently we are looking for volunteers for this important project. And there's going to be a person that will be appointed to be leading this important initiative, and it will be exciting to see how the look of the new Standards of Practice for NSWOCs will be once it's been reviewed and revised. Now, other important initiatives include the webinar and presentation on the Canadian BPR and Malignant continuous wounds will now be available in French language, and thanks to our colleagues for making this possible. The consensus document on venous ulcer management has also received NSWOCC Canada endorsement and will be made available for you on the website. Now, the harm reduction wound ostomy incontinence toolkit remains in progress, and more updates to come once the toolkit has been completed. Now, I believe it is great to meet virtually as what we are doing right now, as this bridges our distances from one another. But however, I find that there is something different when you get to meet others in person. So personally, as the Ontario Regional Director, I am looking at partnering with NSWOCs and SWANs and industry to host about 3 to 4 in-person events in 2025 for us to really get to know each other and network with each other and see how we can collaborate. I'm hoping to host it where a lot of our members are centrally situated, whether that would be in the north, east, west, or southern part of Ontario. So please let us know if you are interested to partner and collaborate and open to suggestions and ideas to entice our members. And we will also have a component for updates and, of course, continuous learning and education. So let's work on this together. And the last update I have is in terms of communities of practice. So further to the various initiatives, projects, and working groups that we have highlighted this afternoon, if you happen to know of any opportunities to engage our NSWOCs and SWANs, or if you are interested in forming a community of practice related to wound, ostomy, and incontinence, please let us know to see how we can engage our members and facilitate this process together. So again, if you are working currently in a community practice and you're thinking that you want to involve other members or you don't know how to facilitate that process, please reach out to us and we are more than happy to support this process with you. I'm going to stop sharing my slide here for a moment just to see if we have any questions from the chat at this time. Nope, no questions here. Share it again. Okay, so we are now at the very end of our day today. It has been such an exciting, invigorating, inspiring, and very eye-opening day. And what a day just came by so quickly. So at this time, I would like to really take a few moments to extend my gratitude to our esteemed speakers for sharing their valuable time and expertise and experiences with us. So thanks to Kathy Harley, Joel and Goldenberg, Aaron Meager, Deborah Johnston, Jason Lau, Rosemary Hill, Terry Kalam, Carol McAnuff, Dr. Kevin Wu, and Dr. Kimberly LeBlanc. Once again, thank you to our sponsors for today's education event, to Coloplast, Hollister, and Ergo Medical for partnering and sponsoring our event today, for making it possible, and for sponsoring our harms reduction project. A huge and special thanks to both Kathy and Troy. Planning this event and behind the scenes that goes with it is just unreal. So thank you for your unending support and your tireless support for making this day possible. And a huge thanks to every member of our NSWOCC Canada, my SWAN and NSWOCC family for your valuable contributions to the lives of our specialized population and for always representing our organization. Always remember, we value each and every member of the NSWOCC Canada. And thank you to all our attendees and for staying all this time. Please note that all attendees and registrants all attendees of today's event will receive a certificate of attendance and continuous learning hours that can be put towards your CNA renewal, especially for my fellow NSWOCs. Please don't forget to email office@nswoc.ca if you have any feedback, interest, recommendations, or questions from any of our content from today's Education Day. Again, this is Joshua Morolero, your Ontario NSWOC Regional Director, wishing each and every one of you a pleasant Friday afternoon and advance happy holidays.